progressive symmetrical weakness of lower limb and myalgia for 3 years. He was having difficulty in rising from sitting position and climbing stairs. He also had progressive shortness of breath and dry cough for last 1 year. Family history: his mother, his elder sister and younger sister also had the similar presentation, and all of them died at the age of 62, 54 and 45 years respectively. On general and systemic examination, there was everything unremarkable except skin examination showed red scaly lesion over metacarpophalangeal and proximal interphalangeal joints and reddish brown discoloration around eyelids. In inspiratory capillations in bilateral infraxillary and infrascapular region, which increased on leaning forward, and power in the bilateral lower limb was 3 by 5. Investigations and imaging: routine investigations were within normal limit. CPK and CRP was raised. Anti-MI2 antibody was positive, but anti-Jo1 antibody was negative. RA factor, anti-CCP antibody and ANA was negative. Then myositis profile was done, which showed anti-PL7, PL12 and anti-SRP antibody was positive, which confirmed the diagnosis of dermatomyositis. Chest X-ray PA view showed bilateral reticular opacities involving all the lung zones. HRCT showed bilateral symmetrical fine reticular opacities, honeycombing, traction bronchiectasis with lower lobe predominance, suggestive of UIP pattern. So diagnosis: this is a case of familial interstitial pneumonia associated with dermatomyositis. Treatment: now the patient is maintaining on nintedanib 150 mg BD, mycophenolate mofetil 500 mg BD, and nebulization with Foracort 0.5 mg BD. So in conclusion, incidence of familial occurrence in IPF is around 25%, and incidence of ILD in inflammatory myopathy is 5 to 30%. Previously UIP pattern, but now NSIP pattern is more common. It is also more common in females. Male is to female ratio is 3:1. Anti-MI2 antibody is more common is dermatomyositis, but anti-Jo1 antibody is more common is polymyositis. Prevalence of anti-PL7, anti-PL2 and SRP antibodies are 6%, 1% and 5% respectively. Thank you.
So Dr. Soumya, what was special in your case?
So especially in our case that there is in two successive generation, the 4 members of the same family was infected with ILD, and all of them have features of dermatomyositis. So this is a quite a rare case.
Okay, so you want to say that it is familial interstitial pneumonia and dermatomyositis. So all the rest of the 3 family members, they were diagnosed with this condition, because you have told that they died at respective ages. No? They had similar complaints, but
same presentation. The HRCT showed that UIP pattern, but though the serological markers were not done in that patients. But in my patient, the serological marker was done.
No, the rest of the 3 patients, rest of their family members, I'm talking about your patient and their family members. So their family members were diagnosed patients of ILD with dermatomyositis, or they were just having the similar presentation.
Same features, and HRCT had the same features, but not confirmed.
But diagnosis. The rest of the 3 family members were not investigated, na?
Not investigated. Matlab, serological markers was not done. HRCT and clinical features were there.
HRCT of rest of the 3 family members was done?
Yes.
So it was suggestive of what?
Suggestive of UIP pattern.
So were they on any treatment? Rest of the 3 family members I'm talking about.
Only one had under treatment. Rest of them had the similar features, but they did not get any treatment or get the treatment in the later stage of life, which did not show any improvement in the course of the disease.
So that they were diagnosed with ILD, but they were not having the serological markers.
Yes, actually diagnosed with ILD, but later we found out that they also had the similar skin features, similar.
And what was the cause of their death? All 3 patients.
What was the
cause of death?
So the progressive shortness of breath.
All 3 of them.
All 3, yes. Respiratory distress was the cause of death.
How long the present patient is getting medicines?
So my patient is taking medicine for last 5 years.
Last 5 years?
Yes, sir.
And what are the changes in HRCT or other markers?
Sir, actually, sir, the HRCT, repeat HRCT was done, but I have not included it. But patient is actually having a shortness of breath, gradual shortness of breath was there. But patient is now Despite of 5 years survival, he is maintaining quite well.
The symptomatic you are
Yes,
telling.
symptomatically improved, sir.
But
There is no
other-
deterioration, no
Other,
deterioration.
other parameters, HRCT or other parameters.
The Sir, actually, patient cannot walk, so she he can't come to our OPD, so HRCT cannot be done. So his relative comes to OPD and
So the patient is on nintedanib since last 5 years.
yes, sir.
Could the patient afford nintedanib some 3-4 years back? Because it was quite costly at that time.
Sir,
It is so
actually,
recently because of that COVID that it has come at a quite lesser rate. But earlier it was some 80,000 a month therapy.
Nintedanib is not,
That
it was
is
not.
very,
actually,
you
madam,
know.
they belong to a very rich family. So the serological
So, and
profile,
what was the pulmonary function testing of this patient at
ma'am, that was
baseline?
restrictive in restrictive pattern.
Could you show me that? Is it available with you? Because in such kind of patients, you simply can't follow them clinically.
Yes,
Na?
clinical.
You have to have some parameters on which you assess the patient after a period of time. And if the patient is already on treatment for last 5 years,
Ma'am, actually, his shortness of breath or lung function is like not deteriorated, but his progressive muscle weakness is progressively deteriorating. So even he cannot walk right now.
and what was the indication of nintedanib in this patient? Like what are the indications of antifibrotics in patients with the underlying dermatomyositis? In simpler terms.
Ma'am, there was in HRCT there was the finding was um, progressive.
This is the baseline HRCT 5 years back.
Ma'am, it was done 2 to 3 years back.
So what is the
So
like
5 years back HRCT I did not get. Actually, when the diagnosis was started, the HRCT I did not get. It was done around 2 years ago. So I got that.
okay, and the treatment was started 5 years back.
Around 4 to 5 years back around.
4 to 5 years back. So that time also HRCT must have been done. Or at least there must be some records.
Serial
Yes,
HRCTs
that is
and
very important, na?
pulmonary function.
They're
That
very,
too
very
can be
important.
done.
Okay, ma'am.
Because otherwise, how will you say that, like, if anybody has got this HRCT done 2 years back, obviously that means that he must be trying to follow up this patient, no? Because the patient was already on treatment for last 5 years. So on records, it should
So
be
due to
that
muscle
what-
weakness, the patient cannot come to upper OPD. So how can I do? What can you do HRCT?
No, the baseline HRCT I'm talking about, no?
Baseline HRCT.
Somebody who has done this HRCT 2 years back, he must have done it to compare it with the previous one, no? Because he is not initiating the patient on treatment.
Actually,
The patient is already on treatment since 5 years. So why will any clinician go for a HRCT after 2 to 3 years of treatment? Obviously, that is to follow that patient. Otherwise, so there is no fun of getting an HRCT if the patient can't come or if the patient is clinically well off.
Yes, ma'am.
Okay.
Thank you.
Yes, yes, sure, sir.
Sir, so answer the first question is the family members died because of they actually there was no proper diagnosis and disease was already in the advanced stage. So they died in early stages. So there was no comorbidities, no hypertension or diabetes mellitus, and no other systemic diseases, and they were like businessmen in profession. So no history of exposures are there.
You see, sir is very right in asking this question. This is what I also asked. Now that you have 3 family members who died because of some disease. Maybe it is dermatomyositis with ILD. And if you are saying that the family is well off, and if somebody has got a HRCT done, all those 3 family members, obviously then his serological markers and rest of things would have been done. Because if the patient is diagnosed with a ILD, any clinician who sees ILD on CT, then definitely that patient will be subjected to rest of the things before he is started on any treatment, na? And what is the cause of death in those 3 patients?
Yes. Yes, yes, sir. There is no features of such history. Yes. Yes, sir. Uh, yes, yes, sir.
Now, in literature, have you find any such disease in the literature?
Yes,
What
sir.
are
I
the
found.
incidents?
These values were taken from the literature. They said the familial occurrence is 25% and incidence of ILD in primary puberty is 5 to 30%. These values are taken from literature. Literature.
On literature, sir.
Yes.
So see, familiar occurrence is around 25%.
Yes, ma'am.
So three family members of that same patient having, and then tracking down, going down the
Yes, sir.
family
Actually,
tree. Sir's point is very important, that you should look it
yes,
in
sir.
the.
Ma'am, we are tracking down the family members.
Because his children are obviously available. The members which have died, we can't do anything about. We can just juggle through the records. But the presentation, the
Yes,
CTs
ma'am.
and
There is no
X-rays,
features.
none in his children.
No, 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 no.
At this point, there are no other.
No other family member are involved except for these four people. So actually, there was.
Difficult.
So actually, the skin features are classical of dermatomyositis. The rash, the Gottron's papular rash. So if we take in consider like scleroderma, there was no history of malar rash or photosensitivity or like other features. Or in rheumatoid, if we consider.
Thank you.
Thank you very much.
The next one is Promosi Poddar. Yes. Thank you.
Hello, good morning, everybody. I'm Dr. Pramoshi Poddar. So my topic is concurrent ABP and farmer's lung in a 35. Yeah. My topic is concurrent ABPA and farmer's lung in a 35-year-old male with previous pulmonary tuberculosis. I am Dr. Pramoshi Poddar, first year PGT. From IQ City Medical College and Hospital, Durgapur. So introduction is ABPA occur as a result of hypersensitivity reaction to germinating fungal spores of Aspergillus fumigatus in the airway wall of asthma or cystic fibrosis patient. Farmer lung in an allergic disease usually caused by breathing in the dust from moldy hay. Farmer's lung is a type of hypersensitivity pneumonitis which is also known as an extensive allergic alveolitis. It is caused due to result of inhalation exposure of thermophilic actinomyces species, um, M. amphani, and occasionally exposure to various Aspergillus species. ABPA was found in 83% of population of outpatient with severe asthma, 50% of patient given diagnosis of pulmonary eosinophilia have ABPA. So case report is chief complaint 35-year-old male presented with shortness of breath along with cough and expectoration since last 2 months with one episode of hemoptysis. Cough was increasing during night time with no aggravating or relieving factor and expectoration was watery in nature. He was known case of bronchial asthma since last 5 years and had history of pulmonary tuberculosis 9 month back and completed ATT for 6 months. By occupation, he is a farmer and on examination, all were normal. On chest auscultation, bilateral rhonchi were present all over the chest. On investigation, PFT was moderate restrictive pattern with severe obstructive pattern. with reversibility ever diseases. Serum IgE was very high along with absolute eosinophilic count. We did a panel test of aspergillus antibiotic panel and farmer's lung panel. On that, we can see that aspergillus IgE was very high, along with farmer's lung, where also panel test was positive. Along with HSCT shows bilateral bronchiectasis, central bronchiectasis, along with finger in glove sign and tram track sign. So my conclusion is this is a case of allergic bronchopulmonary aspergillosis with farmer's lung with a past history of old pulmonary tuberculosis. On treatment, we gave the patient itraconazole, prednisolone, and formoterol MDI budesonide. So my conclusion and discussion is that ABPA complicate the course of asthma and cystic fibrosis. Along with farmer lung is very common in India but rarely get diagnosed. Most patients of presented only with acute exacerbation of COPD and bronchial asthma. And as this CT, thorax and serological tests are very costly in lower socio-economic group of population. So we can create an awareness and resources for the diagnosis. Thank you.
So, Dr. Pramoshi, what criteria did you follow for diagnosing this patient as a patient of ABPA?
First, ma'am, he was a known case of bronchial asthma. So we know that due to chronic bronchial asthma, we can suspect that ABPA can happen. And along with he was an occupation, he was a farmer. So we did a both panel testing. And on that panel testing, aspergillosis Ig came very high, along with farmer's lungs also presented. So we concluded that HRCT we should be doing that, and by that we see that bilateral central bronchitis was present. So mostly it's an concurrent ABPA with farmer's
No,
lung.
could you tell me the criteria which you used for the diagnosis of ABPA in this patient?
So we did a skin test along with we see the precipitants.
What is the name of that criteria?
Ma'am, ischemic criteria.
ISHAM you used.
Ischemia.
And what was the treatment?
Ma'am, we did we gave the patient on itraconazole.
Why the patient was started on itraconazole?
Ma'am,
What is the indication of itraconazole in a patient of ABPA?
ma'am, it's mechanism of action that it can block
Indication of itraconazole in a patient of ABPA.
Ma'am, it's an antifungal, so as in we can see that is aspergillus
So in
positive.
any patient of bronchial asthma diagnosed with ABPA, do you start itraconazole?
There are so many antigens.
Mostly we start itraconazole along with steroids.
So what is the dose of steroids in patients of ABPA?
We can control the inflammation. We can control the inflammation.
What are the dose of steroids in patients
Dose.
of ABPA?
Ma'am, we giving the patient 40 mg OD for 6 to 8 weeks.
Then how do you taper it?
Taper it by 20 mg.
Now regarding farmer's lung,
Yes, sir.
we do not usually do such a panels for diagnosis. How do you do it?
So generally he was by occupation he was farmer's lung and he was having a chronic cough. So we suspected that it might can happen a farmer's lung also. So we did a panel testing.
Only that he is a farmer.
No, along with his Ig was level also very high. So serum Ig was very high along with eosinophilia. So we did.
That could be simple. That could be in ABPA also. First of all,
ABPA
you will
only.
suspect
That-
only ABPA because total
Only
Ig
ABPA
is
and
high.
stop it.
Yeah,
And
that's why, ma'am, we did an HRCT and it shows ki bilateral central bronchitis.
No, that is for
that is all for ABPA. Sir is asking that what was the indication of getting a farmer's lung panel in this patient? Like why did you suspect farmer's lung in this patient?
So he did. Huh. So actually, he had an one. Hmm. So we are following the patient and he is totally fine now, and he's not having now any cough or any hemoptysis problem. So
that you were the patient was a known case of bronchial asthma. Okay, the patient's total IgE was high, his absolute eosinophil count, and there was peripheral blood eosinophilia, है ना? So these things think of ABPA. So the question is that in any and every patient of ABPA, say who is a farmer, you don't go for a farmer's lung profile, है ना? Panel. So the question what sir is asking and sir is asking is
Why?
that what was the indication of getting a farmer's lung panel in this patient? What was his clinical history? What was his examination? What was his X-ray or CT findings that you thought that this could be farmer's lung along with? ठीक है, your farmer's lung panel came out to be positive, that is okay. Now ultimately you diagnose the patient as ABPA plus farmer's lung, that is also fine. But what was the thing which told your mind that farmer's lung panel should be done? This is what is his question.
So actually the first point is that he is a farmer. So in farmer, when we find a chronic cough along with allergic profile, we generally with eosinophilia we did a farmer's lung panel testing.
Yes.
अगर कोई भी फार्मर होगा, है ना, ब्रोंकियल एस्मा होगा, प्लस एलर्जिक प्रोफाइल होगा, प्लस व्हाट डू यू कॉल आईजी रेज होगा, उसमें वो केबीपीएस होती है ना, पहले वो आपने सोचा
Stop there.
stop there, है ना, and then why farmers and
Why farm? Complicating. You should search for.
So that in lower socio-economic group, we can everybody cannot do an HRCT nowadays, and everybody cannot do a panel testing. So if we can reduce the cost and its effectiveness, so we can do an awareness.
If you want to have a study with it, study with the why.
ठीक है, thank you.
Thank you.
Now invite Dr. Vikrant Solanki.
A very good morning, respected faculty members. I'm Vikrant Solanki, presenting a poster on unusual etiology for breathlessness, Sjogren syndrome. Introduction. Sjogren syndrome is autoimmune disease. It is characterized by lymphocytic infiltration of exocrine gland, resulting in xerostomia and keratoconjunctivitis sicca. The disease may be primary or secondary to other diseases like rheumatoid arthritis, SLE, systemic sclerosis, polymyositis, and biliary cirrhosis. The clinical consequence ranging from difficulty in speaking, eating, oral candidiasis, rampant caries to celluloidinitis due to xerostomia, diminution of secretion of tear, destruction in corneal and bulbar conjunctiva epithelium with ocular complaints of itching and dryness. Interstitial lung disease may be life-threatening complication of primary Sjogren syndrome and has a poor prognosis in terms of survival and quality of life. We present a case of 56-year female with diagnosis of Sjogren syndrome and related ILD. A case report. 56-year-old female patient presented to us with gradually progressive multiple joint pain without significant morning stiffness, low-grade intermittent fever, exertional dyspnea, and generalized weakness for past 4 years. Patient revealed difficulty in swallowing, drawing mouth, and gritty sensation in eyes and proximal muscle weakness for the same duration. Patient also lost about 15 kg of weight during this illness. On examination, grade 4 clubbing was seen, swelling and tenderness at proximal metacarpal phalangeal and interphalangeal joints. Uh, Patient also, on examination, hepatosplenomegaly was also observed, and bilateral basal and inspiratory fine crepitation was also heard. On examination, her biomarkers were non-reactive, and X-ray shows cardiomegaly with bilateral reticular nodular pattern with craniocaudal gradient, and her HbA1c was 7.2, and ultrasound abdomen shows hepatosplenomegaly with blood rheumatoid factor was positive, and other autoantibodies like anti-SSA, anti-SSP, and anti-RO were positive, and SCL70 and ribonucleoprotein and dsDNA and JO1 were negative. Schimmer's test and unstimulated saliva secretions were normal. Rose Bengal test was positive, and parotid ultrasonography shows multiple hypoechoic areas, and pulmonary function test reveals restricted type, and CT shows interlobar fibrosis with interstitial thickening of lower zone of both hemithorax. Discussion. Primary Sjogren syndrome is a progressive systemic autoimmune disease primarily affecting female that is manifested by inflammatory lymphocytic infiltration of exocrine glands, lacrimal and cerebral lead to destruction of tissues. It is characterized by dry mouth and eyes, parotid swelling, profound fatigue, and widespread musculoskeletal pain and polyarthritis. The prevalence is estimated at 0.3 to 3%, and making it one of the most prevalent multisystem autoimmune disease after rheumatoid arthritis. Screening for pulmonary involvement in Sjogren syndrome remains a topic of debate. Conventional chest radiograph may delay early treatment due to the low sensitivity. Although pathology has higher sensitivity, it remains impractical to perform a screening test given the invasive sampling required. HRCT has been shown to be well associated with pathology, reflects a pathological finding in patients with rheumatoid arthritis and primary Sjogren syndrome. Recent study noted a significant improvement in FPC in patients treated with azathioprine-based regime when compared to untreated patient. Moreover, Saichi et al. Reported corticosteroid therapy combined with oral cyclophosphamide products, favorable response in majority of primary Sjogren syndrome with lung involvement. The conclusion is interstitial lung disease involvement in primary Sjogren syndrome is a common clinical occurrence. The clinical manifestation of non-specific and variable Raynaud's phenomena and lymphopenia may predict its onset. Primary Sjogren syndrome with advanced age, dry cough, dyspnea, and should be systematically evaluated for ILD involvement and managed according to their symptoms. Identification of risk factors and pathogenesis for primary Sjogren syndrome ILD is a complex, and it is necessary to clarify the potential of molecular and biological mechanism between these risk factors.
So what is special about your patient? Like what brought you to bring this patient on this platform?
Ma'am, as Sjogren syndrome is a rare, autoimmune disorder, uh, it is very highly that in clinical practice, most of the patients are missed, not diagnosed, and because the patient was experiencing dyspnea with for longer period of duration, dyspnea, fatigue, and weight loss with swelling of proximal limbs. The diagnosis, uh, it was difficult to diagnose because before coming to us, the patient have been visited to multiple local practitioners. There he was misdiagnosed as tuberculosis, was given ATT, and none of the treatment before improved the symptoms. So
Patient has taken ATT.
in past,
So do you have
for
chest
2 months,
X-rays
for
of
two
that time?
months,
Do you have chest X-rays of that time that the patient was
ma'am,
started on ATT?
this was the
Because on this X-ray, I
Enrollment.
doubt that the patient will be started on ATT by any clinician.
ma'am, I have, ma'am.
And why did the patient take ATT only for 2 months? Like he defaulted or the clinician stopped the
Ma'am,
ATT?
we stopped.
You stopped.
Yes,
Okay.
ma'am.
So I don't want to see the X-ray. Just tell me that whether his previous X-ray was suggestive of
Ma'am,
tuberculosis in
not
any way.
suggestive of, because the lesion was same.
Mhm.
Reticular nodular pattern was seen, but the local practitioner missed it. Because sir, the weight loss was present and intermittent fever, low grade intermittent fever was also present. Sir.
What ma'am was asking, why you are presenting this case?
Sir,
You know this case, it can be diagnosed, it has got treatment, then why you are presenting this case?
so the occurrence is very low now, so it is 0.023%. So, and it's more common in female. So because it is rare, because we have seen, sir, 3-4 cases.
One thing, you should make short,
Yes, sir. Sorry, sir, I didn't know it was my first time presenting, so
make it short.
sorry, sir.
You can get 7, 8, 9, 10 slides, but slides should,
Yes, sorry,
is
sir.
not looking good.
Sorry, sir. I didn't.
Sorry, thank you.
Thank you, sir. Thank you, ma'am. Yes, sir. Huh. Sir, patient presented to us 4 year back. Sir, uh, primary Sjogren's syndrome, sir, the breathlessness is unusual, sir. Sir, patient presented to us with as a sir, sir, sir. So the initial rheumatoid titer was less than 8, sir. Uh, the rheumatoid factor was positive in like so 2021.
No, it should be fast.
Sir, when patient presented to us, sir,
This,
sir, 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 cardiovascular. Yes, sir. Sir, 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 when sir came to us, we did Turico, in which she has moderate PAH. Sir, sir, cardiomegaly on the basis of X-ray, and sir, Turico was done. Ma'am, I have report, ma'am. Echo was normal with moderate pH.
So what could be the reason of moderate PA? What could be the reason of moderate PA?
Ma'am, cardiomegaly with restrictive lung disease.
Okay, thank you.
Thank you, ma'am. Thank you.
Dr. Ronak, is he present here? Absent. Devkonna. Devkonna De. It should be faster. Yeah, 4A.
5A, sorry, 5A.
5A, 5A.
Shall I begin?
Yes.
Yeah. Sure. Good morning, everyone. I'm Devkonna De. I'm a PhD scholar at Calcutta University, and my topic of presentation is non-smoker COPD similar to smoker COPD based on the oxidative damage? Now, we all know that COPD is induced by smoking, but of late, the non-smoker phenotype is emerging. And not only emerging, the numbers are getting high day by day. Even in our OPD, we are getting a very high number of non-smoker COPDs. Now, we know that COPD is caused by oxidative damage. The major pathophysiology of COPD is oxidative damage. But what happens in case of non-smoker COPD? The pathophysiology has not been explored. So when we looked into the literature, we found that clinicians were mostly focusing on the clinical difference between the non-smoker COPD and smoker COPD. But we could not find any paper which was focusing on the pathophysiology of non-smoker COPD. With this in mind, our main objective for this project was to find out the clinical difference, that is the spirometry based difference between the non-smoker COPD and smoker COPD, and then look into the oxidant and antioxidant status of non-smoker and smoker COPD. And then we would try to find an association between the clinical and the oxidative status. So in our OPD, we collected 60 patients, out of them 60 COPD patients, out of them 30 were smokers or ex-smokers and 30 were non-smokers. We also had 29 healthy subjects. Healthy means they had normal spirometry and normal chest X-ray. Out of them, 12 were smokers and 17 were non-smokers. So we have collected their serum, and with their serum, we have evaluated their total oxidant status and total antioxidant status using the REL assay kit. And the results we got, we have statistically analyzed them using GraphPad Preset. So this is our result. The pink bar over here shows the non-smoker COPD and the blue shows the smoker COPD. This is the spirometry data, and here you can see that non-smoker COPD, almost all the spirometry variables are higher in case of non-smoker COPD as compared to the smoker COPD, and this higher is significantly higher. So this means that non-smoker COPD have a better lung function as compared to the smoker COPD. Now coming to the oxidative damage. In this case, the blue bars represent the COPD and the green bars represent the healthy population. Here you can see in case of the total oxidant status, both the smoker COPD and non-smoker COPD have practically similar oxidant status. While in case of the both COPD, the oxidant status were higher than the healthy subjects. So this means that yes, COPD had a higher oxidative damage as compared to the healthy subjects, but there is practically no difference between the smoker COPD and non-smoker COPD. Now comes the interesting part. When we evaluated the total antioxidant status, we found the non-smoker COPD have a significantly lesser antioxidant level as compared to any other group. And the ratio of this two is known as oxidative stress index. And here also we see a similar result, that non-smoker COPD and non-smoker COPD have exactly similar levels of oxidative stress index as compared to the non-smoker COPD. But from the healthy, when we compare, the oxidative damage is quite high, but there is no difference between the smoker and non-smoker COPD. Then we moved on to the correlation, and here we found the correlation, the R value to be minus 0.35 and minus 0.42. This means a moderate correlation. So this means that as the lung function variables were going down, the oxidative damage was going high. And this is actually justified, because as the lung function was going down, there is more oxidative damage, and that is why the lung function was also getting affected. So with this, my conclusion is that non-smoker COPD have exactly similar pathophysiology based on the oxidative damage than smoker COPD, even after the fact that their lung function was better. So this means that non-smoker COPD is equally important. They should be given equal importance and treated seriously. Otherwise, they would follow the normal course of COPD curve, that is a rapid decline in their lung function. So with this, I conclude my first presentation. Thank you everyone.
So what was the reason of COPD in your non-smoker group?
Yeah, so I actually have included it. I have not presented it because of lack of time. So there are many reasons why a person may have a non-smoker COPD. They could be exposed to high level of pollution. They could be exposed to biomass fuel gas, which is very rampant in our villages. And then they could be exposed to passive smoking. Their husbands, mainly the females, are more prone to non-smokers. So their husbands may be a chain smoker. So they are experiencing passive smoking for a long period of time.
So could you tell me the distribution of your these 30 patients? Like how many of
Majority of them had a biomass fuel and passive smoking history, about 30 to 30% each, and rest were pollution and occupational hazard. And there were 2 to 3 patients who did not have any explanation, so we put them under maybe pollution exposure.
what was the age group of your population?
The age group of the population, both of them were 60. The mean age was 60 and the standard deviation for non-smoker was 5 and for the smoker it was 7. So there was no difference between the age group.
And what about your healthy controls?
Yeah, healthy control, the age group was slightly less. The reason I'll tell you, because
What was the mean age of your healthy
it
age
was
group?
about 45 and the standard deviation was 5. The reason is that as we were checking the patients, like patients of, not patients, the healthy subjects of higher than 60 years, they are basically not healthy. They might have a high blood pressure, they might have diabetes. So pure healthy we were not getting in a population above 60.
Because see, your age group or your healthy controls is very important.
I
See,
agree with that.
because if you're having your majority of your healthy population in the age group 45, and when you distribute these patients into two groups, you have said that these many were smokers and these many were non-smokers in your healthy population, है ना? So when you talk about smoking index or the number of pack years, obviously the patients, I think your 17 patients were smokers in the healthy group.
12 were smokers.
12 were
and
smokers,
17
yes.
were non-smokers.
So 12 were smokers. So your 12 were smokers, but their pack years will never match with the, as per their age, will probably never fall into that COPD group. So maybe these are your patients which in another 10 years, if they are heavy smokers, they may be turning up into a COPD group itself.
So the thing is, yeah, I agree with you. We know that COPD, the age group is from 40 onwards.
Yeah.
Yeah, so that is why our control was taken above 40, 45. And what happened is, when we tried to take healthy subjects in our OPD, like we were targeting the family members of our patients. What we found was that we screened about 80 patients and we found only this many patients who were actually healthy. We were finding some problem in them or the other.
No, so this is important now, because see, if when you're talking about passive smoking, so if you're screening the family members of patients who are smokers, so their family members are most likely to be exposed to passive smoking.
Right.
And then second important thing is that when you are taking smokers as your healthy population, so their oxidative levels cannot match with those of non-smokers, oxidative stress levels. So why did you not take all the healthy controls as non-smokers or without any of these exposures?
No, our
Because
healthy,
you could have taken that as an exclusion criteria, that
no,
the
our
patients.
healthy did not actually have any of these. The 30 that I have taken, they did not have any of these exposures. The non-smoker that I'm.
But they were there. 12 were smokers, no?
They were smokers. There were
Yes.
12 smokers. But
So
the
why
seven-
did you exclude? Why did you include smokers
Yeah, the
and
reason
you
is
did
that
not
I wanted to
include
see
these?
The difference between the healthy smokers and COPD smokers. The difference was important to me with what is happening in case of healthy smokers and COPD smokers.
So what was the pack years in your 12 healthy smokers?
The pack years, I think there was no significant difference between the COPD and the normal pack years. There was no difference. That
So
why I'm
it is very difficult. It is very difficult to
Because actually, when we have done a correlation with the pack years and say the different spirometry variables, we did not find any correlation.
because that could be the reason, because you are doing the correlation between the whole 30 group versus the 30 group. So when
I am
you
doing the correlation in different groups.
this is what I'm saying, na? So you had 29 healthy controls. So your number of pack years will be diluted because your 17 were non-smokers.
No, for that purpose, I'm taking only 12 because I don't have pack years for the non-smoker patients. If I take, that will be wrong.
So could you show me that correlation?
I don't have it here because the time limit was 4 minutes. I couldn't show all the results.
Because it is important.
Okay, thank you. Thank you. Carry on a second.
Second
I'll go to
presentation.
my second. So this is my second topic, childhood factors important for predicting COPD and asthma in adulthood. Now we know that there are several researches going on which is focusing on the adult lung diseases and their roots in childhood. When we look into the literature, we find that there are several papers which are actually focusing on the childhood risk factors of adult COPD and asthma. But when we try to find out what is happening in India, we do not find any paper. So from India, we do not know what is the childhood risk factor for adult COPD or asthma. So this is the objective for this study, to find out the childhood risk factors for adult COPD and asthma in Indian population and to differentiate COPD and asthma based on the questionnaire of childhood risk factor. So we had 486 patients from our OPD. Out of them, there were 333 COPD patients and 153 asthma patients. They were clinically diagnosed and spirometrically diagnosed as well by our pulmonologist. And then we filled a detailed questionnaire which had important questions about their childhood exposures, diseases and events. With all their answers, we have performed statistical analysis using R, metaboanalysis and graph in order to find out the main risk factors of childhood for adult lung disease. This is the glimpse of the questionnaire. There were about 33 questions that we have addressed. So coming to my result, out of the 33 questions, we found that there were 10 major risk factors. Why am I emphasizing on this 10? Because they were statistically significant. So these are the 10 risk factors for COPD and asthma. Now if I break them down, for asthma, the risk factors that we found were asthma history in childhood, eczema in childhood, recurrent purulent expectoration in childhood, recurrent antibiotic intake in childhood, recurrent sneezing and running nose in childhood, recurrent childhood hospitalization, recurrent wheezing and also recurrent emergency visits to the doctor. These were the main risk factors in case of the asthma patients. Now for COPD patients, apart from smoking, which is not related to childhood but it is related to the COPD risk factor, the major other risk factor for childhood was childhood tuberculosis. Now moving on to my second objective. With all the 33 answers, we have done a multivariate analysis using unsupervised modeling, firstly principal component analysis. And in this case, you can see that this red one are the asthma patients and green one are the COPD patients. So there is a bit of overlap here and this is justified because COPD and asthma are both obstructive lung disease. So they will have overlap risk factors. But in spite of that, you can see distinctly we can differentiate between COPD and asthma. Now moving on to the supervised modeling, which is known as PLSDA, partial least square discrimination analysis. And in this case, you can see there is a better division between the COPD and asthma. This means the questions that we were asking and the results when we were getting, with that we can clearly determine that whether a person might have COPD in future or an asthma in future. And this is a very good model because the R2Q2 value is about 0.5. And these are the factors which are basically causing the difference between the COPD and asthma. So with this, I can conclude that our questionnaire was able to find out the risk factors for COPD and asthma, the childhood risk factors mainly. And with this, when we know the childhood risk factors for COPD and asthma, we will be able to prevent them as well. So with this, I end my presentation. Thank you. Sure.
So how did you devise this questionnaire? Did you take it from some standard questionnaire,
This
or you?
questionnaire was actually prepared by my guide, Dr. Partha Bhattacharya, and he has validated it by sending it to his pulmonology pens, and they have validated it.
So this is a self-structured
This
questionnaire
is a self-structured question.
having 15 questions.
No, total 33 questions. Sorry, here you can.
You are showing the
find,
15 questions, no?
There are basically 33 questions.
So all are in yes and no?
Yeah, all are in yes and no, but there are some questions that were like how many times you had this sneezing and how many times you were being visited the doctor. So those questions were quantitative that we have not taken into analysis in this case. We have only taken into consideration on the yes no ones.
So you have taken the 15 questions in your final
Yes
analysis.
no ones, because those are quantitative questions. So when we take into the consideration, we have to do multiple regression equations to actually find out that how many times they are visiting doctor, and so they may have COPD, etc.
It's very difficult. It's very difficult to get all the information from
Absolutely, it's very difficult. So we actually had to spend more than 1 hour with each of the patients to actually find out the answers. You know, talk to them and then find the answers from them. It's very difficult.
Answer to say question like, do you have exposure to damp environment? So you have taken some time frame.
We had taken a time frame up to 8 years. And we
No, I'm talking about the time frame in a way like during the past 1 year or during past 4 weeks or during
This
past.
is because this is a childhood questionnaire, so we are only concerned of their exposure in their childhood, so up to 8 years. So we are.
So you have whom did you ask these questions? The parents?
As the patients as well
Patients,
as the family
as well as the
members.
parents.
Yeah, family members also come with them, so
That's-
they can answer sometimes.
That's good, yeah.
Okay, thank you.
Thank you.
Sayanti Pulmocon.
Sure.
Yes.
So we actually spend a lot of time with them, we talk to them and with their family members as well. So a patient is coming with their mother, so the mother is remembering that my son had TB. She is telling me that, okay, he had TB when he was 4 years old. In that way we come.
It's very difficult to get this.
Yeah. Right.
Most of the family members do not remember.
They can tell about the exposures and diseases. They can mainly tell about malnutrition. Yeah, so mother usually tells that, no, my son was very malnutrited when he was young. So we have to restructure the question. Okay, thank you, ma'am. We did not actually include that. We should have actually. We should have.
Yeah,
This is basically case control. Yeah. Yeah.
Thank you. Thank you, Devkanna. Sayanti, we have got 2. 3. 3. Hmm? 6 ABC.
Good morning, my respected faculties, delegates, and everyone present over here. Today I am going to present one of my work titled Evaluation of Spirometric Parameters for Identification of Concomitant Obstruction in Patients who are already suffering with diffuse parenchyma lung diseases. So here goes the background of the study, which is based on, as we all know from the literature, that obstructive airway disease and restrictive airway disease are often coexisting in patients. So thus it becomes important to identify the situation to offer the best possible treatment. Keeping this in mind, we had set the objective to compare the different spirometric parameters in assessing an accompanying obstruction in patients who are already having restrictive airway defect. Thus, we had selected DPLD patients who are reporting in our outpatient department based on their clinical radiological criteria, and following that, they were subjected to the spirometrical tests. And based on the GOLD recommendation of considering FEV1 by FVC ratio less than 0.7, we had segregated the patients with mixed defect. That is, they are having an overlap of obstruction as well as restriction. Now this diagnosed pure DPLD as well as the overlap diseases were compared based on the other available spirometric variables like FVC, FEV1 by FVC and FEF 2575. Hello? And after considering all the parameters, the parameter which came out as the most significant one, we had performed an ROC curve analysis using the FEF criteria. Means I would come in the results section, as it had come out as the best significant parameter to differentiate between these two groups to generate a cutoff. And this was done using the GraphPad Prism software version 8. So with this, I come to the results section. In the pure ILD group, I had 140 patients, whereas 23 patients were there in the DPLD OAD overlap group. While comparing their spirometrical variables, we found that FEF 2575 came out to be the most significant parameter between these two groups. That is, FEF 2575 was significantly higher in the pure ILD group, while comparing the same with the counterpart group ILD-OLD overlap. Here we can see that FEV1 by FVC ratio is also significant, but we did not consider that because it became obvious that FEV1 by FVC ratio will be significantly different, as we took the ILD-OLD overlap group based on this ratio only. So this group is already having less than 0.7, so it will be obvious. So we did not consider that. The four groups are the statistical graphs that are showing the spirometrical variables. The red one is the most significant one, FEF 2575, and with this we performed an ROC curve which gave a cutoff value of 45.5 with a sensitivity as high as 91.3% and specificity as 90%. So the conclusion of my study comes like this, that it can effectively predict airflow obstruction in a DPLD patient population, and thus it can be a surrogate marker of airway limitation. So I would acknowledge my guide, Dr. Partho Sharathi Bhattacharya, for mentoring me all throughout, all the staff, colleagues of the institute, and of course Pulmocon 2022 organizing committee for giving me an opportunity to present my work in front of you all the patients who willingly participated in the study. And these are the references of my
Madam,
study.
you will have one.
Thank you. Yes. No, the FEV1 was also significant, but the most significant was FEF 2575. Yes, ma'am.
Yes. One thing.
It- yes. No, we wanted to see. Since those patients were having an FEV1 by FVC ratio less than 0.7, we were considering that they were having an accompanying obstruction. And then we wanted to see whether they are having a smaller airway obstruction, because FEF 2575 in a way denotes smaller airway obstruction only. So that's why we were trying to see. So FEF 2575 was highly significant.
Start your second one.
So with the findings from my previous study, we had extrapolated that to frame another study which is based on extending the scope of identification of obstructive airway disease and diffuse parenchymal lung disease to enumerate the role of FEF25 in a detailed way. So by now we all know that obstructive airway disease is often diagnosed by the gold recommended criteria of FEV1 by FVC ratio less than 0.7. But using this criteria solely, we are having to miss many patients. It might get unnoticed. So using the criteria that has been set from the ROC curve of FEF 2575 in my previous study, we tried to use this criteria in a different cohort of DPLD patients to see whether this role of FEF 2575 seems worthwhile or not. So we considered OAD in 3 groups. The first group had normal FEV1 by FVC ratio with FEV1 reversibility greater than 100 ml. The second group also had normal FEV1 by FVC ratio with a disproportionate reduction of FEF 2575. I would explain later what I actually meant with disproportionate reduction of FEF 2575. And the third group had the absolute value of FEV1 by FVC lesser than the lower limit of normal. These 3 subgroups were then subjected to this FEF 2575 cutoff. We wanted to see this cutoff value that is greater than 45.5 is applicable for these 3 groups or not, so that we can see that, so that we can validate further whether FEF 2575 is actually can identify obstructive patients in DPLD patient pool. So 140 patients were there in pure DPLD group where their ratio was greater than 0.7, whereas 24 patients were there in the overlap group having FEV1 by FVC ratio less than 0.7. 5 patients were there in group A, which I had explained before. 21 patients were there in group A2, and group B had 4 patients. Now, this 26 patients were taken for checking the cutoff, and they successfully qualified for the cutoff. This 30 patients had their FEF 2575% predicted value lesser than 45.5. So the cutoff set by the ROC curve of FEF in my previous study was successful in identifying patients of DPLD having a concomitant obstruction. So we can see that using both GOLD and FEF 2575 criteria together, we can identify 54 subjects out of my 165 subjects that I had taken, that is 32.72% with OAD, while GOLD criteria can only detect 24 of them, that is 14.54. That means almost 23% we are missing on if we are only considering GOLD criteria. So the conclusion of the study goes like this, that unearthing significant proportion of OAD admixed with DPLD can take place if we are incorporating an additional tool of FEF 2575. Although this demands further research, we can make a preliminary conclusion with this. So I would acknowledge my guide and mentor again and the staff of the institute along with the Pulmocon organizing committee for the same. And these are the references. Thank you.
Now we go on to last third question.
So I'll be presenting another work of mine, which is entitled Studying Forced Vital Capacity in Diffuse Parenchymal Lung Disease Patients based on high HRCT derived underlying features. So we all know that DPLD patients on a regular basis, they do undergo radiological screening when they are seeing pulmonologists. So we tried to see the baseline function of the patients suffering from diffuse parenchymal lung disease on a classification done based on their HRCT changes. What do I mean by classification done on their HRCT changes? That is, the patients were subcategorized into 3 groups: fibrotic, non-fibrotic, and mixed, based on the features that they manifested in their HRCT. Like if the patient had changes like honeycombing, traction bronchiectasis, and fine reticulations, they were taken into fibrotic group, while patients manifesting changes like ground glass opacities and mosaic changes were considered as non-fibrotic. And another study group was taken which had patients of with both the changes, that is a mixed group. Now these patients had their HRCT sheets scored by both the pulmonologist as well as a radiologist on a linear scale of 0 to 5. 0 means minimum and 5 means maximum. Then they were considered for statistical calculation. The spirometrical variable as FVC, force vital capacity, both in terms of absolute as well as percent predicted, were compared between these 3 study groups. Now we see fibrotic group has the least number of patients as 19, whereas mixed group has 65 and non-fibrotic group has 30. The mean age between the fibrotic and mixed group are almost comparable, with a little lesser age in the patients of non-fibrotic group. And as we see, the fibrotic group has recorded the lowest FVC, both in terms of absolute value as well as in terms of percent predicted. So fibrotic group had recorded the maximal reduction, followed by the non-fibrotic group, and the mixed group at the point of recruitment. We wanted to see what is their baseline level FVC. Although this demands longitudinal monitoring of these patients, this is actually a part of a long-term study which we are trying to plan, that after say 3, 6 and 9 months post-treatment, what are their treatment effects on the patients based on their spirometrical and as well as functional variables. So as of now, we have their baseline level parameters only, and thus we are presenting the same. So with this, I conclude my third presentation. Thank you so much. Follow them longitudinally. Yes, sir. No, I did not. Observational study, long-term monitoring, cross-sectional long-term study. No, we could not take any healthy control of this patient because the healthy control age group doesn't match with this DPLD population also. No, we are not being able to do that. Actually, we are trying to subcategorize the patients in 3 groups based on their HRCT features, and we'll monitor them longitudinally. Based on, as they'll go on coming up in their follow-up visits, we'll be just asking them to undergo spirometry, and we'll be recording different scoring system, 6-minute walk test, CAT score, and other scoring systems that we have, R score, Raghu scale for the IPF, which has been already established for DPLD. So we'll be taking those, and we'll be seeing whether they are in the improvement group or they are in the deteriorated group.
No. Yes, covered. Huh? Okay.
So we conclude our poster and presentation sessions here. Next, we have a session by our pulmonary rehab team, setting up and running pulmonary rehab program, the lessons learned. I would like to invite Dr. Kranti to please come and chair the session. He is MD in Community Medicine and currently Chief Advisor to CIPLA Foundation. Our pulmonary rehab team comprises of Dr. Parthasarathi Bhattacharya, T.D. Vishwanathan, Dr. Anurna Bhattobbal, Sneha Vishwas, and Reek Chakraborty.
কি করবে এখন বসে? ওখানে গিয়ে হচ্ছে নাকি?
না না, ও কিছু না, চলছে, ওটা তো মাঝে রাস্তায় আছে। স্যার তো মাইক।
Very good morning and greetings. And at the outset, I would like to, thank the organizers of the Pulmocon 22 and Institute of Pulmocare and Research. Doing such a great work since a long time in the academic field of, pulmonology. Uh, we all, have witnessed, the scene of COVID. Not only we, but all over world we witnessed. And there was a huge amount, we all, witnessed, the amount of morbidity and mortality everybody had. And we were also, still we are, I hope we are struggling that we don't know that what COVID will cause in long term. Though we are now aware about, initially we were not aware about the pathophysiology, but now probably we're a little bit more aware, but still I hope, it's like the mystery being unraveled that what all, we hear so many stories, so we are not aware that what eventually COVID will, lead. So it was thought that one of the, apart from the pharmacotherapy, and of course, every pathy has claimed that they had, some amount of care for COVID. But beyond that, there was also a role of pulmonary, rehab, which was otherwise, being advised to the other cases of chronic respiratory diseases. So there was a thought that this could be extended to the post-COVID cases also. So Institute of Pulmocare and Research, started a pulmonary rehab, and they have been running now more than 6 months now. So I would like to, invite Dr. Parthasarthi on the stage, who has been the, pioneer to start this center. So may I request you to please come on the stage, please? Yeah. I'll request, Dr. Ananya to give us a, take through the presentation. Dr. Ananya is a, physiotherapist associated with Institute of Pulmocare. She's working there for more than 6 months. They have developed a very customized, of course, she'll tell in great detail about the work which they are doing. Over to you, Anna.
Good morning, everyone. I am Dr. Ananya from IPCR. I will presenting a presentation that setting up and running a pulmonary rehabilitation program, the lesson learned. First, our head, Dr. Parthasarathi Bhattacharya, will be present the first slide.
Thank you very much. It's a teamwork, in fact, and first of all, I pay my regards to Dr. Kranti for taking the trouble to come all along from Pune and guiding us all along for this pulmonary rehab program itself. So it was a new experience, and I think it's worth presenting. Everyone knows that pulmonary rehab is an established treatment for chronic respiratory ailments, as COPD, EPLD, but we didn't think of doing it, despite knowing that it's working, it's very good, because of several reasons, but the most important reason being that we couldn't afford to do it. So there is a question to afford it. Well, COVID-19 changed the scenario. First it was, there was overwhelming panic followed by apprehension. Then once we survived, we thought that what to do. And by then a lot of post-COVID patients started pouring in. And it was a question of concern as doctors. And we used to see a lot of patients suffering with respiratory distress. Why not think of post-COVID rehabilitation? We thought, and we got interested because of sheer passion. And we meanwhile got some support, assurance of support. But as we started preparing, the surge of the post-COVID problem also ebbed down quite a bit. And then we decided that, well, once we have been on the way, we should start with COPD rehabilitation. So the problems are there to take up any challenge. And the most important problem was that we didn't have any experience. Usually our experience is our mentor, but in this case we are, clueless. There was a hide and seek game with COVID-19. We couldn't continue the OPD continuously, and in between waves we opened it. And meanwhile we got a list of needed items from a prospective sponsor, and that is Cipla Foundation. And we listened to some experience from another centers from a rehab consultant. That actually helped us a lot to frame our mind. And then framing a budget was not easy. Dealing with a MO, which is I had to do alone, and I'm the odd man out, but yet I need to act smart. I'm not a lawyer, it's very difficult to understand. But I would say the basic attitude and the approach of my sponsor or supporter was very positive. They are all out to support us. And that was the main encouragement so that we could go ahead. Delay was inevitable. So the sanction came late. Once it came, the new issues loom important. Things happened like that. But in addition to that, there are other practical problems, like how to procure the instruments. The first supplier, he retreated. Then I had to get another supplier. And the most important is to get the right people. You have to have a good physiotherapist, a social worker, a data manager, and you have to have a nutritionist and other psychological intervention specialist. In fact, I played a role myself, multiple roles, as a nutritional expert, as a psychological, but I think I could do my job. I enjoyed that doing. It sounds nice, but it is difficult. Difficult because we went on, there is no cardiopulmonary training center in the Eastern India. You have to get somebody from outside, or you have to prepare someone. That was a big challenge. And we inducted some people to reject them with hopelessness. So it took a lot of time. At one point of time, I was made to feel myself a foolish guy. Why did you get into this business? And ultimately I thought, okay, let me try and see what can I do. The other problems like a busy schedule of a physician is difficult. And for us, especially once we are generating our electricity to light our own house, I hope you can understand what do I mean. A recruitment doesn't mean solution. If you have manpower, just by namesake doesn't mean anything. You have to have the expertise. So it needs a good lot of training and retraining. One needs to be truthful to himself or herself. We had special problems with us. Reporting, budgeting, these are important issues. Spending the money within the frame period of time was mandatory. The new paraphernalias from the regulatory authorities was sometimes a little disturbing. Making an SOP was an absolute necessity. So we went for making an SOP, and we had to make it customized. We need clarity of vision and room of accommodations because we do not know what is coming in the next morning. And regarding the majority of the issues, needs to fit it to our real world aptly, and finally to focus and choose on COPD rehabilitations. Let me continue my problems. We are unhappy because just the job being done is not our job, not our aim. Our aim was that to keep data for research, which will be research worthy, and derive important inferences from that. So it was all the more difficult for me because I was just entering that domain as a physician. Making a protocol with decision and evaluation and inclusions, follow-up modes, monitoring objectively the impact and others was also our job that we had to do. So we finally formatted an SOP, something which is practical and feasible, and which will be doing as the best possible for our performance. Needs to be grounded simultaneously to the real world also. Now we started the job. We recruited quite a few patients, but there was a stumbling block. The patients didn't turn up for the weekly or bi-weekly follow-up. So this we didn't expect. We thought that we are doing everything free of cost. We are giving so much of input. We are trying the best for the patients. The patients will be, rushing in. They will love to come. It was the contrary. 10% patient turn up. So we thought that this is not the way. We have to make a survey. Why the patients are not coming? So we did a survey. That survey included, that was a Google survey, that included patients' desired degree of interest in the pulmonary rehab, feasibility of comfortable visit frequency, and the major imminent obstacles faced by them to visit the PR program. Then we tried it on a patient cohort of 200 COPD patients. That patient had male predominance, and you can see the result here. See here, 95.5% patients say, yeah, we are ready. We welcome this proposal. We are eager to come. But if you see the second pie chart, you can see that 1/3 of them, 32.5%, only are willing to come once a week, and rest in different frequencies, sometimes some twice a week, very few. Once a month is another 34% or 1/3. So I could understand that most of our patients have got a problem of logistics. Their feasibility was difficult to come once a week. Forget about twice a week. These questions were framed on a consensus, and we responded. We collected the response in a 0 to 5 scale. 0 means no difficulty, 5 means extreme difficulty. I'm not going to present that all, but what we made after that. So we thought that we have to customize. We made 4 modules. The module 1 is a monthly visit. Module 2 is weekly visit, once or 2 days a week. Module 3 is as per the patient's desire and convenience. Well, you cannot come once a week, come at your convenience, but you be in the follow-up, be in the evaluation system. And module 4 is some patients being unwilling to join the rehab program for several reasons. Hence, we categorize them as control, or some patients whom we couldn't accommodate. So they act as a control. So with this, we started our journey, and these are the initial teething issues that we have sorted out. We have been doing. I feel that there are a lot more things to do, but I will just hand over the mic now for deliberation of the operational difficulties to my colleague, Dr. Ananya.
Thank you so much, sir. At induction stage, we suffer so many operational difficulties. That is, main problem is the patients are come that they are unprepared, and the timing is the main issue for successful interactions. And the patients are lethargic, and they non-compliance is the main problem, and the problem of understanding the whole rehabilitation program is the main thing, and they are not so much understand the training that is very difficult for us, and they are not attend our sessions continuously because of their non-medical barriers, such as educational, cognitive issues, financial and socio-religious class related problem. That's why. That is the main problem, but we have to suffer, and the answer is the patient is give more patience and give more time for the initial counseling, and make extra hours for the convenience, and motivate to declare hours, and make multiple interactions to exemplify from success in the real world, and the repetition of the same exercises, and correcting the flaws, and repeated meeting and group meets and video counseling. This is the actual show. The first we inducted after Dr. P.S. Bhattacharya's referral. Rehabilitation program is started, then screening, explaining, and induction the modules, which modules the patient will be comfortable, then evaluation, assessment and intervention, and follow up with regular medication, and module of the PR program as per previously suggested that is followed. After the modules are completed, then we are going to for the post PR maintenance phase. There was one operation difficulties that the patient are not continuing regularly. That's why we have faced some problems. That these operational difficulties to maintain, we break the lethargy and counseling the patient, and ensuring the cooperation for continuation and the data collection, and repeating the performance regularly. With OPD and our PR department collaboration, we running the show, but we maintain it multiple modules and maintain the quality of the job. The next part will be delivered to Dr. Sneha Vishesh.
Thank you, ma'am. Good morning, all. Now I am going to present our areas of intervention. We divided the areas of intervention in 6 categories. The first one is education and motivation of the patient, then patient preparation, then airway clearance and breathing exercise, and lastly strength and endurance training. These 6 categories are subdivided into some portion. That first one, we first briefly discuss about the disease, then role of rehab on COPD, that is a non-pharmacological intervention, and then breathing pattern correction. We see in some patients there are tendency to paradoxical breathing, which is chest wall is inward in inspiration and outward movement in on expiration. So we try to correct those breathing pattern, and after that correction of inhalation technique. In patient preparation, we first correct the posture of the patient, then we go for some warm-up exercise, 1 minute walking, upper limb exercise, upper limb up and down exercise, neck relaxation exercise, and lower limb exercise. Then airway clearance, if required in some patients, we go for postural drainage, which helps in airway clearance. By those, it helps in mobilizing secretions from different segments of lung to the central airways by placing the patient in different position. Postural drainage, which includes percussion, vibration, and shaking with coupled voluntary coughing. Achha, then breathing exercise, which is a main part of the pulmonary rehabilitation. We deep breathing exercise, diaphragmatic breathing, abdominal and segmental breathing exercise. And after lastly, we go for strength and endurance training. We seen in some patients there are tendency to neuromuscular dysfunction and loss of muscle tone. So we try to correct this by strength and endurance training. This is a deep breathing exercise. We instruct the patient to deep breathe in through the nose and exhale through the mouth. This is diaphragmatic breathing exercise. And this is abdominal breathing. Okay, this part will describe by Rick Chakravarti.
Well, thank you, Sneha, and good morning to everyone. I will be discussing about the findings that we had from the rehabilitation program. As Dr. Bhattacharya told earlier, we had divided our modules into 4 modules, module 1, 2, 3, and 4. Module 1 comprises of patients who visit like in 1 month. Module 2 with weekly visits, once a week or twice a week. Module 3, patients, these patients come from long distances and they can't visit regularly. So they are under remote monitoring, and the module 4 patients, many patients come who are not willing to join the program. So we kept them as control. So in this case, in module 1, we have recruited 54 patients till date who have already completed 45 follow-ups. Followed by module 2, where the recruitment has been 51 patients with a very large number of follow-up, that is 308. In case of module 3, we have 75 recruited patients. Out of them, 30 patients has been remotely monitored, and the others will be monitored very soon. We have got 410 control patients for now. Next, this is a brief data of all the patients in module 1 and 2. I'll be showing the gist of summaries in the next slides. So as we can see the health status variables across the modules, in CAT and CAT score has been significantly reducing in follow-ups in module 1 and 2, the physical follow-ups that I mean. In peak of flow, we can see there has been an increase. In peak expiratory flow, there has been increase. But in case of module 2, there has been a decline because in some patients there has been cases of exacerbations and repeated exacerbations. I think that might be the cause. Well, these results need to be validated further. Though. We have also showed the 6-minute walk distance with all the other variables. In the next slides, I will be discussing the findings later. So this is an overview of all the findings that I just showed in the earlier slide. So changes in CAT score across the modules. Here in case of module 1, we can see at induction, the average CAT score of the patients was 10.53, which after at least 1 to 3 follow-ups has reduced to 7.8 on an average. In case of module 2, the average score was 11.58, which has been reduced to 5.36. And in case of module 2, the average follow-up has been like 8 follow-ups, so average 8 follow-ups. There, the standard deviation is 5.7, because certain patients have already completed 17 or 18 follow-ups. The peak curve flow, as you can all see in both the modules, the peak curve flow has increased as compared to the date of induction on an average. Now in case of PEF, we can see there has been some changes in module 1 and module 2. In case of module 1, there has been a significant increase in peak expiratory flow, where as in case of module 2, it has reduced on an average. The patients who come to module 2, generally they show a tremendous amount of exacerbations once or twice, and quite frequently they whenever they're developing their condition, they seem to miss their follow-ups, and for like 2 to 3 weeks they miss the follow-ups. Then again, we have to start from like they have decreased their developing trend, so we start from there back then. So this shows an average fluctuation, and that's why I think the average score is a bit low in this case. In 6-minute walk distance in both the modules, you can see there has been increases. There has been, in case of module 2, we have around 30 meter of increase in 6-minute walk distance on an average, whereas in module 1, we have like more than 50 meters in increase in the 6-minute walk distance. The percentage covered has increased as compared to the age groups, those of the patients who come inducted to the program, and this is the result, as you can see over here. The VAS is a visual analog scale. This is recorded by the patients, their self-realization about how they are feeling right now. So in this case, the low score means they are better, and the higher score means they are not well. They are not feeling well themselves. It is their self-realization, and they scored themselves. On that score, we see the VAS score is falling, means they are feeling well themselves. So there are certain, this is the finding parts, and the result and official issue will be discussed by Dr. Ananya. Thank you. Thank you, everyone.
Thank you, Rick, for this opportunity. That there are many official issues, that is, being a CSR funded program, the reporting requirements to the statutory authorities are getting more and more demanding by the day. We welcome that, but extracting and collecting data related to socio-economic and other than non-medical personal details from the patient seems to be impossible task. Sometimes this type of attempts raises suspicion and about the program itself on the patient's side. This is the peer group meeting photos that we conducted in our institute. This is the one endorsement by our patients. Sorry, sound is not on. Thank you so much. For this. Peer group meeting. Yes, yes. Huh. Huh. That is neck relaxation exercise. Neck relaxation exercise. Because many COPD patients have difficulties in accessory muscles. So we are treating by neck relaxation exercise, that neck expansion. That is yes, ma'am. Yes, sir. Yes, sir. Yes. This is yeah. Actually, sir, we yes, sir. Yes, sir. Actually, sir, actually, actually, first we
So, as to the question, as you asked, like incentives and all these things. Sir, no, sir, it's not, we don't actually, we don't refuse the patients and we don't categorize them. It's up to them. No, sir, the thing is like, we give the, sir, we just survey the patients. Okay, sir, we just survey the patients. It's up to their feasibility. Means there are patients who are coming from very long distances. So it's not possible for them to attend very day. So we, when they're eager, we just appreciate they come on a weekly basis or a monthly basis. So that's why we created the modules. Okay. 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 Okay, sir. We'll look into that, sir. Sir, still, I would just like to justify the point. Like the program is very in its seedling stage, sir. We are yet to reach to all the patients, and the patients. Yes, sir, we are yet to reach to the patients. Sir. We are yet to reach to the patients. The patients are coming on not at least at a 3 months gap when they are coming to the OPD. So basically, we'll take some time, but definitely we will, sir. Sir.
yes, sir. Sir, actually, we are made an arrangement. Those whose patients are staying outside Calcutta, we are giving some of token money for attending our PR program. Yes, yes, sir. Free visits also there, video counseling, and That will do, sir. Video conferencing and. Yes, sir. Yes. They definitely do that, sir. The inauguration program of just started. Yes. Thank you, sir.
Check, check, check. Pacho. Check.
ইউরি সাইকেলে লিক হওয়ার কারণে চাষ নতুন দামে কত প্যান্ট এর বিস্তৃত প্লাস রশ্মি ইউরিন চুষে নেয় তাড়াতাড়িও লাগাতার ভাবে এখন কোনো মেডিসিন নেই 12 ঘন্টা পর্যন্ত এই থেকে বাঁচায় ভালো ঘুমাতে যদি রেকর্ড ভাবে শরীরের ভার একটু কোমর ভাঙলেও বা কি হয়েছে যাতে জীবনের মাঝে ব্যথা না আসে Presenting Dollar Whistle, range of cool, friendly ladies. Dollar Whistle Lens. Zamano and Morigato. এখন আমার গাড়ি এসে গেছে সেল করে দেয় পার্সেন্ট কত বেতন করা হচ্ছে লাইফ রিপ্যারেন্স এর আছে দ্বিগুণ স্ট্রেচেবল ওয়েসি ব্যাগ যা সেল করতে সহজ করায় আর লিকেজ হয়ে বন্ধ আর ডায়পার নিচে দিয়ে পড়া মানে মাথা উঁচু করে জীবন যাপন লাইফ রিপ্যারেন্স ওরা আত্মবিশ্বাস Amazon Great Indian Festival. Get up to 7
Welcome to the Pulmocon quiz. We'll have we have 35 questions. The total time duration for the whole quiz will be 25 minutes. After that, we'll be having the scoring, and the same 15 minutes we'll be discussing the answers. Okay? Every correct response is +4 marks and every negative -1. Okay? +4 -1. All right?
So importantly, all of you, make sure that the other teams don't look into what you're doing. Okay? Otherwise, you're going to lose your question to them. So just make sure that the other teams don't look at what you're doing. And make sure that you are writing the response. If you are going to tick 2 responses, we are going to give that 0 marks. Just one response, whichever one you think is correct. Yeah. And if somebody gives 2 responses, as Dr. Unnithan said, you get negative marks for it. Yeah. Yeah. So, and at the end of the day, Quizmaster's decision is final. Okay. So, Dr. Webber will say questions. For every question, you get 40 seconds. And then we move on to the next question. So 25 minutes we will do the questions, then 10 minutes we will discuss after we've taken those sheets from you, discussing the answers so that you know what you've done. Okay? Okay, all the best to everyone.
Same questions are here, no problem.
Question number 1 started. Question number 2. There are 40 seconds. I need. Question number 2. दे दो. We'll have to finish 25 minutes to finish 35 minutes.
Are you sure about this? I'm not very sure about this. ठीक है ना? अच्छा, हाँ हाँ. How did he come there? ये तो disqualify करना चाहिए. इन लोगों को disqualify करना चाहिए. उसके बाद में
वो लगा दो. वो मैं लगा दूंगा. 11 more minutes.
Yeah, we're fine.
Don't need to like wait for 25 minutes. Finish earlier, just submit. And we discuss all the questions.
Eight more minutes. 8. 7 minutes.
Will anyone finish before time?
7
You're done? Correction करें? हाँ, correction करें. Right. 4 more minutes. Question sheet boy. Three minutes more. Negative, wrong answer. 2 more minutes. हाँ.
कल का जो है ना वो
बहुत डिफिकल्ट है. कल का बहुत डिफिकल्ट है.
Has everybody submitted? দাঁড়া এক্ষুনি এটা খুলিস না, লাগবে এক্ষুনি। So, well done to all of you. So we'll just discuss the questions one by one. Let's come to the first question of group 1. A severe COPD program, patient enters a rehab program. What is the most likely to improve? What is the answer? C, exercise tolerance. That's correct. So C is the correct answer for first question. The second question is, what is the most pathognomonic sign of ABPA? Ham, that's correct. B is the correct answer. B, high attenuated mucus is the correct answer. The third question, which calcification pattern in SPN is more likely of malignancy? Stippled, very good. D is the correct answer. So this question, D is the correct answer. Pemberton sign is positive in which disease? Retrosternal goiter. D is the correct answer. D. Next question. Drugs not used in the prophylaxis for pneumocystis jirovecii pneumonia in immune compromised patient. What is the correct answer? B. Clindamycin is the correct answer. Dapsone, atorvaquone and pentamidine are all used. Okay, so this is your group 1 questions. Well done. Looks like everyone has done it correctly. Group 2, which is not a sign of nicotine withdrawal? What? What? Tachycardia. A is the correct answer. So tachycardia is not a sign of nicotine withdrawal. Which of the following is not an acid-fast organism? Which one? Cryptococcus is not an acid-fast organism. Contrary to popular belief. Oh, sorry. C, Cryptococcus. C is the correct answer. The Dr. Webber has taken a lot of pains, and he has also given all the recommendations and also where these answers are coming from. If there is any queries, contact him, he will tell you. As per the latest ERS criteria, as per the latest ERS ESC criteria, IPAH is defined as PVR more than 2 Woods unit. That's correct. So A is the correct answer. What is level 8 mediastinal lymph node? Paraesophageal. C is the correct answer. C. Next question. Black pleura sign is seen in PAM. So it is seen in PAM. So black pleura sign, A is the correct answer. D. Okay. Okay. So round 3 questions. Your first question is type 3 respiratory failure is associated with post-operative atelectasis. B is the correct answer. D is the correct answer. Gunshot nodules on pleural surface on thoracoscopy is seen in, very good, endometriosis. So gunshot wound is very typical of endometriosis. Duration of ATD in all oral longer MDR regimen is D. D, 18 to 20 months. D is the correct answer. D. Dr. Agarwal, is it okay? D. Acha. D. D is the correct answer. So, which wave is predominant in EEG in N3 sleep? Huh? Delta. Very good. D is the correct answer. Delta is the predominant EEG in N3 sleep. Well done. In Stop Bank questionnaire, obesity criteria is BMI more than, what is the correct answer? 35. Correct. D is the correct answer. 35. Round 4. Which QTC interval on ECG is not prolonged? Very good. A is the correct answer. Less than 470 milliseconds in females. A. Severe OSA is classified as AHI more than 30. Well done. D is the correct answer. D. D is the correct answer. Significant PEFR variability in children is by diurnal variation of more than dash percentage. What's the correct answer? Huh? How many people said A? How many B? Put your hands up. How many said C? How many said D? C is the correct answer, 13%. It's children. It's not adults. Look at GINA 2020. C is the correct answer. Next question. In COPD grading as per GOLD, a person with CAT more than 10, no exacerbations in 1 year, and MMRC 4 is B. B is the correct answer. They are in group B. Correct. So more symptoms, no exacerbation. Next word, as per latest GINA guidelines, a person with symptoms less than twice a week and no night awakening is classified as, very good, A. Intermittent is the correct answer. A. A is the correct answer. Round 5. Reed index is positive in chronic bronchitis if it is more than 0.4. B is the correct answer. 0.4. 0.4 is the correct answer. B. Ultrafine PM is less than 0.1 microns, 0.5 microns, less than 1 micron, less than 5 microns. What's the correct answer? A is the correct answer. 0.1 micron is the correct answer. Which of the following inhaled drugs is not ultra long acting? A, B, C, D. Very good. D is the correct answer. Aclidinium is not an ultra long acting bronchodilator. D is the correct answer. Which biologic also blocks IL-13 pathway? Dupilumab. A. A is the correct answer. Quickly, last round. Huh? Oh, what is the normal alveolar protein arterial oxygen gradient? What is the correct answer? B is the correct answer. Less than 25. What ATD is important to prevent relapse maximum sterilizing activity? A. Rifampicin is the correct answer. A. Which ATD can precipitate Addisonian crisis? A. Rifampicin is the correct answer. Pre-XDR TB is resistant to? A. Both are A. 26, 27, both are A. Pre-XDR TB is resistant to? B is the correct answer. B. B is the correct answer. Which of the following is not commonly a cause for QT prolongation? D. 28 is B. 28 is B. 29 is D. Ethionamide. Which study has evaluated combined use of bedaquiline and delamide? A is the correct answer. 30 is A. And last group of questions quickly, because we have to go for the next session. We are very late. Is EBUS elastography. Stiff nodes are blue. A is the correct answer. A. A is the correct answer. pH due to schistosomiasis. A is the correct answer. Group 1. Increase in minute ventilation in pregnancy is due to? B is the correct answer. Tidal volume is increased, respiratory rate unchanged. B is the correct answer. Second last question. Listing criteria for COPD for lung transplant is? A is the correct answer. FEV1 less than 15 to 20%. And last question. A is the correct answer. The minimum number of air exchanges in bronchoscopy room is? A, 12. Okay, so that finishes our elimination. We will calculate and come back to you after this session. Thank you. এটা লাগাও হ্যাঁ বিমান গাঙ্গুলির ঢোকালে All of you, please sit down. Dr. Dhiman Ganguly is going to give his lecture, and after this, we will tell which teams are going to go forward. So please sit down and have a seat.
So for the next session, we are going to have a talk on medical education, some perspectives from home and abroad. The talk will be mainly focused on medical education, changing methods and practice, the scenic route to medicine, medical teaching, experience of a teacher without frontiers. For this, I would like to welcome Dr. Dhiman Ganguly, sir. Dr. Dhiman Ganguly, sir, is devoted to academic activities and an eminent orator across the country and abroad. He is currently associated with Vivekananda Institute of Medical Sciences, Kolkata. He has also adorned the chair of the East India chapter of ACCP. He is also the Honorable President of Indian Chess Society and also holding a very prestigious position of Institute of Pulmocon and Research, being the President. So please welcome Dr. Dhiman Ganguly on the dais. Thank you. Over to you, sir.
Good afternoon and very warm welcome to this session. I don't think any one of you has any experience of having a topic like this in any conference. I had this in mind for about 5 years, but it was difficult to convince conference organizers that a session on medical education, where can we change, what are things being done elsewhere, these things need to be discussed so that we can form our own opinion about what to do. Now the problem is, changing things may not always lead to improvement. There are plenty of examples in history where a change has led to disaster. But at the same time, if we do not change, remain as we were, we create a cesspool. And cesspools are never useful to any society. So important thing is we've got to keep thinking about changes. I begin the talk with this quotation from a German scientist of 18th century. He said, "I cannot say whether things will get better if we change. What I can say is they must change if they are to get better." So that, I think, is a much better way of expressing what I was trying to present. Now, looking for changes, where do we look for changes? Because I have only 30 minutes, so I have decided these two headings: education and training, and then under medical education, what can we do with the curriculum that we are following now? I graduated more than 50 years ago, and as far as I can see, you people with minor changes are following the same schedule for your MBBS courses. So we'll talk a little about education, why it is important to emphasize education. And education and training, we use these terms interchangeably. I don't think we really realize that education and training are entirely different things. They have different purpose. I'll come to that in a minute. Now, Richard Stanley Peters is a British philosopher. He was born in India, in Mussoorie, British India. And in 1960s, he published this book, Concept of Education, edited by R.S. Peters. In that book, Peters himself writes a chapter. And this is the most important line I could find out. To be educated is not to have arrived, but to travel with a different view. You see, this is very important. Education is supposed to change the way we look at things. You see, Puran, Sa Vidya Ya Vimuktaye. That is education that sets you free. Sets you free from what? Your prejudices, your dogmas. You see, you begin to analyze things with an open mind, without a preconceived idea. That's what education does, is supposed to do when we are following a course or whatever. To be educated is to have a broad perspective, should touch the student at a personal level. Education is supposed to change your personality. And training has a narrow focus. The word training is more useful for vocational training, like a plumber or an electrician. That's why what we call vocational training. You are taught to be an electrician or a plumber or whatever. So, but over the last 100 years or so, unfortunately, we have gradually put more and more importance on training rather than education. You see, even you people will be more interested to learn how to do a coronary angiogram rather than, spend time on your education so that you get a better quality human being. We talk of students being trained to be doctors rather than being educated in medicine. You see, that word, trained to be doctors, is wrong. We need to think in terms of getting educated in medicine. You see, I will finish these quotations with this one. John Stuart Mill was a Liberal Party MP and a philosopher in 19th century. He said, it is really of importance not only what men can do, but also what manner of men they are that do it. You see, if you and me are doing the same thing, the result will depend on what kind of man I am and what kind of man you are. Your quality as a human being will affect the result that we will get. What manner of men they are that do it. Among the works of men, which human life is rightly involved in perfecting and beautifying, the first of importance is the man himself. So the summary is, in any educative process, including medical education, it is the person that is to be given more importance than what technologies he is learned in the laboratories. Now, where are we looking for changes? For example, the curriculum. We have anatomy, physiology, pharmacology, pathology, and what have you. That's what we have been reading. Can we think of altering this? Or can we think of adding something else that will increase the educative value of a medical curriculum? Now, I was very pleased to see that General Medical Council in United Kingdom published a document way back in 1993, and their important emphasis was greater focus on education. And the good doctor, again, this good doctor is a vague term. It's very difficult to define a good doctor. A little later, my friend Shankar Sinha will probably touch upon this subject. The good doctor must be an educated doctor, and this is one of the major areas where arts and humanities subjects might make a contribution. I don't know whether you have ever heard about it, that people are thinking of including literature in medical curriculum. They believe that this will help you grow up as a more complete human being. Now, when I read that GMC document, I thought that was a wonderful idea of including humanities in medical curriculum. And I thought they must be the first group of people who have thought about it. But I was wrong. About 2 years ago, I was presented a small booklet on Jamsetji Tata. Now, Jahangir Tata is his nephew, cousin, brother, son. And some of you would know that he is considered to be the father of Indian aviation. What we know as Indian Airlines today was created by this man. But along with that, he was a president of the Court of Indian Institute of Science between 1955 to 1993. I hope all of you have heard the name of Indian Institute of Science, a very premier institute for higher studies in India. And this is what he said in their Jubilee celebration lecture. It has been said that education is what makes a man. Men and women pursuing advanced studies in our institute have little time or opportunity to expose themselves to literature, arts, drama, poetry, music, history, philosophy, which though unconnected to their study or research work, are essential elements in the makeup of a civilized, educated man. And as Jamsetji Tata had in mind, look at the far-sightedness of this man. Jamsetji Tata was born in 1839. You see, and he could think of these things. Indian Institute of Science, I don't know whether you are aware, the money came from Jamsetji Tata, and the area was donated by the Maharaja of Mysore, who was a disciple of Swami Vivekananda. And in that campus, there was no mention of Jamsetji Tata. You see, look at the man's character. Only recently, I think about 10 years back, somebody has put in a statue of Jamsetji Tata in Indian Institute of Science. Otherwise, the name is Indian Institute of Science. There is no mention of Jamsetji Tata. So it's very, very important. Now, some work has already been done. I'm not talking about utopian ideas. Some work has already been done to include humanities in medical education. Context, outcome, and structure. I haven't got enough time to tell you what this paper tries to prove, but this is available in the internet. If any one of you is interested, I would be very glad to give you the reference. So it's from Durham University in United Kingdom. They have started doing it and they have problems with it because boys are not interested. Only a handful. Now, whether to make it a examination related subject or whether to keep humanities as an optional class to attend, they haven't decided yet. But anyway, some advancement has already been done. Now, Leo Tolstoy, in his epic novel, what is the purpose? What purpose would it serve to include literature in medical curriculum? I will come to that in a minute. Tolstoy, in his epic novel Anna Karenina, began with this sentence: all happy families resemble each other, but all unhappy families are unhappy in their own way. As doctors, you will be seeing unhappy people all the time. Happy people wouldn't come to you. So whoever meets you is an unhappy individual. So you got to sort of get some kind of education about unhappiness. Why do people feel unhappy? Now, I haven't got more time to discuss this, but how is this going to help? This is what I have summarized. Humanities in medical curriculum will expose you people to problematic life situations and how individuals respond to it. Very unfortunately, our medical student community is from generally upper middle class people. But once you become a doctor, you are supposed to interact and take care of all strata of people. You see, the thinking line of these people, the way they react to certain situations is unknown to you. You have no idea. Because you have been brought up in a generally affluent family. So, problematic life situations and how individuals respond to it, it exposes you to some of the great thinkers of the world, making them consider different ways of perceiving the world. Again, a question of viewpoint. You have a different way of perceiving the world. And it exposes you to a counter culture and widening their mental horizon. Why I say counter culture? You people have left school and entered a medical college. You see, so, and the culture inside the medical college, where you have spent about 10 years maybe, that's very uniform all over the world. So that kind of makes you blind to other cultures. You see, when you were a class 12 student, did you have any idea what is taught in geology classes? No idea. What is anthropology? What do they do? You see, so it's important that they get exposed to counter cultures. By the way, in Europe and America, in most universities, medicine is a postgraduate degree. That means you have to have a BA degree before you enter a medical college. So what happens is they are an older lot when they get into a medical college. If you got into a medical college at 17 and they got in, usually get in at 19. In those 2 years, the maturity grows. So you are in a better position to decide what you would like to do, which is not easy. Eligibility and selection. What is the purpose? To identify individuals who can be good doctors. Simple. That's what we are looking for when we are fixing eligibility and selection. And to explain that, You see, in the training, what are we looking for in a student? Mainly two things: cognitive ability or potential to tackle the intellectual burden of a medical curriculum. Now, intellectual burden of a medical curriculum is nothing much. Any mediocre student can handle the intellectual burden. All they have to do is to work hard. You don't really need to be very meritorious to finish MBBS course successfully. And the second point is more important: non-cognitive traits or potential to negotiate the ethical, interrelational and motivational challenges of a medical degree. That is more difficult, because that's what we do every day, those challenges that we need to keep in mind. Now, what is the problem with selection tools? I mean, in our country, it's a multiple choice examination. In other countries, they have multiple choice examination, personality test, aptitude test, single interview, multiple interview, all sorts of different ways are there in different countries, with the only one single idea to pick out the right material who would be good doctors. Now this man, I will now give you two examples to show you how difficult it is to decide who is good for what. You see, that's what we are trying to do. Is this boy good to be a doctor, or would he do better if he is a lawyer? You see, and that's not easy. This man's name is Venkatraman Ramakrishnan. He is a Nobel laureate, and this picture I took from a video from NDTV when he came to India at Rashtrapati Bhavan to accept his Padma Vibhushan award. And in response to the award, he gave a 3-minute lecture. You people are in the internet all the time. His interviews are all there in internet, and they are wonderfully worded, and you have a lot to learn, really. Now, this is his brief biodata. This man was born in 1952 in Tamil Nadu, India. He wanted to become a doctor. So he wanted to go to a good coaching class to prepare for the entrance test. But his scientist father called that idea a nonsense, didn't send him to a good coaching class, and he fared very poorly in entrance test. No IIT, no medical college. He couldn't find a seat. So what can he do? He went to Baroda, where his father was posted, and started a physics honors course in BSc. He did very well in his BSc class and managed to go to USA. Not a very good university, Ohio. It's not a top grade university in USA. But he managed to go there and did a PhD in physics in 1976. And then he said in an interview that I was not liking what I was doing. Just imagine a man with a doctorate in physics is saying that he is not liking what he is doing. So what he did? He enrolled in a graduate student biology, as a graduate student in a biology course. Mind you, somebody with a doctorate in physics is getting enrolled in an undergraduate course on biology. He said in an interview that my father was almost mad. He thought I had gone crazy. You see, this is like committing suicide, that somebody with a doctorate in physics is reading biology now, but that's what he did. Didn't listen to his father. He was a postdoctoral fellow at Yale, which is a good university, and started working on ribosomes. You know, ribosomes are intracellular organisms where we manufacture our protein. He was refused by 50 universities in USA for a faculty position. He tried to get a teaching posting, and he was refused by at least 50 American universities. They didn't like him. So what he did, he joined Brookhaven National Laboratory and he was there between 1983 and 95. This was a grade 1 laboratory that is famous for research in basic sciences. So he joined there, spent those years, and eventually got a post of professor of biochemistry in Utah University in 1995. But he didn't like that job either. So he left that job, came to England, and joined Medical Research Council Laboratory of Molecular Biology in the United Kingdom to pursue his interest in ribosomes. And it is there he published wonderful papers on atomic structure of ribosomes and how do they work. This was published in Nature. And this led to a Nobel Prize in Chemistry jointly with 2 other workers in 2009. You see, somebody from theoretical physics to biology to chemistry, you see, this is how you improve your country. You see, we close doors in front of our students. They keep everything open. Somebody with a doctorate in physics is trying to do a course in biology, he will be all right, he will be taken in. And he became president of Royal Society in 2015, which he is the only person of Indian origin who became a president of Royal Society, the chair once occupied by Sir Isaac Newton. Now, the second story is this man, Harold Varmus. He came to Kolkata in 2018 for a function, and there I managed to get his biodata. He graduated with English literature in 1962 from Harvard, English literature. Then for some reason or other, he decided that he would like to do some voluntary work and came to India in a mission hospital in Bareilly in Uttar Pradesh. He worked as a volunteer for 3 months. And those 3 months make him decide that he wanted to become a doctor. And he became a doctor in 1966, the same year I graduated. And he is 23 years later, he is a joint Nobel Prize winner in 1989 for his work on oncogenes. So again, I think I have made enough point to tell you that it's the selection and eligibility problem is terrible. It's very, very difficult. Do we select our profession, career, or the career profession seeks us out, at least sometimes? And when it does, the result can be wonderful. Now I'll have to finish quickly. Now, this is a Nassim Nicholas Taleb, is a Lebanese American. He is a statistician and a risk analyst. He has written a book called Fooled by Randomness, the hidden role of chance in life and in the markets. So what he tried to establish is that your efficiency merit is less important than the chances that come to you. And a second book, I haven't got time to explain. Mihaly Csikszentmihalyi is a Hungarian American. He is a professor of psychology and management in USA. He interviewed hundreds of very creative people all over the world with one question: what did they think is responsible for their spectacular success? And majority of them replied, I was lucky. You see, so that's what now I have intentionally avoided mentioning this. I'll briefly tell you that now, as I was telling you a little earlier, people think the social structure of medical students should be similar to the social structure of people they are going to serve. But that's not possible, because unless your parents have reasonable money, it's very, very difficult to compete in an entrance test. So what to do? There are countries who have resorted to reservation, as we have done since independence, but that is highly criticized. Now this is a news from New Zealand, Dunedin University. You know, in New Zealand, Maoris were the original residents, and the white-skinned Caucasian people went in to occupy that country. So Dunedin University has now reserved seats for Maoris, and that's being hotly debated in New Zealand. And a psychiatrist, you know, that word Pakeha in Maori language means a white-skinned man. He argues that if you are very meritorious, if you have done very well through your school and college career, then you are not the right person to become a doctor. You see, you should go for basic science. We would like you to do microbiology, biochemistry, molecular biology, nuclear medicine, so that the country benefits from your merit. But if you become a doctor, you treat peptic ulcer and migraine all your life without really contributing what you could have to the country. I think in half an hour it's difficult to cover such a subject, but I think it was not too boring for you, because these informations were probably not available to you and should give you a food for thought to for your future guidance. Now, can we have Dr. Shankar Sinha's biodata? My friend Dr. Shankar Sinha has spent his working life as a general surgeon with a special interest in medical education in many countries, from India, Africa, United Kingdom, Papua New Guinea, and Australia. He now lives in Australia. His MBBS is from Arjigar Medical College. He did his MS from All India Institute of Medical Sciences, and he has enjoyed traveling fellowships. For the last 30 years, he lives in Hobart, Australia. Having retired as a practicing general surgeon, he is now engaged heavily in
problem. কি বলছে তোমার নামে শুনতে পাচ্ছে না। হ্যালো, তো ফ্রিজ করে গেল আবার তো।
স্যার স্ক্রিনটা চেঞ্জ হচ্ছে স্যার, আমি আপনাকে আপনি একটু কলে থাকবেন?
হ্যাঁ হ্যাঁ, আমি লাইনে আছি।
ফিজিক্যাল মনিটর থেকে হ্যাঁ আপনি একটু থাকুন স্যার, একটা অ্যানাউন্সমেন্ট করে আমি আপনার সাথে কমিউনিকেট করছি স্যার।
আচ্ছা ঠিক আছে, থ্যাংক ইউ।
হ্যাঁ স্যার।
Chakravarti. Fourth, again tie. We have two teams, one from Calcutta National Medical College, Dr. Rahul Pal and Dr. Akhtarul. And AIMS Patna, Dr. Amit. So these are the 6 teams who are going on to tomorrow.
আচ্ছা ঠিক আছে ঠিক আছে আচ্ছা আমি স্ক্রিন শেয়ারটা এখন করতে পারছি না দেখলাম আমি তুমি ওটাকে
Sir,
enable
it's you are audible, sir.
hello
Shankar, are you there?
yes I am there I am here
Okay. Well, why can't we see your face?
well I don't know why let me just check it because I have the video is on I can see my face on the screen but it is on
Sir,
your
you
end.
are visible now. Your face is also visible.
Okay,
So,
visible? Okay, good.
it's
Okay.
visible. Yes, sir. This is fine, sir.
Can you enable the share screen function mode?
Sir,
Because
your
I
screen is already shared, sir.
But-
It's on the screen.
I cannot see my slides.
Yes, sir. It's visible.
Is it visible now? Okay, good.
Yeah, it's
Good.
visible. It's visible.
Okay.
We're good to go.
Okay, thank you. I'll just start from the beginning.
Over to you, sir.
Okay, thank you so much. And well, thank you, the Pulmocon Society, for inviting me for this talk, and I'm extremely honored to participate in this. And my special thanks to my friend Dhiman, with whom I studied together, and also the conference organizer Partho Bhattacharya. This is a talk which I will give it, to provide some narrative about my experiences being fortunate to work in different parts of the world. So I will start by asking a question actually to the audience that how many of you consider yourselves to be a good doctor? But before that, I want to define, which my friend Dhiman actually alluded to it, that the definition of a doctor is in Latin is teacher. So a good doctor not only is a clinician, but by very definition is also a teacher. Now the question is, how do you define a good doctor? And if one goes to the internet and check the YouTube and also the other literature, there are various qualities have been mentioned about definition of a good doctor. But I have read somewhere, one person has mentioned that I do not know how to define a good doctor, but I can recognize one when I see them. And I think that actually encapsulates the characteristics of a good doctor. So my question to the audience would be now, how many of you in the audience consider yourselves to be a good doctor?
Okay, raise your hands. Do you consider yourself to be a good doctor? Come on. Oh, there are only two hands, Shankar.
I think the audience is feeling they are a bit sort of shy to tell, and this is lack of confidence, I think, because they must be a good doctor, otherwise they would not have come and attended this conference. So I think my next question would be, what percentage of your knowledge came from your learning at the medical school or college to become a good doctor? And I have given all these choices, 10, 20, 50, and more than 80%. And I think it will be
10%. And how many of you would consider 10% of your undergraduate training is what you are using now? 10%, 20%?
Yes,
anybody else? Oh, they are between 10 and 20, Shankar.
Okay, well, that is exactly what was my guess estimate. So that brings to my next question. If that is the case, 80% of your knowledge you gather after you have graduated. So the question is, and I bring it to your point earlier, is changing the current structure necessary? And again, I wanted to bring this point also. You mentioned already in your talk that not all changes translates into progress. And in fact, you said some of them may be disastrous. But even on the conservative side, I wanted to give you this example to the audience that this is a very posh, sophisticated car which they designed with this addition of technology in which the headlight cover will only open up when the car starts its engine, particularly in darkness, and the headlight will be on. Now, this technology has not been, accepted by other, advanced cars, and the reason is simple: because this change neither has made the car more efficient, nor has it made it safe to drive. So not all change translates into progress. I want you to keep this in mind, and I will answer these questions at towards the end of my talk based on my personal perspective about the experience around the world. So I will just start by saying that my journey in medicine started precisely on the 10th of July 1961, and Dhiman might remember the day. Our first lecture was chemistry by Professor Robi Ganguly, and as you are entering into the class, this particular small card was handed over to us by my respected senior colleague, Dr. Syed Ali Asad. He retired as a professor of anatomy and he lives in Calcutta, and I am still in contact with him. So that was a very significant day in our career. And then we graduated in 1966. In fact, actually 65 we graduated, but then we did what we call as a pre-registration of clinical assistant, 6 months time. Now, one thing I realized after I had my graduation, and what Dr. Richard Gordon, who was an anesthetist but became famous by writing series of books which became movie also. And in one of his book, he mentions that I have got the free ticket to travel the world. And that's exactly, I have followed it, not by design, but by more or less by chance. And my journey in medicine coincided with the three distinct periods of evolution of a medical education curriculum. And I divide them into three periods: the period until 1960, then between 70 and 80, and then 1980s. And I'll narrate these experiences. Now, in the 60s, when we were a student at the RG Corps Medical College, and our teachers, the almost 90% or maybe a little more than the senior teachers, the consultants, all had qualification from Western country. They all went to mostly to UK, and some went to other parts of the world also, and came back with their foreign qualification. And that was a ticket, more or less, to establish them into their private practice. And what happened is that, as a result of that, we actually followed the Western mode of instruction. And the fashion was there, and I repeat this word here, very important. The fashion was adoption and not adaptation. And I want you to sort of really look at this and the choice of these two words carefully. We are talking about adoption, which is almost everything, whatever the Western medicine has been delivering, we just copied them almost word for word. We did not adapt it. And as a result, much of our training was hospital oriented, without no attention to the health in the community. We did have some what we used to call as excursion as a part of our preventive and social medicine component of the course. We used to visit some of the primary health center, but they were more of a sightseeing rather than a learning opportunity. We also suffered from lack of the medical textbook with relevant local contexts. We followed Belly and Love's textbook of surgery written by the UK medical students for them. And as a result, we probably produced good export quality doctors, myself included. So what happened in 1970s and 80s, and I put this slide with a red mark on the word efforts. The efforts were made to align the medical training with the primary health care initiated by the WHOs. And why I put it in effort? Because they have made an effort, but it was hardly implemented appropriately. And as again, I referred to Dhiman's talk earlier. He did mention the curriculum which he had 50 years ago has hardly changed even now. Although in India there has been few committees, and one of them was Srivastava committee, which suggested reorientation of the medical education based on national priorities and needs. Subsequently, Bajaj committee came and their observation was the current medical school faculty, although efficient in delivering clinical care, but they were deficient as educators. And then Medical Council of India intervened and they said that, well, we need to produce a uniform standard of medical education across the country. And as you know that this was all more in papers than in practice. And I can tell you about my experience briefly when I was working as a lecturer at the North Bengal Medical College under the University of North Bengal, but was working at the SSKM hospital because they did not have their own hospital. The Medical Council of India team came to accredited. This is their first visit, and I was, given the responsibility to organize and produce the Medical Council of India, the structure of the surgical department as appropriate to fit into their qualities. And we rapidly sort of artificially made all those units of surgical disciplines, which was not never existed. So it is all bit of a sham, work. So the second, in that period, then what happened is that I actually went to work in Africa, in Zambia, and that was actually after I spent a year as a Commonwealth Fellow in UK. And most of my time I spent was at the city called Ndola, where there was a very, very posh building, multi-storied building built by the donation of the United Nations. And the two upper floor of this was occupied by the staff from the World Health Organization, with whom we had no contact. Although we were in the same building, we had no contact. And one of my shock was that when we worked there, we came across to certain diseases which I have never studied in detail and I have never seen a patient. And most important example, and I know that in your multiple choice question, I was just watching, they mentioned about schistosomiasis, but that is, they're talking about pulmonary one. But this is what I found. There was a urological component of it. Schistosomia hematobium is actually another species of parasite which is excreted through the urine and causes lesion in the bladder. And the most frequent cause of hematuria in Zambia when I was worked there was bilharziasis. We have hardly heard about that. So that was what my experience about the inappropriate, resources and lack of community exposure at all. There is no community exposure. We didn't know what is happening in the community. And as a result, what happened, we found that although the medical school in Zambia was established in 1966, but the current statistics established as late as 2021, there has been a massive healthcare staff shortage, massive. They could not fulfill to deliver the number of doctors required in the country. That brings to my third phase of my career in medicine, which until now it is still continuing. And in this phase, what we have learned is that there is an effort to implement global standards and institutional accreditation on the medical schools worldwide. The question here, can we reconcile the global standards and local needs? And I have put this map here for information. If you look at it, all these areas in the atlas with blue, they are called the north, and the red one is the south. Exceptions are the Australia and New Zealand. The red countries are the developing world, and the blue are the developed countries, what we call as a north and south divide. So my main part of my third phase was spent in Papua New Guinea, and I don't know, many of you probably have not heard that land, and I have to confess that when I applied for the position as a senior lecturer at the University of Papua New Guinea, I was working in Zambia, and I did not know where the Papua New Guinea was. I had to look into the map. So here it was, I arrived in 1979 in Port Moresby, which is the country's capital, and the Port Moresby General Hospital being the tertiary referral hospital. So this was an eye-opener to me. When I reached to this country, I was exposed to a group of students who were the first generation in their family to do medicine. In fact, to come into the university. Their fathers and their grandfathers never been to the school or colleges. So this is the first generation of Papua New Guinean who have entered into the medicine. And I realized that the context is very important in that case, and one had to be very sensitive about their cultural aspects of it. And what I have found, very, to my pleasant surprise, they're way ahead actually. Although they're a little country, what you can call it is a backward sort of in our definition, they actually tried what we call is to emulate, not to imitate the Western medicine. And what they have done, which is quite a revolution, because their medical course was a 4-year degree course, but the internship was 2 years. And that is based on the adult learning principle. Then an adult learn better when they're allowed to do something. So instead of listening lectures, but if they're allowed to practice medicine, they become a better doctor. And not only that, in that country I have seen they have produced textbooks, and this is an example of a pediatric medicine which is based on the local need and the local resources. And these are the first batch of final year students, and some of them have done very well. They went on to become the dean of the medical school, and one of them is this person, Dr. Tefuarani. He is the current dean in the medical school in Port Moresby. And also there are people who became the secretary for health, like Clement. And then there is a Frank Toroba who became a surgeon and also became the brigadier in the head of the armed forces of Papua New Guinea. So I'm very privileged to be associated with their development. And this is a picture I wanted to show you because you would see that how proud they are to show their local culture in the graduation ceremony. And this is one of my students, Dr. Zango, who comes from the highland, very fierce tribe there, they're hunters, and as you can see, they're wearing their, the village, the ritual, the costumes, and he has later on became a gynecologist. And in my role as head of surgery, I was involved in training the future surgeons, and of which one of them you can see who is assisting me. He is the current head of surgery now in Port Moresby. Unfortunately, he is retiring soon because of a Parkinson's disease. I was also involved in the community work, in preventive work. The Port Moresby had a very high road accidents, and one of the reasons was the seat belt was not a compulsory at the time. And this is one of my contribution to that, that I actually made a campaign. And finally, before I left the country, the seat belt became a law. And I often jokingly said to my students that this is one reason when I die, I suddenly have booked my seat in heaven. And this is a follow-up picture about my going back to Port Moresby General Hospital. Back in 2016, I was asked to give a crash course to the postgraduates for a week, and I spent there. The purpose of this slide is I want you to carefully watch, and this is where I'm saying, and look at all these postgraduate students who were preparing for their surgical postgraduate training at that time. Look at their concentration, their focus, and look at them. None of them are using mobile phone, checking their Facebook or checking their emails. This is what I find when I teach my students in Hobart and in Sydney in the School of Medicine of Notre Dame. And this is one of the very pleasant thing, my pleasant experience of working there. But like all developing countries, this is what happened. In Papua New Guinea, they are also suffering from lack of money, and this is lack of the supplies, and this is partly because of the corruption. And this is the story of the developing country, India not excluded, and I'm not going to go into what is happening in West Bengal at the moment. So I come back to this question, and which again I have to refer back to Dhiman, who has given a talk, I think it's last year or maybe year before, for a general audience, and his talk is on Bengali about the Tattva এবং Prayog, and he actually showed that there is a ocean of difference between the theory and practice. And this is what was highlighted when I was reading this article by Dr. Kulkarni, which I have alluded before. And in his article, he mentions when he was at a conference, one of the nursing faculty asked a question that how come today's medical interns cannot record a blood pressure or put a Foley's catheter or insert a intravenous line. And the reason is they are very good in theory, but they are not so good in practice. And that has led to the changes in the curriculum, in particularly in Australia, and it's also happening in North America, Canada, and UK, that there is introduction of simulation-based skills learning, and the assessment of the intern is based as a workplace-based assessment, and I have got a little role to play in that one. And coming back to this one, when I came to Australia in 1991, I was working at the Royal Hobart Hospital under the aegis of the University of Tasmania College of Health and Medicine. And then in 2010, I joined the University of Notre Dame School of Medicine in Sydney as head of anatomy. Now, while I was working at the University of Tasmania, I introduced the simulation-based course, which was highly successful. And I have also introduced a student-centered learning by what is called as a blended learning. And I used surgical pathology specimen as a mode of bridge between the basic science and the clinical science. And of course, in the Notre Dame, I did this anatomy teaching. I changed the curriculum based on evidence, and we both, I'm happy to say that we both actually led to our team award, not only from the university, but from the national award. So coming back to this is what Dhiman again has mentioned, that this slide to show is two aspects. One, that in Australia it is possible to join medicine from non-science background, and also it tells you the role of humanities in medicine. And this is actually one recent example from one of my present student who has done a Bachelor of Music, and the student plays this instrument called flugelhorn. I don't know whether you are aware about it. You must have seen it before. And after doing Bachelor of Medicine, Bachelor of Music, he has joined medicine. And when I asked the question to this student, he has given me, or she actually it was, given me her observation, and she said there is a great deal of similarity between being a musician and being a doctor. And I would like you to sort of read this one without repeating what she has said. So coming back to my original question, should we need a change in medical education? And my answer is given to very recent article came out in the India Today, which in January 2022, and although you said that India has 541 medical colleges, but still the healthcare falls far short of the ideal and needs urgent changes to cater for the healthcare demands of the nation. Time doesn't permit me because I had my experience in going to work in Sundarban area, and I found that is the case. So learning point from my talk, I hope what I have learned is that I have started, I really sort of found it that we all must think globally, but we must act locally. So local context is very important, and we must create this curriculum, medical curriculum, which should be student-centered and outcome-focused medical education. And I think I wanted to end this one with Roger Federer, what he said yesterday, as of yesterday, and it just almost echoed my sentiment that it has been a perfect journey. Whatever I have done, it was wonderful. I'm very grateful to God, to allow me this opportunity to experience this, and I would do it all over again. Thank you so much.
Is Shampa ready also?
Yes, I'm just getting her ready for the. She will share my same computer,
Okay.
and I'm going to get her presentation up in the screen.
Okay. That will be very helpful. If we have time, and if the
Yes.
audience here is interested, we might have one or two question answers at the end. So remain online.
I would be very eager to do that. Okay.
Presentation mode. Change it. Presentation mode. There.
Just see whether she can see. You can see this.
Okay. Oh, hello. So thank you very much, everyone. Thank you particularly to Dr. Ganguly and Dr. Bhattacharya.
Shampa, give me 2 minutes to say a few words about you.
Okay.
To sort of introduce you to the audience.
Okay.
Dr. Shampa Sinha is currently completing her specialist palliative care training at Royal Hobart Hospital. She did a graduation in MBBS degree from University of Notre Dame in Sydney and completed her basic physician training in various hospitals in Sydney and Hobart before passing her FRACP examination in 2021. Prior to doing medicine, this is what makes her very special. Prior to doing medicine, she worked at the World Bank in Washington, D.C. in the areas of public health and evaluation. Over to you, Shampa.
Thank you. Thanks for that very generous introduction, Dr. Ganguly. And thank you also to Dr. Bhattacharya for the opportunity to speak at this conference. And thanks to all of you for allowing an interloper like myself, who is a non-respiratory physician, to impose upon your time. So my presentation is going to be a little bit self-indulgent in that I thought what I would do is just lead you through my journey to medicine and my planned and unplanned detours that I took. So my journey began in Papua New Guinea. So I was a high school student in Port Moresby, which is the capital of Papua New Guinea, and I had diligently picked all the science subjects that I needed in order to qualify to apply for medicine. And I'd even gone as far as applying to medical school, actually, at the University of Adelaide. And then I happened to go into the libraries, in the school library, and I discovered this amazing book, which was written by a political scientist by the name of Susan George. And it was on, it was called A Fate Worse Than Debt. And it basically deconstructed the debt crisis of the 1980s, where developing countries were forced to basically borrow a lot of money from first world countries because they had a lot of the banks in first world countries were basically repositories for all the excess petrodollars that were coming from the oil exporting countries because of the spikes in the price of petroleum. And they essentially ended up borrowing lots of money, went into debt, and then subsequently couldn't repay the debt. And this caused basically breakdown in their economies. And then at the same time, I also started reading The Economist, which is also, I would recommend it highly to everyone in terms of in medicine too, because it really explains what happens in the world, the current politics and economics of the world, in very simple and very entertaining terms. So as a result of reading these two publications, I suddenly realized that maybe the answer to all the world's problems does not lie in just treating individuals. Maybe I should go out and actually learn more about the systemic forces and the systemic influences that are leading to poverty, and that led me down the route of actually abandoning medicine, my plans to do medicine, and instead I decided to go and do economics and law. So that after finishing my combined economics and law degree, I decided to join the Australian Foreign Service, and that led me on this quite interesting, some quite interesting adventures, including going on short-term missions as part of the Australian delegation to the United Nations in New York, Geneva, and Bangkok, and then a longer-term mission in Mexico City, which is the picture on the top right is actually the opera house, the Palacio de Bellas Artes, which is in the center of Mexico City. It's a beautiful building. And then I also was able to visit Fidel Castro's Cuba and hear him speak live. I was in the room when he was speaking and doing one of his interminable 2-hour-long speeches. And I also got to be a glorified fly on the wall, or a note taker, essentially, during a meeting, which was the Conference of Financing for Development in Monterrey in Mexico, where George Bush and Colin Powell both attended. So all of this was very exciting, but there was also a very soul-destroying side of diplomacy, where I felt that we were basically, I was stuck in this endless loop of meetings where very little concrete was achieved. And especially after 9/11, I think a lot of foreign services around the world were basically permeated with sort of a culture of parochialism and fear. And Australia, under the Howard government at the time, walked away from a lot of its international obligations on climate change as well as cutting funding for development assistance. And I felt like it no longer sort of gelled very well with my own idealistic sort of principles. I decided to leave the Foreign Service at that stage. And I went back to academia, and I went to study at Princeton, and it was very exciting again to sort of walk the same hallowed grounds that Albert Einstein had treaded, and that's his house on the top right corner is his house on Princeton campus, or near Princeton campus. And I was also very fortunate to have go attend courses by Nobel laureates such as Professor Angus Deaton, who taught this amazing course on health inequality, and the other gentleman on the bottom right-hand side is Daniel Kahneman, who's also a Nobel laureate in economics, and he had designed this excellent course called The Psychology of Public Policy, which delves into the biases that affect human decision making. And I still use that knowledge a lot in my clinical practice today.
Shampa, can you make the slides a little larger? It looks too small.
No, I actually can't, because it's actually it's on my full screen.
It's already on your full screen.
Yeah, yeah.
It's difficult for us to sort of see and read what's in your slides.
Let's see. So I don't have any text on the slides. I just have.
Okay, that's all right. Keep talking.
Yeah. So then, after I graduated from Princeton, I I actually went to the World Bank, and I worked at the World Bank for a while. And I was involved in a lot of reports, some of which are shown on the screen, mainly in the health sector. But again, I started feeling this sort of restlessness. I started feeling more and more ignorant, actually, as I kept doing this work, because I felt as my role was essentially to evaluate projects in the health sector, and yet I knew nothing about clinical side of health. And most of the people who had designed these projects and who were implementing these projects were actually people with medical degrees and doctors or former doctors. And I felt that I had no idea what I was really doing. So I felt like in order to really be effective, I needed to learn more about clinical medicine. And so I decided then to take, in Australia, we have to do this thing called the GAMSAT exam to enter into the graduate medical degree. So I did that. That's sort of that's a 3-part exam. And the first part is on comprehension and analytical thinking. The second part is on essay writing, and the third part is on science. So it's basically tests first year university level physics, chemistry, and biology. So I struggled to prepare for this exam because I had only done high school physics, chemistry. I hadn't actually done a high school level year 11, 12 biology. So it basically involved a lot of late nights in a lot of bookstores in the US, where I was based at the time, studying for this exam. Managed to scrape through, and then I went and had to do a written application and then an interview, and then got through that and made it to med school, and started and did a 4-year course. But initially, this is how I felt in the classroom. I felt like the geriatric, elderly person in a room full of young, keen, sharp, intelligent people. The youngest person there was 21 years old, and I think they actually had their 21st birthday at the end of their first year. But fortunately, I wasn't the oldest person. The oldest person in my cohort was a 52-year-old gentleman who had done agricultural economics. So I was a bit, we had a very large a range in ages. We also had like a lot of people from very interesting backgrounds. We had an ex-policeman, we had someone who was a CEO of an IT company. We also had a philosophy major who has now become a cardiologist, actually. So there's all sorts of diverse backgrounds. Um, and at times I felt my motivation was flagging. But at the time, I remember my father's mentor, Dr. P.N. Chatterjee, actually sent him a letter sort of saying that he should remind me of Albert Schweitzer, who is this German polymath essentially, and he did he decided to do medicine at the age of 30, and ended up getting the Nobel Prize for his writing on philosophy. Essentially, he got a Nobel Prize for peace. Um, and one of his quotes was something that I resonated a lot with me, which was that success is not the key to happiness. Happiness is the key to success. And if you love what you are doing, you will be successful. It actually took me a lot of time long time to actually love what I was doing, I'll be honest. The first 2 years of medical school were pretty difficult and onerous, but then once we got into the clinical years, I actually started enjoying medicine. And unfortunately, something quite tragic happened where one of my very good friends had a melanoma, and he ended up dying at the age of 42 after a 10-year struggle with melanoma. And in the last few months of his life, he spent a lot of time in hospice. And I used to visit him, and he used to describe his doctors and nurses as angels. And I was very curious about this, and I thought, I've never heard of any other specialty, well, maybe except for respiratory physicians, being described as angels. So I decided that I would do a rotation in palliative care as a medical student. And I went there with great trepidation, expecting to be very depressed every day, and very demoralized. But I found completely the opposite feeling. I used to end every day just feeling so fulfilled and so enriched by all the patients I had met and all their stories. And I would just feel energized, and I wouldn't be able to wait to begin the next day. And that feeling has stayed with me, which is why I've picked this specialty. And the other great thing that happened was, as a resident, I was also very fortunate to work with Dr. Frank Brennan, who worked at St. George Hospital, one of the hospitals in Sydney. And he is himself comes from a bit of an interesting background, because he began his professional life as a general practitioner in Ireland, then went to South Africa to work as a doctor. And while he was in South Africa, he heard a lawyer being interviewed on the radio who described health as a human right. And this was a very interesting concept to him. So he thought, he decided to study law, because he liked the concept of studying about human rights and thinking of health as a human right. And then he ended up actually coming to Australia. And while he was in Australia, and he was working as a legal clerk for one of the High Court judges in Australia. In Australia, the High Court is the highest court in the land, and he. At the same time, on the weekends, he would work. He would moonlight as a emergency department doctor, so to keep his hand in medicine. And then in the end, he went back to being a physician and decided to specialize in palliative care. And he was someone he's an amazing clinician, and he is someone who really believes in the value of storytelling in medicine. And as I've shown there, he's sort of one of the things he said once in an interview was that there is something very natural and human in storytelling. The story of illness and suffering needs to be heard, and then that simple thing can be very helpful and healing. And I would highly encourage you to look his work up. He's got a beautiful essay online, which he's then incorporated into a book of essays. It's very moving, and I think it really brings home to you how delving into the stories of our patients teaches us compassion and helps us humanize them as well. And we also have storytellers, storytelling palliative care physicians in India. And I would also highly recommend this book by Dr. M.R. Rajagopal, who is considered the father of palliative care in India. He began his medical life as a anesthetist, and then in the process of treating people's pain, discovered the value of palliative care, and has a wonderful organization called Pallium India, which is in Kerala, and they do amazing work in terms of trying to improve the access to palliative care, bringing it to the poor in India. And since this is a conference of respiratory physicians, I thought I would also mention this landmark paper, which is an old paper now. It was a NEJM paper in 2010, which showed the value of early palliative care for patients with non-small cell lung cancer, and actually found that early referral to palliative care actually resulted in increasing survival of lung cancer patients by a median of 3 months, which doesn't sound like a big deal, but when you're at the end of your life, 3 months of better quality of life can make a huge difference. And they actually ended up getting less aggressive treatments at the end of life as well, which also contributed to their quality of life. And then just to end off my sort of my medical journey, my most recent experience in palliative care was in a community palliative care team. And it helped me sort of draw together all the diverse threads of my academic and professional background. So I got to be the inaugural registrar implementing this pilot program, which is aimed at improving access to palliative care for nursing home residents. So in the top right-hand corner of the slide is one of the nursing homes I used to frequent quite a lot. And in the bottom left is the view from one of the tea rooms of one of the nursing homes of Mount Wellington, which is the main sort of mountain in Hobart. And I found this extremely fulfilling. I had to use my diplomatic skills in order to nurture relationships between the care managers, with the care managers in the nursing homes and the GPs who were sort of already working in palliative care in these nursing homes, and also use negotiation skills in different clinical situations. So that was extremely satisfying. And so if I had to sort of talk about the advantages and disadvantages of taking the scenic route to medicine and doing medicine late in life, I would say that, medicine is quite a tough field, and it exposes us to a lot of difficult life situations. And I think a little maturity and a little life experience helps you a great deal in sort of empathizing with those situations, and in terms of relating, improving your ability to relate to your patients. It also, I think, it helps to have had those experiences because you are more resilient. I think because as you grow older, you experience a lot of trauma and challenges in your own life, and that makes you better able to withstand pressures that medicine exposes you to. And the other advantage is, of course, that you end up being better lateral thinkers if you've had more of a diverse academic background before you come to medicine. There are lots of disadvantages. I think one of the things was I found that my brain took a lot longer to memorize facts and figures, and of course the volume of knowledge you need for fellowship exams in particular in medicine is vast. So that was a bit of a challenge. It's also kind of lonely doing it as a mature age student, because all your friends, all my friends from outside of medicine were off, having a great time on their weekends. They could relax and enjoy life, and I was stuck, with my head in Harrison's, and
Yeah.
so it was pretty hard.
Did that feel very distasting? I mean,
Yeah.
did you regret coming to medicine?
Oh, a lot of
Every
time.
time?
Yeah, yeah, definitely. In the first 2 years, I definitely did. And of course, you have no income, right? Because you don't have a job.
Ah,
So, so yeah, so that was tough. And then obviously, there's lots of people who I had family and financial commitments, like mortgages and little children, and so that was hard. And then the other thing is that you get very rigid in your schedule, in your life schedules and your personality. So, and
yeah.
medicine, particularly when you're rotating through different teams and different clinical rotations, you all have to be flexible and adaptable. And that can be a challenge when you're older. Um, so I guess my takeaways from my experience, and there's just my humble experience, is that no experience in life is wasted. And I think a rolling stone can gather moss, contrary to the popular adage. And I think everything that I've done in my life has been of value now. The other thing is that to remember that you need to sort of check your ego in at the door. A lot of my bosses now are older, are sorry, younger than me, or even the same age as me. And yeah, so
Is
and
that a
I've realized,
problem?
no, so well, I've realized that just being older, me being older doesn't make me wiser. Like I actually have, I can learn from everyone, and so I constantly learn from my patients in particular. So, and I think the third thing is to sort of cultivate curiosity and have, as Zen philosophers say, have a beginner's mind. Always be open and see everything anew. And I guess the fourth thing that I would say is that, medicine is a big tent, by which I mean that there's room for all personality types. There's a specialty for every personality type. So the minute I walked into an operating theater, I knew that I wasn't a surgeon. um,
Yeah.
and whereas, the minute, I did my rotation in palliative care, I knew it was the best fit for me. So if you're not enjoying your specialty, then you can always move laterally into a different.
What made you choose terminal care?
So that's a misconception, because palliative care is not just terminal care. It's not
Palliative
just,
care, yeah.
yeah. So it's not just about the absolute end. It's sort of also supportive care. I think because you learn, I think first of all, it's a great privilege to be involved in that very precious time in a person's life, which is the final days of their life, or the final weeks or months leading up to it. And the other thing is that you get to really know the patient, not as a patient, not as their disease, but in a holistic sense. So in palliative care, we don't just look at the disease process and their pain and their nausea and vomiting, but we look at, how they've lived their life, what their
Okay.
biggest
Well,
story is.
Shampa, we have exceeded our time limit. Would
Yeah.
you tell us about a take-home message from
Yeah.
someone who changed his career pretty late in young ages and has reached this stage now? It's not difficult, it shows. The first 2 years was difficult, was it? The
Yeah,
first 2 years.
yeah. I think, and then I think once you get to actually see how you can apply, when you get into your clinical years,
Then things
and
become easier.
things become more interesting and easier. Yes, definitely.
Okay.
So yeah, that's my
Uh,
final slide.
Thank you. Thank
Yeah,
you. It
thank you.
was enjoyable talking to you. Maybe
Yes,
someday in future we will meet face to face.
yes, that
If
would be
God
wonderful.
willing,
That would
uh,
be wonderful.
keep well and keep working.
Thank you.
We
Thank you.
will now sign off. Okay.
All Right. Thank you.
Thank you.
Thank you very much, Diman.
Yeah, well, I tried to do something new.
No, I think you have been very successful, and you have built a very good, efficient team. I must congratulate them, and this is my dream come true that I have been trying to do it for last more than 12 years actually. I've been associated with the KPC Medical College. I wanted to do this, but I think now I see that there is a possibility that we can expand this further
Can
in
easily be done. Yes.
periodic exchange of ideas and communication. Yes, sure. Thank you.
Thank you, Shankar. Well, when are you coming to India?
I think I'm hoping that probably would be coming to attend the reunion. Hoping. So
Before 19th December.
Yes, yes, yes.
Okay.
Thank you. Thank you.
Okay, it's all right.
And
We'll sign off now.
Yeah, my special thanks to Rick for the technical side. Thank you so much.
Oh,
Bye.
he has done wonderfully.
Thank you. Very
Yes.
good. Well done.
Okay.
Thank you. Bye. Bye.
Bye.
এখন আমি করছি ও করনি ওই তো মাল পাঠিয়েছিল হ্যাঁ তোমরা দেখতে পাচ্ছ এসে নিশ্চয়ই হ্যাঁ
মানুষটা নিজের হাতে এক গ্লাস জল দিয়ে কি করছে কে জানে আমার কথা ছাড় আমি ভাবছি ওদের কথা রাজা এক করছিল কি করছে কে জানে বলছি তুমি একবার ডাকলে ওরা আবার চলে না শোন আমি তো ওদের তাড়িয়ে দিই ওরা নিজে থেকে চলে যাচ্ছে মাথা উঁচু করে নিজের ছেলেকে সঙ্গে করে চলেছে যাবো বাড়ি এদিকে দিন নিজে আমাদের নিতে আসবে যে যেমন তার নারায়ণ চৌধুরী আছে তেমন এই সুভাষণী চৌধুরী ওরই জন্মবিজ্ঞান ঈশ্বর তিনি কি খেলা খেলছিল আমার কিছু করার নেই
or young pulmonologist. To chair the session, I would like to welcome Dr. A.G. Ghoshal. Dr. Ghoshal is an ex-president of Indian Chess Society. Currently, he is the medical director of NAABI Kolkata. He is a consultant pulmonologist with more than 30 years of clinical and teaching experience. His area of expertise are airway diseases, lung diseases, drug-resistant TB, and sleep disorder. I welcome you, Dr. Ghoshal, to chair the session.
না অসম্ভব আমার রাজা কোনোদিন এই ধরনের কোনো কাজ করতে পারে না এটা নিশ্চয়ই কোনো চক্রান্ত
Hello, hello. Okay, done. So, the title of this next 1.5 hours, I think, or 2 hours. 2 hours, yes, 2 hours, is career options in pulmonology. Is that okay, Partho? It is the pulmonology clear? Okay. Sandeep, I have heard that you have some other talk. No? Here only? So here only. So can we keep the schedule as before? Done, done. Okay. So no hurry, Sandeep? Okay, that's great. Now, when you talk of career options in pulmonology, you think there are some guidance rules. Guidance rules are precept. But example is always better than precept. Partho has done a very good task by this ensemble, because this is a good topic, and good task because you see the best and you understand what does it mean by career option in pulmonology. So when you see one Sandeep Salvi doing research, Randeep Guleria as a teacher, and the younger next generation, some of them I don't even know by name, by know their work. So when you see the best, it's very clear that these are the options, career options in pulmonology. But these are only very few. The big chunk, bigger chunk, the biggest chunk is outside. So I am always for the next benches, to middle benches, to back benches. Long back, I was busy in my OPD, SSKM, some of you may know, at least 250 patients in the OPD. And there was a crowd, maddening crowd. I was very busy writing, and an affable face just peeped from the curtain. I looked like this. He said that he has got a, again, what I am going to tell you may be a little biased because I am a hardcore pulmonologist. So affable face looked like, and I said yes, questioningly, I didn't say even anything. And he uttered that he has got an opening in internal medicine. Is he free to join there? So I looked like this and I started seeing patient without even any answer. And that poor fellow immediately went back, gave resignation to the internal medicine and came back. Dr. Ayadhar. Before that, another, he was studying something. Okay, sir, this is, I am trying to get the pediatrics. He has already got admission in pediatrics. Same thing again. I forgot about his existence. And again, he immediately resigned from this pediatrician. He is now Indranil Haldar. And again, another, it is C. She was very clumsy in her work. So after some intervention, when I went there, it was in a mess. The intervention was done, it was in a mess. I wrote, who did this? Nothing will happen to him in future. There was a new sister. She thought she should assist me. So that lady, only one lady among the group was standing there. She pointed out for me, sir, this is C. Nothing will happen to her in future. And fortunately, that lady came for our DM inspection here a few years back. And fortunately, she gave the clearance for DM pulmonology course in Bengal. So the options are many. And fortunately, Partha has done a great task because he has assembled almost all this, almost all of them. And it is good. May I start with Monotos? You are not in a hurry. Okay, that's good. কোথায় গেল সে মেয়েটা পালিয়েছে নাকি? আচ্ছা, anyway. So, it is good that we are starting with Dr. Monotos Khada. He is respiratory physician primarily, and he has not shifted his base from a rural background to the, what we usually do, we come to cities. We come to cities to get more facilities, more patients. Monotos didn't do that. But he has made his existence known to the rest of the state and some outside as well. So it is good to know how Monotos worked over there and what is his take at the present moment. Dr. Monotos Khada, please, and then we'll proceed one by one. Monotos. আমাকে একটা ওটা দেবে, আমি জানি না তো কে কে আছে। No, no, I don't want this. No biodata for me. I am the list. এই তোমরা বুঝো, তোমরা বুঝো।
Hello, yeah, okay, yes. First of all, my sincere thanks and gratitude to Dr. Partho Sarathi Bhattacharya for asking me to be a part of this panel. And my sincere gratitude to Professor A.G. Ghoshal, who has kind enough to introduce me. My session is here, Pulmonology Practice in Rural Areas. My lessons and suggestions.
Just one
As
second.
we know,
Just one second, Monotos. Again, for everybody, there are multiple speakers, so everybody is to conclude within 10 minutes. Okay?
Okay, sir.
Everybody, please.
Okay. So my subject is Pulmonology Practice in Rural Area, my lessons and suggestions. This topic is very important to all of us, particularly the young pulmonologist, as because number of pulmonologists is increasing day by day. Everybody will not get chance to be associated with the medical education, government service, or with the corporate houses. Somebody may go to abroad, somebody may move to some research work, but as the number is hugely increasing day by day, somebody has to move. Not somebody, many of us have to move to the rural area to serve the people. So this is the as we all know, for the pulmonologist, I have already told, they need to go to the rural area for their practice and for their existence. But on the other hand, we can see the urban-rural specialist doctors ratio is very poor. Villages need more medical specialists nearby. Not only the pulmonologist, many other specialties they need. And in contrary to the first, the affordability of the villages has increased more. So, in a nutshell, I can say the pulmonary practice, the prospect of pulmonary practice is good, but initial struggle may be very difficult to bear with, and sometimes may be depressing. The young pulmonologist should overcome this stage of depression. First question is, how many chambers? If you want to go to the rural places, how many chambers should you attend? Because I used to see the young pulmonologists or doctors, those who are going from the city of Howrah or Kolkata to the different villages of suburban area, they used to run from one chamber to other chambers. And patient also try to reach him once he has consulted you. Now he's trying to reach you. Once he reached your chamber, then you have already left that chamber and now in the way to attend the other chambers. That is the problem. So if you want to establish you as a good practitioner in that rural area, you have to restrict your chamber. Maximum 2 to 3 chambers you can attend. If you are going to practice in your native place, for example, one pulmonologist who just passed now and decided to practice in the rural area, if he want to practice in his native place, that is in Midnapur, try to open your chamber in your local area and sit there regularly, almost 6 days a week. But I think it may not be possible for all of you to purchase a chamber of your own at the initial stage. In that case, you may start consulting places around that area, 3 chambers after 3 to 4 years, when you are having a good number of patients, then you should think about to purchase or establish a chamber of your own. It may take time to establish your practice, but in the long run, that practice will remain at a reasonable, acceptable range. Next question. What should be your starting consultation fees? Yes, keeping in mind the affordability of the patients, normal fee range, you should restrict your consultation fee as per the other doctors are charging. You may rather keep it little bit lower range. It will help your patients to come to you at a regular basis. When he or she will be cured, rather than managed satisfactorily, he or she will bring more and more patients related to you. In that case, your number of patients will increase gradually. Another questions that is in the rural area regarding home calls. Question is, whether should we entertain home calls? There are some good reasons for that and also some bad reasons for that. First of all, home calls, benefits of attending home calls are many. Patient, when a sick patient party will ask you to visit his or her place to see the patient, the party, if you go there, definitely the patient party will get confidence that yes, the doctor is available on request at his home place. This is one sense of satisfaction from the patient party, from the view of the patient party. Secondly, it is a sort of advertisement. Whenever you go to one place to see a patient, other persons or neighbors will say, this is a new doctor. He has come. He's a pulmonologist. He came here from SSKM or NRS like that. And that they will know you. And that is a sort of advertisement. And you will also, the local places, every villages, every roads and person, everything you know. These are the benefit. But there are some problems are there. Problems are the rich people, the powerful people may disturb you off and on. They will ask you, please doctor, come to my house, to my wife, my children, like that, that you may be disturbed. May be forced to attend the patients at home, keeping your chamber patient waiting. And there is nothing but loss of time. So the bottom line is attend home calls at least during your initial phase of practice. After getting more and more patients, when your chamber is full, the party will not ask you more. They please visit our place, because they will see the chamber is full with patients. They will not ask you repeatedly to visit their places. But to build the practice, you need to attend the home calls. Local management, very, very important. That may be in case of your family, that may be in case of in corporate house, that may be in case of your hospitals. Everywhere, local management is very, very important. You have to good relationship with the neighbors who will protect you during any problem. With the political leaders, Gram Panchayat members will not, to be frank, will not help you at all. But if you have good relationship with them, they will at least protect you. That means they may not roll negatively against you. That is much more important. And most importantly, you should have good relationship with the club, NGO. You should attend any health program, any social program organized by them. You should attend the blood donation camp. You should attend any awareness, any type of awareness program, maybe on the TB, maybe on the HIV, anything else. You should attend, because not only by attending the program, you will be familiar with the local peoples, but also will be introduced with the other senior doctors who are practicing there for a long time. That is that there will be good relationship building will be there. Yes, chambers, the patients are your client. We open our chamber for the client. So, not like before, we have to have good chamber, comfortable chamber for sitting of our patients. Sitting arrangements should be comfortable. Your assistant should be polite and responsible chap. And among the patients who are waiting for a long time, you have to give emergency service. At least prioritize those patients who are suffering from dyspnea, bleeding, chest pain, everything like that. So you should have emergency service in that cases. Newspaper and health magazines should be kept on the table, so that the patient party or patient can time pass with joy. Drinking water should be available. Washrooms should be clean and sanitized regularly. And as you are pulmonologist, you should have oxygen facilities and nebulizer, at least for the emergency patient of patients suffering from some dyspnea. This is very, very important. This is, assume the patient sitting in front of you is a relative. This is not my talking. This was the talking or teaching by Professor late Devabroto Sen. He used to tell us that the person who is sitting in front of you as a patient, think he is your relative. So, as you talk or behave with your relatives, talk with the patient in that way. Be polite, be patient, listen to them carefully, and talk to them gently. Don't express your anger or quarrel with them. Try to follow the latest guidelines to treat a disease. And if needed, if you think so, the patient should be consulted with your seniors. Refer the patient early, not at the 11th hour. Don't fall in the trap. Trap means network in which you have been enclosed. That trap may be due to the pharma companies, that may be from the laboratories, that may be from the nursing homes, that trap may be from the medical shop owner. Be patient, be hardworking, devote maximum time during your initial phase of practice. Try to apply your clinical acumen. This is very, very important. Don't write so many investigations. Write only those which are actually needed. Try to judge the patient financial capability. Try to judge the patient financial capability before writing medicine and investigations. If you found one patient looks to be poor, if you write so many costly medicines and investigation, the patient will go and he will purchase medicine for 2 to 3 days only. He discontinue. If the symptoms recur, he or she will not visit your chamber. They will go to the coax. So you will lose the patients. So try to assess the patient's purchasing capacity. After that, you will write. The patient will stay with you. Yes, as a pulmonologist, okay, sir. 2 or 3 slides are there. Admission in a nursing home, it is required. Admit when they are really necessary. Bronchoscopy, pleural aspiration, lymph node biopsy, you can do there. But if you admit a patient, if you think the proper facilities for the treatment of the patient is not available, then you please refer the patient, but not at the 11th hour. Keep yourself updated. If we found the one patient is having some problem, you are not sure about the management, go through the books, journals regularly about the critical cases you have seen recently. Attend CME regularly to update your knowledge, and don't hesitate to consult your seniors if necessary. Another quotation from late Professor Bacharam Sadhuka. If one patient asks you, showing the prescription, that was the previous doctors has done correctly diagnose the case or write the prescription correctly? If somebody asks you, your answer should be, he has done his best at that point of time. Similarly, if you find any reports from the diagnostic center which is not corroborating your clinical judgment, talk to the concerned pathologist and radiologist and ask them to repeat the test free of cost. This is my final slide. Take home message. Yes, you are a pulmonologist. You have to see the patient, all patients from during your initial phase. You may have to see the patient with eye problem. You may have to see some patients with ENT problem or orthopedic problem or so on and so forth. But try to dispose this type of patients after 1 or 2 visits and refer those patients to the specialist concerned. Always try to establish you as a pulmonologist. You will be your own boss. Nobody is there to dictate you. Offer concession to poor patients. Concession, you may reduce your fees half or 1/3. You may write to the pathology center to reduce the charges of pathology examination. You may even offer the free samples which are given from the pharma houses to the patient. This type of concessions are needed for the poor patients. Keep medical legal aspects in mind. This is very, very important, and that will be probably discussed in today's lecture. Take care of your own health. We know our life is very stressful. To reduce stress, we need to do regular exercise, at least 45 minutes a day, yogasana and pranayama. If you do, you will be relieved of stress and you will continue work for decades. Be famous a social personality, not a merely a doctors. People usually do not respect the doctors only. The doctors with social attachment, social acumen, they respect. So Not merely a doctor, your aim should be a famous social personality. If you do follow all these things, prosperity, honor, and satisfaction will reach at your doorstep. Thank you very much for your listen hearing.
Okay, thank you. One of those you missed it. Eta bondo rakho, slide. So that was really good. Actually, I was not aware that Monotos has been so much senior. It is very elderly wisdom, what he has said. But again, what he has said is true for any branch of medicine, as a whole medical practice. So thanks, Monotos. And again, there are very good stories. Actually, I have the talk next, but as the moderator, once I went somewhere and I saw that the doctor was not there. Why? Assistant said that he is busy at some other chamber 2 or 3 miles away. He came much later, and then I didn't ask anything. He himself explained, it is always good to keep few chambers, because one may not work, then you may work in the other. So if one chamber is not full, other chamber can be full. I said that is not possible. If one chamber is not full, then no chamber is full. And if one chamber is full, then other chambers will be overflowing. One chamber is good enough. One stetho is good enough. The rest is all in your hand. Actually, Monotos has been very pragmatic, very worldly wisdom. But before I start, now I am not the moderator, I am starting as the speaker. So before I start, I must tell you that I am a mad romantic. And I am passionate about pulmonology. So what I will tell now is pure hardcore, mad, passionate pulmonologist. Okay. So what we are, Partho give my topic, actually the topic is not written. It's a take on wide take. That's what it is, Partho. Wide take. Wide take on different aspects of pulmonology. What is the possibilities and what is the future? Let us start a little back. So, after independence, a young, impoverished nation saw a formidable enemy in tuberculosis, and they had to develop a dedicated subspecialty to fight that menace. And so came the subspecialty known as tuberculosis and respiratory diseases, as the most of the battleground in tuberculosis is the lung. But unfortunately, tuberculosis and respiratory diseases as a subspecialty never got uniform with mainstream internal medicine. It did not. So over the years, practitioners of tuberculosis and chest disease, that was the name that time, tuberculosis and chest diseases, they got alienated, angry, and arrogant. And that shackles were there for a long time. So these pulmonology specialties start with shackles around. And when in, say, late 70s, 80s, it was felt that tuberculosis is coming to a down. That was a wrong notion. We understood later. There was a series of books known as Progress in Clinical Medicine in 1979-80, regular year. And one was, I think I'm talking with pulmonologists here, yes? I am not talking for any other specialty. Okay. So in 1980, there was a book, Progress in Clinical Medicine. The preface, almost an editorial, was on pulmonary diseases. The editors, it's a global phenomenon, were very skeptic that after tuberculosis come down, what will happen to these practitioners of tuberculosis and chest diseases? That was the notion in 1979-80. And then when respiratory medicine started blooming all the over worldwide, so first skepticism was how many patients they will get apart from tuberculosis. My own colleague, actually we were 3 very good friends with legendary Professor Devabrata Sen. And we got actually options in both internal medicine and respiratory medicine. I opted for this naturally. And somebody said me, those days it was said, that you have only one disease, 2 lungs, and 3 drugs. Streptomycin, INH, what was that? Ethanamide. Yes, INH, ethanamide. I said to my friend, okay, just sit in our chest OPD, just discard all the tuberculosis patients, you need not see. Just see all other patients who are definitely not tuberculosis and just write a diagnosis. 70% got without any diagnosis. Those are not cases of tuberculosis. Those are all underdiagnosed respiratory diseases. So it started blooming against the skeptics, questionnaires, and then it was being said everywhere that knowledge of general medicine is mandatory for practice of pulmonology. Dr. Rupakos is here, he knew. I used to debate it every time. All the debates I was against. Knowledge of general medicine is mandatory for practice of pulmonology. Well, they don't say it for cardiology. Nobody said the knowledge of general medicine is mandatory for cardiology. Nobody said it for endocrinology. Why do you say it for pulmonary medicine? It is implied, that is very obvious. You have to, then knowledge of geography is also mandatory because you have been taught at some point. Knowledge of mathematics is mandatory. So again, that is your underrating of pulmonology. You are skeptic about own capacity on pulmonology and you are hunching on general medicine knowledge. So that phase passed. Then came critical care. It was blooming all over. Practically, when critical care came, the new term came, okay, one cannot practice pulmonology without a grasp on critical care. Again, an understatement. Because pulmonology is a much bigger thing, and it is getting bigger every day. So, critical care is good, will assimilate inside, but that doesn't mean that critical care is the crux of all, and then one cannot practice pulmonology without going for critical care. And then you know what happened? 2 things happened. One, in 1989, there was outbreak of nosocomial tuberculosis in New York and San Francisco. So nosocomial, that means hospital-acquired tuberculosis. And so the whole world looked back. They thought tuberculosis was still now a third world disease. There was a convention in Chicago just on this, migration and tuberculosis. And so the developed world woke up to the possibility of tuberculosis, drug-resistant tuberculosis, and there was marriage of molecular biology, the new world, with epidemiology, the old world. And the whole thing got a new boost because there are new stakeholders. The governments become oriented about tuberculosis and respiratory diseases, and the giant pharma companies came in support. We got funding, and there was a new life. So practically, the advent in molecular biology and imaging actually made havoc and critical care. So when I say that it's a wide take, the question is how wide? It is getting wider every day. So the immense possibilities are immense. And if I stay here on my white tech here, I am standing here with my white tech. That means definitely pleural diseases, pulmonary disease, different parenchymal lung disease, pneumoconiosis, lung cancer, and of course tuberculosis. I don't undermine myself that I know tuberculosis very well. Yes, I know it very well. And of course, the big chunk, the biggest chunk, undetected, undiagnosed, untreated, obstructive airway disease. Any 6 out of 10 in India is suffering from obstructive airway disease. So immense, huge, and it is getting wider day by day. So my take is stay here and you get entry everywhere. Teacher, anytime from this tech, this white tech, anytime. Actually, any white tech, any clinician, any pulmonologist is a teacher. Everybody has to learn from him. And he learns every day. The patient is the best teacher. Research, I think research is mandatory. Practically, research does not mean you have to go to the computer and do everything. Yes, computer is necessary. What you really know is to keep the data. So just documentation, keep the data. Again, if you don't get time or you don't have the aptitude to go for the analysis, somebody else will do it for you. So just keep the data, the documentation, somebody else will do the meaning for you and you will get it later. So ultimately this white tech means, number one, again, unfortunately you have to diagnose the patient. So ultimately it boils down to everything, diagnosis. And for diagnosis there are the different counterparts. One, history taking, the greatest art in clinical medicine for any branch of science. And history taking is not what the patient says, no. History taking is what you interpret of the history. And patient does not say it all. History is how the patient comes in, how he behaves, how he smiles, how he talks, small talks. কেমন আছেন, কি ব্যাপার, মেট্রো চড়েছিলেন নাকি? Just small talks. They give you deep insight about the disease. And many of the times, before doing examination, you understand what is the disease. And if you don't understand, very little chance you will understand it after doing all the examination. So history taking. And then, again, my very favorite, patient communication. Inside you are a detective, very shrewd, very rational. Outside, you have to be at the level of the patient. Outside, I am a villager, I am talking with a villager. Inside, I am very ruthless detective. I am dissecting everything. And then, clinical methods. Again, newer technologies are coming. I support them. Ultrasonography is definitely important. Bedside imaging is important. But clinical methods, because number one, they teach you rationality in medicine. Number two, they give insight to what we do in our everyday practice. And then, first assemble the data without anything. Just assemble the data. Just here is a computer. This is a computer. Just assemble the data. And then you discard the unnecessary data. That is the second part. You discard, this is not, this does not fit, this does not fit, this does not fit, this fits, this fits, this fits, and then you correlate them all and you get to a diagnosis. So clinical methods, patient communication, and detective, that is a rational deduction, this deduction. And then, as you see patients, as Monoto has said, you see one patient, he brings another. The best promotion is not by advertising, by patients. They are the best promoter of our practice. And then, what are the limitations? I must say something about that. Because in pulmonology also, you know, now there are scientific ways of deliberation. So there is a known thing as happiness index. So happiness index, how much happiness index do the pulmonologist have? And it is not very good. Not abysmal either, but again, I think cardiologists are well a bit above us. But pulmonology is not that down either. And what are the causes of lack of happiness index in pulmonologists? That also we tried. Number one is too much bureaucratic work. That is something which try to avoid, number one. And number two is overwork. And number three is lack of respect. It is written, lack of respect. That means if you have lack of respect to your own specialty, you will not be happy with your subject. So my white take, I will rather stop here because I am so emotional. If I start talking, it will be very long. But again, the limitations, almost none. Only two things you know, aptitude and skill. Skill we know, it comes with training, repeated training. Aptitude, we had a thinking that it comes within. You come here with aptitude for this and you start this, not the total truth. Aptitude develops and can be developed over religious regular practice. I have got it many times. Again, my students, some of them came to me. He was roaming from center to center and not happy anywhere. I said, okay, do one thing, just stay here for some weeks. Then it will be months, then it will be years. Then he never went back. So aptitude is not something, it comes very suddenly. Everybody understands Bengali here? হরিনামে কি করে ভক্তি জন্মায় তার উত্তর হচ্ছে হরিনাম করতে করতে ভক্তি জন্মায় অর্থাৎ প্রথমেই হরিনামে ভক্তি আসবে না। So you love pulmonology, you learn pulmonology. And as you learn pulmonology, you love pulmonology. All doors are open. The last one, in San Francisco, there is a big road. One side are the sex shops, full. The other side is San Francisco General Library and written open to all possibilities. So I tried, let us see how much it's open to all possibilities. It was. I was nobody with no identity. They didn't hold me. Just get in, you are welcome. And there are plenty of computers, just sit in, start it. Here is the password, you get in, you start, whatever you want to. Open to all possibilities. Pulmonology at the present moment is the exponential phase of the curve. It will develop very rapidly, very widely. My wide take is very limited compared to what it would be in the next 5 years. Wider to wider. Lot of there. And from there, at this position of wide tech, you can happen anywhere. You can go to Sandeep Salvi for collaborative research, staying at your position. You can go to AIMS to deliver your lecture, staying at your position. So every possibilities are open with this wide take on pulmonology. I don't see any further option for me at the present moment. But next would be Sandeep Salvi. My greatest regard, because actually the list of the best scientists all over the world, it includes 6 from India or 10? 10. You are the second or the first? Number 1. Sandeep, hats up. Clap for Sandeep Salvi. I assume that a few of the claps are is for me also, okay? So Sandeep, please.
Thank you so much, sir. I have always looked up to Dr. Ghoshal as a role model. And I think for anybody to become big in life, one big inspiration is always to have a good role model. And Dr. Ghoshal has been a mentor and somebody whom you always looked up to and said, I always said I would like to be like him someday. So I think that is very critical. It's important to have role models in your life. Why did I do research? How did I do research? And what did I do? I think these are the 3 questions that I'm going to address. My grandmother, with whom I was very close to, she died of lung cancer. And I saw her suffer. And I was asking, I was doing my schooling days at that time. Why is there no treatment for my grandmother? It was a question that I kept on asking myself and everybody else. And then my mother suffered from asthma. And I saw her suffer. I saw her cough the whole night. And she used to go to so many doctors. She tried everything possible, but no relief. So I kept on asking myself, why can't somebody cure my mother of her asthma? So those were the sources of inspiration for me to do something different than what other doctors did. So I became a doctor. I went into the specialty of respiratory medicine, perhaps largely because at the back of my mind, I wanted to find answers for the suffering that I saw of my grandmother and my mother. So that was the source of inspiration. When I started doing my post-graduation in respiratory medicine, I always said, I want to do research. And the reason for that, apart from relieving the suffering of not only my mother, but everybody else, was what would I do if I become a practicing physician? I would say I would see 20 patients, 30 patients, 50 patients, 100 patients a day. Over a period of time, how many patients would I end up seeing? How many patients would I end up serving? The answer would be some few thousands, some 10,000, 30,000, 40,000. But I realized that if I do research and if I find answers, I make discoveries, I make inventions, I will be able to serve millions and millions of people. So that was a lure for me, that I should do something that will benefit more number of people than what I could potentially do if I do clinical practice. So that was my second way of thinking. I became very passionate about respiratory medicine when I joined. My first post was as a diploma in tuberculosis and chest diseases. And it gave me a tremendous insight and a love for that subject. I worked very hard after that to say that I'm going to go into research and I'm going to do my PhD in respiratory medicine. And for that, I said, which is the best place in the world to do it? I realized it was the UK, because all the books that I read, the textbooks that I read, most of them came from the UK. So I said, I will go to UK and I will do my PhD. I want to do my PhD in asthma and find solutions to relieve the suffering of these people. So it is with that inspiration and motivation, I started applying for a research position after my MD in respiratory medicine. It took me a long time, but I persevered. I persevered and I said, I'm going to keep on trying and trying and trying and trying till somebody gives me an opportunity to say, come to UK and do research with me. It took me about 2 years, 1.5, 2 years. And believe me, at that point of time, there was no email. The only way you could communicate to the universities and to the professors was through the snail mail, air mail. You write a letter, post it, and then you wait for the reply from the other side whenever it comes. I must have sent hundreds of letters to all the universities in the UK requesting for an admission to come and do research over there in the field of asthma or any other respiratory disease. Failure, 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 failure. Kept on. But I kept on persevering because I knew I want to do that. I wanted to do it so desperately. And then one fine day, everything just opened. But it comes after a lot of hard work. And my mother tells me that, Sandeep, the only reason why you have reached where you are today is because of your perseverance. It is important. When you keep on failing all the time, it's very easy to get discouraged and say, okay, I can't do it, let's stop. But I didn't stop. I kept on till I got the answer for it. So I got an opening to do a PhD in the UK, worked in cutting edge research for 8 years, and then it opened a lot of other doors for me. Where have I reached so far? Well, I think I've been very fortunate over the years to make research my career. I spent more than 80% of my time only doing research or getting research done. I was very fortunate to get an opportunity to set up the Chest Research Foundation in Pune. It all happened. I had completed my PhD in the UK and I was looking for an opportunity to come back to India and continue with my research. Where should I do my research? Should it be in a medical college? Should I do research at the All India Institute of Medical Sciences? Should I do research at Indian Institute of Science? Which are the places where I can go and continue with my research? I was looking for those opportunities when I got a phone call one day from Cipla saying, Dr. Salvi, I'm so-and-so from Cipla. Can I talk to you for 5 minutes? I said, yes, of course. I said, Dr. Salvi, we are thinking of setting up a research institute in the city of Pune in India, and we are looking for somebody to drive it. Would you be interested in coming back to India and developing this Chest Research Foundation? It all happened. So the lesson that I learned is when you're very passionate about things, you want things very desperately, you will always get it. But the caveat for that is it has to be a desperate want. You must want it very badly. Then only you will get it. Others will not get it. Over the years, I've been fortunate enough in doing a lot of research, got a lot of recognitions, awards, had opportunities of traveling to 35, 40 countries as an invited speaker, opportunities of working with some of the world's best organizations and so on. If you do something with dedication and passion, I think any branch that you go, the sky is the limit, whichever branch you go. But it has to be with passion. And who better than Dr. Ghoshal? Even when he was talking about it, you could see the passion oozing out of his body, passion towards respiratory medicine. I think so that is so important. And that is what I see lacking in some of the youngsters, the passion to do something very different. There are two important lessons that I learned in my life during my research career, and I thought it's important to share it with you all. Very, very important lessons in my life. When I got the opportunity to go to UK to do my PhD, I was on the moon. I said, I'm going to do research in one of the best research departments in the world with Professor Stephen Holgate. He was the world authority on asthma. So I said, coming from a small city of Pune, I didn't want to feel little low in that department, top class scientists. I said, let me read everything that I can possibly can in the field of asthma, because that was going to be my area for research. I read every single book that I could get hold of on asthma. There's no internet at that time. There was no Google. There was no PubMed. It was all going to the library and going and getting those books. Going to the British Council Library, going to other medical colleges. Every possible book that I could get hold of on asthma, I read everything. And I had the confidence in my mind. Ask me anything about asthma, I know everything. Why? Because I really, really worked hard. I'm sure nobody had read as much as what I had read on asthma at that point of time. It is with this confidence that I went to the UK, to the University of Southampton, to do my research. I spent 8 years doing cutting edge research. As I said, I got lots of awards, distinctions, lots of good quality publications. And after the 8 years, when I was sitting on the plane to come back to India, I asked myself, what is the most important lesson that I learned out of my 8 years of research in the UK? Do you know what it was? The realization that I know so little about asthma. Look at the contrast. I went to UK with that full confidence. I know everything about asthma. Why? Because I read everything. Nobody has read more than me. But when I came back, it was that humbling experience that I know just so little about asthma. I think it is important for all of us to start realizing that we do not know much. We believe we know everything. We read all those big, big fat books. We pass exams with a distinction. We get a rank with the university and we suddenly feel we know everything. I think that's not the truth. The truth is a very humbling experience that we still need to know a lot more. So that was one important lesson that I learned in my life. The second important lesson that I learned in my life was a very simple real life example. I used to go home for lunch, and because my workplace was very close by, and I used to have my lunch in a hurry and then go back to work. So I had only about 15-20 minutes that I used to come home. My kids were in their second, third, fourth standards, and it was a summer vacation. And because in my society there were a lot of young boys and girls, kids, they used to come and play with my children. So in the afternoon they were shouting, screaming, running around, 6, 7 of them. And I wanted peace of my mind to eat my lunch. But I didn't know how to engage them. And they were shouting, screaming. So I said, okay, come on kids, come, all of you will come here. Let's play a game. I don't know how I thought about it. It just came spontaneously. So all these kids, 3rd, 4th, 5th, 6th, 7th standard, they came, they made them sit in front of me. And I gave every one of them a piece of a paper and a pencil. And I said, we're going to play a nice, very interesting game. So they got very interested. They got very excited. Uncle is going to play a game with us. So they said, Uncle, what game is it? So I said, this is a game perhaps you may have never played in your school or anywhere. I am going to show you an object. And based on that object, you have to write down as many questions as you possibly can. And the child who asks the most number of questions and the most interesting question will get a prize. So from my pocket, I removed my pen. I said, this is the object for the first game. You have to ask as many questions as you possibly can on the pen. Then the children said, Uncle, but we have never played this game before. I said, yes, but I think it's a very interesting, exciting game. But Uncle, do we have to give answers? I said, no answers. Only ask questions. Ask as many questions as you possibly can on the pen. So they said, okay, very interesting. I said, you have 15 minutes, and after 15 minutes, I'm going to take your papers. So the children started writing questions about the pen. Hari, how many questions have we finished? 3 questions. This is a competition going on there. Scratching their head and said, okay, I'm going to ask more questions. So the competition among the children started. 4th, 5th, 6th standard children. I want to ask more questions on the pen. At the end of the 15 minutes, when I collected that piece of paper from the children and I read those questions, I got a shock of my life. What amazing questions they had asked on the pen. If you found answers for those questions, it would take the pen to a different level. It is at that point of time I realized the value of asking questions. You know, our education system has only taught us to give answers, right from nursery till even your post-graduation days. Here is a set of syllabus that you have to read. You have to assimilate that knowledge. We will ask you questions, you have to give us answer. Your job is only to give answers. We are not taught to ask questions. And I found this exercise so fascinating. I said, this is the power of asking questions. I'm going to play this game every day with them. So the next day, anything that was lying around was the object for the game. So there's a potato lying on the table. I said, boys, this is the object for today's game. Ask as many questions as you can on the potato. And my God, what fascinating questions. Potato, simple thing like a potato. But look at the creativity that came out. And I think research, discovery, invention is all about asking questions. We are never taught to ask questions. We are only taught to give answers. That's where the major flaw of our educational system is. The apple fell on Isaac Newton's head. What did Isaac Newton do? He asked a question. Why did it fall on my head? What do most of us do when an apple falls on our head? We curse the apple, isn't it? We curse the apple. Why did it? I mean, we don't think about why did it fall on our head. In your daily practice as postgraduate students, there will be apples falling on your heads every day. The patient that you saw in your clinic, the patient that you saw in the ward, you did not know an answer for that. You did not know how to treat that. These are apples falling on your heads. What do? You curse. I don't know the answer for that. I mean, you will shout at the patient. Or you'll do something that, because you don't have the answer for that. But you'll not have the desire to find an answer for that. And that desire of finding an answer for a problem that you are facing on a daily basis is what research is all about. Finding answers to your day-to-day routine life questions. This is research. And I think your mindset now has to change. As doctors, we are trained, but I'm only going to offer services, no questions. Whatever knowledge I have, I'm going to use it in practice. But I think, sir, it is so important to have that realization that it's important to start asking questions for problems that you see in your day-to-day life. Stop cursing the apples that fall on your head. Start asking questions. I think I'm going to stop over here. And research is a fantastic field. I think I've been very fortunate, but it came out of sheer passion from my inner side. There are 60,400 respiratory scientists in the world. And I have been fortunate enough to be ranked number 79 in the world and number 1 in India. Why? I never aimed for it. I never wanted to be one of the best researchers in the field of respiratory medicine. I just did it out of passion. I just did it out of love for the subject. And when you do that, things automatically just keep on happening when you don't even expect them. So there's so much that you can achieve in this field of research. So I hope I have been able to inspire, motivate some of you all who are sitting here and at least start thinking on those lines, your mindset that research can be a fantastic career for pulmonologists. And perhaps I've been a fortunate example to have shown that. Thank you, sir.
So definitely Dr. Salvi has incited the researcher in you. But again, the hidden words, you have to be desperate. That's really needed. Number 2, hard work very, very hard work, failures, plenty. And so ultimately, you have to be ready for all this hard work, failures. But again, Dr. Salvi, you have been inspirational to the whole of the country. And I think youngsters have today, again, understood the passion in you for research. And as I said, again, clinical pulmonology does not have anything against research. It is embedded within. So every clinician, every pulmonologist can be a researcher as well. And actually, it's good to be a researcher. It gives extra meaning to his daily clinical practice. Okay, and also Thomas, who said this? Newton, no, Edison, Thomas Alva Edison, that genius is 99% perspiration and 1% inspiration. So now I will call Dr. Devraj, is he here? Now coming to the ground now. So Dr. Devraj will tell you, Dr. Devraj, come here. Corporate suggestions, how to engage oneself in a corporate practice. Dr. Devraj Joss, please. He is the brave new generation. He has joined Apollo.
Yep.
Yes, Apollo. He is DM Pulmonology, DNB as well.
Yes.
DNB as well. We have saw again. Actually, we saw Monotos very young because I didn't understand he has been that elder now. And I now know that Joss has been big enough to be counted. So Devraj Joss, please.
Dr. P.S. Bhattacharya gave me a topic that joining corporate hospital, my suggestion. So, am I the person suitable for this lecture? This is the big question because I joined in the corporate hospital for 3 years and I had experience of working in corporate for 4.5 years, 3 years as a consultant and before joining DM as 1.5 years as associate consultant. So probably 20 or 30 years down the lane, probably I will be the better person to talk on such a topic that joining corporate hospital. Now, this is the question that how to get selected for a corporate, where while I was working as an associate consultant in one of the corporate hospitals in Kolkata, so I asked at that time the medical administrator or the medical superintendent, sir, how can I become consultant? This is around the year 2014. So this is the three things which he told me, and after working for 3 years, I still believe these are the three things which will be required for getting yourself selected for a corporate hospital job. The first is that at that time I had an MD degree. So he told me that if you have certain degree, which most of the colleagues of your own branch doesn't possess, then you may have a certain advantage over others. So at that time, he told me that. Second, he told me, this is also very important, this may not look nice, but he told me if you have a good volume or good number of patients, so that you can bring your patients to that corporate rather than corporate giving their own patients to you. And third is that you have a father or your mother or parents or someone working as your partner. So if someone is pushing for you, so these are the three things only based upon which you can selected in a corporate hospital, and barring few exceptions or barring few other things, these are the things which still holds true in 2022 after my experience of working in corporate for 3 years. Now, first thing, because before working in corporate, my experience was around for 15 years in while doing the MBBS, MD, DNB, DM, as well as working as a house staff. Everything was in the government sector. So the first thing which I asked myself is regarding the academics, because before joining in the corporate hospital, I was working in one of the best DM setups in the country. So honestly, in my opinion, it can never be compared with government hospitals. So if any one of you, if any one of the young colleagues, if you want to pursue your career in academics, take my suggestion, work in a government hospital in limited setting. There is no comparison of government hospital with corporate hospital regarding academics. I have no confusion in my mind. It can never be compared with the government hospital. Yes, I agree with all of them ki Naimode, we also have 6 DNV candidates working with us, but situation may change in future, but coming in the coming 5-10 years, I do not see private or corporate hospital, however big it may be. Even in Delhi, I had the chance of going to the big hospitals, but if you compare with the government hospitals having DM fellows or those kind of, so that kind of academics can never be dreamed even of in the corporate hospital. Second is that this is deliberately why I did put this slide, is an interventional pulmonology. Nowadays everyone is talking of interventional pulmonology. This is a thing in which I think corporate hospital is a little bit ahead of most of the government hospital, because AIMS, PGI, Chandigarh or few other hospitals, I cannot take the example of only them. So in the corporate hospital, if you can generate revenue for the hospital, you can ask. This is from my experience, because if you can generate good amount of revenue and if you can justify why you are buying this kind of instrument, then you can buy newer things. So if you want to buy some things in the government sector, while I was working as a MD, my guide was Dr. Supriya Sarkar. He had such a horrible time because he needed to go to Shastha Bhavan, then to another, then principal was offended. So it was a very, in this, I do not know the present circumstances, but still from my experience, at any point of time, buying something or going for any expensive equipment is always relatively easier in corporate hospital. Now, there is a big but in this. You have bought a newer thing which you haven't practiced in your life, entire life. So then becomes a big thing. So if you want to develop any new skills, probably it is not the ideal place always. You cannot experiment here because you are charging for something. So you need to give a result also. So before buying a thing, also you need to be 100% confident of your skill also. So it is not that many a person thinks that we have this equipment, but you need to deliver at the same time. Now coming to the financial side, myself joined the corporate hospital honestly because of the financial aspect. I was brought up in a middle class family, so I wanted, and I went for this side only. So obviously you will earn more. There is no confusion in that you will earn more. Now there is a at one point of time I used to do practice in Barakpur, which is around 25 kilometers from the Kolkata. So the question is that whether you will earn more while you are practicing in a suburb area or corporate hospital straight away. My suggestion always will be to have a little bit experience before working in going straight away in a corporate hospital, because number one, you will have more volume of patients, because straight away when you are joining in a corporate hospital, don't expect they will give everything to you. So, and also there is everything requires experience. Okay, so you will be little bit experienced before going there. So always I prefer working in some small hospitals or small suburbs before joining straight away to a corporate hospital or before starting your innings. So past experience of working in corporate, it matters, because if you had the things are some little bit different, like things like how to chase your investigation, how to order your investigation, how to talk with the ward secretaries, how to get the things are little bit different in corporate hospital compared to the government hospital. So working experience in corporate, it matters, and at least some years of experience. Although in my case it was not that much, but I will advocate all of you to have some years of experience in corporate sector before joining, especially directly as a consultant. Now coming to a very important topic, a sensitive topic, is the intra and interdepartmental relationship. Now before joining here, I worked in NRS as well as PGI Rohtak. So especially in the northern part of the country, it was an amazing experience. They used to scold you, but at the end of that, everyone used to go to a center and then have a drink. So it was always better in the government sector rather than corporate sector. The question is whether it is competitive or not. So I will quote one thing. After joining in the corporate hospital in which presently I am working, I didn't have a good time for first couple of months. So I called my guide, Dr. Dhruv, and he told me one thing, that you need to take it as a, he was sometimes very blunt what he used to say. It may not look nice. He told me that you took it as an exam. You have to be competitive. It is not that everyone will have a warm welcome for you. So you need to be street smart. You need to be competitive. Take it as an exam that I need to be successful. So no one can help you in this regard, but you need to be mentally. So the intra-departmental relationship, although may not be warm always, on the contrary, in government sector, the interdepartmental relationship is not that great. In private sector, the interdepartmental relationship is probably much better than the government sector, contrast to the interdepartmental relationship. Now, there is another thing. There is a popular perception that does corporate push for revenue, does they will push for write some extra investigations or those kind of thing. So they will not say directly. No one in the corporate hospital in which I am working right now told me any day anything about them. But again, I am quoting the name of another great physician, Dr. Shyamashis Bandyopadhyay. Dr. Dhruv and Dr. Shyamashis are the two persons who helped me to reach at the present level in which I am right now. So Shyamashis sir told me one thing, there is no mark sheet here. It is not that you are scoring an exam, you will have an exam that you need to score 75 out of 100 or 50 out of 100. So your score sheet here is the amount of revenue what you are generating. So he told me that you should go to CFO at least every 3 months and check your balance sheets, that how much you are generating, because they at the end of the day will decide regarding you depending upon 2-3 things. If you are doing something which no one is doing, and second, so just you, after competition you may answer anything. So second is that that if you are doing something which others are not doing, so you need to be special also in this context, that if you are doing something which everyone is doing, then a third or fourth person will come some year down the lane, then they will select them because they will do something which you will not be able to do. Another thing, there is a popular misconception that don't do unnecessary tests and keep patient for extra days in hospital. At the end of the day, it is the word of mouth which is the most important. Patient will bring more patient. It is not that hospital will give you patient. It is your word of mouth. It is what the referring physicians have an assumption about you. So it is not. So at the end of the day, patient will bring more patient, and word of mouth is more important. Now there is another thing called as independence. So independence, I think, is much more in private independent clinics rather than corporate hospital. While I am practicing Barakur at my own clinic, no, I am not answerable to anyone. It is reverse is not true, because while I am practicing at a corporate hospital, so I am also at some point of time answerable to them also. But the more you will grow, the more you will become experienced, the more you have larger volume of patient, you will become more and more independent. Investigations and affordability, this is one thing I think corporate hospital, in some of the cases, I do not have the luxury of doing all those tests and all those things while I am working in a government hospital, because some of the facilities are not there. Second, the patient profile or the patient probably doesn't have that much capacity to do that kind of investigation. So in corporate hospital, probably we have the more luxury of writing and doing necessary investigations to clinch the diagnosis. There is another thing which many of younger ones used to love. It's a limelight, that the corporate hospital, due to their marketing, apart from that nothing. So you will definitely be more visible in television and printed medias and certain kind of VIP patient. These are only for 1 to 2 years. After that, these things will not matter anything. Now, medico-legal cases. Medico-legal cases, you need to be more cautious, because patients here are spending money. Some of them are corporate hospital. They will have lot of contacts. They will have lot of contacts with their legal friends also. So the medico-legal context, the corporate hospitals, you need to be more cautious. You always remember everyone is just trying to screw you. Be careful with all the files, documents. Nowadays, even while you are speaking, everyone is recording that also on the phone, and corporate will not save you. At the end of the day, you yourself need to be more and more cautious. So how long corporate will support you? This is another thing. As long as you bring the more patients than corporate gives you, you have a good relationship with all the corporate admins. Until then and then the corporate will support you. After that, not, because those who love soccer, they know that Cristiano Ronaldo wanted to depart from Manchester United this year. He didn't find any buyers. But Erling Haaland, that doesn't mean that Cristiano Ronaldo is not a great player. But at the age of 38 years, he didn't find any buyers. This is a fact. While on the contrary, Erling Haaland, or Kylian Mbappe, every club wanted to buy him. So this is a harsh reality. So success always is a relative term. One person's success may even be the failure of another person. This is also that while you are growing, some other consultant may have a lesser number of patients. These things are very common in corporate. And they were all told that they could not be successful. So there is nothing that you cannot be successful in corporate hospital or any kind of setup. So there is nothing called you cannot be successful. They all are told that they could not be successful. And one of the lessons that I grew up with was to always and true to yourself and never let what someone else says distract you from your goals. Thank you very much.
So, what corporate has done to Devraj, he has been much more confident than what I saw him say 10 years back. So, that has been done by the corporate. The external influence is really good. It has built confidence in you. But just one point I'll say about the limelight business, because Manodas also said this, influential people. It is always good to keep a distance. Because it ultimately always one has to pay for this. And you pay. The other people do not. So be very careful. Okay? Have a polite thing, not antagonizing them as possible. But again, suppose if you have to say no, saying no at the first instance is the best thing. Because it is very difficult once you say yes, then to say no in future developments. But and Dr. Devraj also has been very clear, honest and transparent that these are not all roses. There are hindrances, but again, there are hindrances in government sector as well. Actually, I lost my job because of developing respiratory care unit in NRS hospital. You are that time? House staff. You are that time house staff. I lost my job because I developed respiratory care unit in NRS hospital for the first time in state, and I was on the door. So, yes.
He developed the RITU at that time.
Yes.
4-bedded RITU.
Respiratory care, yes, respiratory RITU. And so I was on the door. So it happens, and corporate do it more subtly actually. Corporate do not do it that open, they do it more subtly. It's choice of yours. Okay, who is the next? Is Puneet Saxena? Puneet, please. You are going to speak on? Please. Puneet is again the brave new young generation. So we are looking forward.
Are the presentations loaded?
Yeah.
I don't think it's loaded yet. So good evening, everybody. It was a pleasure to listen to the previous speakers, especially Dr. Salvi, who has, I've grown up getting inspired by him right from my residency days to my formative years until date. He has always been an inspiration. And believe you me, he was the first person who told me after my MD that go for DM. He won't remember, but we were in Pune and we met at a conference, and he was the person who told me for the first time, go for DM, and then I started exploring the possibility. So I did my MD from Armed Forces Medical College, Pune, where Dr. Salvi was also there. And I did my DM from PGI Chandigarh. So the question that I'm going to try to answer is that why is it really important after MD, after doing everything, does it really make a difference? Do we really need to do it? Again, 3 years of struggle, another dissertation, another thesis, another entrance exam, another exit exam, a lot of humiliation. So is it really required? So let's see. So I'll just cover my talk into three things: why, where, and how. So first we go to why, the most important question, and the majority of my talk will be about why. So why do DM after MD pulmonary medicine or a DNB pulmonary medicine? We have done everything. We know all the skills. We know how to use our interventions. We have done some research. What else do we need to know? So the first question is, but the first reason is upgrade yourself. You have the knowledge, you have the application, but upgrade yourself, develop the core competencies, upgrade your skills, apply them under mentorship at an institute. And most importantly, what the previous speaker, Dr. Ghoshal also said, learn general medicine. So lungs as an organ would crosstalk with every single organ of the body. And as pulmonary medicine postgraduates, we somehow miss upon the non-respiratory diseases. And it's only after a thorough knowledge of general medicine and its practical application, then in true sense, you will become a consultant for the consultants. Because once you have a core knowledge and confidence in yourself about handling general medicine, that is when your gastroenterology colleagues, your cardiology colleagues, the other subspecialties, they will reach up to you, they look up to you for asking for solutions, and you'll be confidently be able to give them the solutions because you know what you're dealing with. So to learn this organ crosstalk, to learn general medicine is very important, and this is something that the DM tenure teaches you. When you do DM, it is generally a medicine unit where you do DM. So it teaches you and what you have possibly missed in your formative versus you cover up here. The next reason is learn interventions. So interventions are being done at every level, but surely when you go and do a DM, you go to a next level. Even the usual interventions that you've always been doing, you would probably unlearn and relearn because the level is different, the way you do them is different, and especially skills like rigid bronchoscopy and more higher forms of interventions are learned better at a institute in a trained manner. Obviously, I mean, you take a rigid bronchoscope, start using it, you will be able to do it someday. But to have a proper formal training program, to do it under mentorship, to know what is wrong, because you might do 100 right procedures and in the 101st procedure you may have a fatal complication because nobody ever told you that this can happen. So when you do DM, you are taught things in a protocolized manner. You learn the checklists, you know what to tick and what to cross. You learn when to do a procedure, learn when to not do a procedure. So this is something that I really I'm thankful that I chose DM and I went through this rigorous program to learn the interventions. The third reason is learn critical care. Again, critical care is part and parcel of pulmonology. A large chunk of our patients would be having respiratory failure, and if you can give a holistic approach to your patients, if you can handle your critical care yourself, if you can handle the sicker patients, you do not have to be dependent upon anybody else, then obviously you can give more holistic care to the patient. Your overall outcomes would improve. So learn critical care, there is the scope overall increases, be it the government hospital, corporate hospital, or any kind of setup. Having a good sound knowledge of critical care helps in the long run in managing your patients. The fourth reason is experience. This, though, sounds not very tangible, but it is really important because I got an opportunity to spend 3 years with one of the finest minds across. Not only my teachers, colleagues, but also my juniors and everybody around me. The technicians, the staff, the research staff, everybody around me, they were one of the finest minds. And 3 years when in that kind of environment, something grows inside you forever. And most of all, you get friends for a lifetime. So it was an enriched academic experience that you get during your 3 years of DM in a good institute with mentors and colleagues and some of the best minds around you. This is something which should not be missed, and it is worth every sacrifice. The next reason is something very important is research. So after I did MD and wrote a few papers, I thought that I know about research. But DM is when I started appreciating the falling apples. So this is where new avenues opened up for me. I really understood what research is, how to generate a research question, how to make a research plan, how to do. I did a lot of research under suitable mentorship with researchers like Dr. Ritesh Agarwal at PGI, and even the dissertation and everything. So after that, if one is keen to develop a career in research, there are avenues. There are avenues that are always open. But this 3 years of mentorship, it makes a lot of difference. And next, I come to something more practical, and that is the brand value. So MD and DNB are doing everything that a DM is doing, but so is a Galaxy phone doing everything that an Apple phone can, but Apple phone has got a brand value. So it does make a lot of difference, because when you go out into the open world, even in the government setup, I work in a government setup, and if my nameplate reads a DM, the patient would automatically want to knock at my door rather than anybody else's. So today's generation, today's patients, everybody is aware. They know that somebody who has done DM what is possibly knows something more than who has not, though it may not be true, but they feel that. So the brand value definitely increases in terms of getting a job, getting patients, getting seen. We become generally more visible. And remuneration always. I'm in Delhi, and in Delhi I've seen that even in corporate hospitals, if a person, two pulmonologists, one who has done DM and one who has not done DM, the remuneration is different. So it makes a difference. It's absolutely, it's something, it's a checklist which the administrators want to see. If the DM is there, there is simply a jump in the remuneration. And also in times to come, I mean, there are some great giants and gems in pulmonary medicine who are not DM, people who have been our teachers, who have not been DM. Those were different times. But now the things are different, that when you start your career, if you have a DM degree with you, you start with an advanced start, and it makes a lot of difference. You take off right from the beginning. And probably in the coming few years, it will become very difficult, especially in a metro city, in a bigger city, in a tier 1 city, it might become difficult to survive, because the DMs are going to eat up the career of MD and DNB residents, DNB professionals. So possibly it will make a difference in the long run. So therefore, I'm sure it does not make too much of a difference whether you do DM or not. In the long run, after a few years of practice, what my previous speaker said, the word of mouth is all that matters. If you're doing a good job, you will be recognized. Or if you're doing good research, you will be recognized. The degrees, the institutes, they don't matter in the long run. After 5 years, 10 years, everything balances out. It's your acumen, your skill, your way, the way you work, that is all that matters. But doing DM gives you a jump start. That is all. Maybe a few years you can jump start, and a few things which will probably last a lifetime. I do feel that it was one of the finest decisions that I made, and I'm thankful to all my mentors who pushed me towards it. Where to do DM? Well, there are many institutes now. When I started, there were only 2 or 3 institutes which are offering DM, but now there are a huge number of institutes which are offering DM, pulmonary medicine and critical care. And now you can choose whichever institute you want. How? Well, there are. Is there, sir? IG, yes, sir. Is there, sir? I should have kept Kolkata on top. Being in Calcutta, this is something that DM did not teach me. So how to do it? Well, there are entrance exams. So now what they've done is that there is a common NEET exam for all the institutes other than AIIMS and PGI Chandigarh. They have a separate exam. Other than that, all the exams are through NEET. So the thing is that, again, to crack the DM entrance exam, you have to know general medicine. Because pulmonary medicine you already know, but general medicine, a good sound knowledge of general medicine is important. That is what you need. And most importantly, what I learned, that it is important to unlearn and then relearn, because I had done pulmonary medicine, I had practiced for a few years when I went for DM. It was very difficult for me to first unlearn and then start relearning again. So you may be an associate professor in your own institute, but when you go to do a DM degree, you possibly have to learn that lesson of modesty, that humility, and start from the scratch and learn again. So, and it matters a lot in that if you maintain that humility, 3 years, try to absorb as much as you can, make mistakes, make more mistakes, so that you never make those mistakes after you leave that institute. So that is all that I have to say. And I'll be gladly be there if you have any questions to ask.
So this was really good. Now, it's a two-way process actually. As he said, You upgrade yourself by doing DN. And what is important, the department also gets upgraded when it caters to DM students. So any new course, any new student definitely is needed for the constant upgradation of a department. Okay, thank you, Puneet. Now, are there, I think there are two together, Sumon Das and Parijat Sen. Partho, were there? Online. Okay, then start it online. Whatever you do it here on the slide. Okay. Hello.
শোনা যাচ্ছে? Audible? Sir, can you hear me, sir?
I can hear you. Can you hear me as well?
Sir. Yes, sir. It's fine. It's working, sir.
Perfect.
We can go now. Yeah, we can.
Let me know whenever I can start.
So you can start, sir. That's fine.
Okay. Firstly, I want to wish you all good afternoon. Welcome to all attendees, panelists, guests at Pulmocon 2022. I am Parijat Sen, and I wanted to present this small session on being a pulmonologist in the United States. But before I start, I want to thank my mentor, my teacher, Dr. Parthasarathi Bhattacharya, for giving me this opportunity, inviting me to be a small part of Pulmocon 2022. So starting, what is the route to becoming a pulmonologist in the United States. So to become a pulmonologist in the United States, you first have to do a fellowship. And these are fellowships that are accredited by the American College of Graduate Medical Education, ACGME. And once you finish the fellowship, there's a certifying exam that you have to take. This is administered by the American Board of Internal Medicine. Now, in the United States, pulmonary medicine is a subspecialty of medicine, just like cardiology, gastroenterology, hematology. So it's an absolute prerequisite to do an internal medicine residency before you can go into pulmonary. And typically an internal medicine residency is 3 years. Once you've done the internal medicine residency, if you want to become a pulmonologist, there are a few options. You could either choose to do just a pulmonary fellowship, which is 2 years, or you could do the more popular route, which is the combined pulmonary and critical care fellowship, which is 3 years. Once you've trained in pulmonary medicine, there are options for additional training. You could do a sleep medicine fellowship, you can do an allergy immunology fellowship, and the more recently accredited interventional pulmonary fellowship as well. So now that you've become a pulmonologist, what are your career options in the United States? I like to break it down into 3 major or main career options. The first is that as a clinician. And as a clinician, you could either be in community practice, where you would be directly employed with a hospital, or you could be a part of a group of pulmonologists who run their own practice. And a lot of times you can be on a partnership track on that. You could also choose to be a clinician in an academic practice, which is often based out of tertiary care institutions. There you could do general pulmonary, or you could also choose to work on a niche area of yours, which could be asthma, COPD, interstitial lung disease, pulmonary hypertension, lung transplant. The next career option would be that of a physician scientist or a researcher. And as a physician scientist, you could either be into hardcore basic and translational science. Most of the individuals who opt for that option either have a background PhD or have spent significant time doing and training in research during their fellowship on a research track. The eventual goal of this career route would be to get funding from the National Institute of Health. A lot of them start their own labs with that funding to do their research. And most of the time, they're spending somewhere between 25 to 30% of their time doing clinical work, while the rest of their time is spent doing research. If that's not your piece of cake, you could still be a researcher and do clinical research, conduct clinical trials, do outcomes research, and you can still get funded, not necessarily just by NIH, but also through the industry. Last but not the least, you could have an option as a medical educator as well. And that could be either through graduate medical education, which means residents and fellows, internal medicine and pulmonary critical care. You could become a program director or an associate program director of a residency or a fellowship. There's actually an association of pulmonary critical care program directors and associate program directors in the United States called APCCMPD. They have their website. If you're ever interested, you can take a look. The other option is to get into medical education through College of Medicine to work with medical students. So you could teach them respiratory physiology, pathology, design courses for them for the first and second years, or be in charge of their clinical rotations through pulmonary medicine as well. And the career track along these lines could end up with you becoming a director of a course or even a dean of student affairs. So now that you know how to become a pulmonologist in the United States and what your options are, you can come back and ask me, why should I even choose that in the first place, as opposed to doing pulmonary medicine in India or so many other countries and options that I could go for? So what are some of the pros that I feel exist in doing pulmonary medicine in the United States? The first thing is that the training is very structured. So whether you're training at a small community hospital or you're training in a large university academic setup, the ACGME mandates that there's a fixed core curriculum that is followed, and there are mandatory rotations and amount of time that you spend on those rotations that is an essential part of the fellowship. When it comes to procedures with pulmonary, like bronchoscopy, airway exams, transbronchial endobronchial biopsies, endobronchial ultrasound, chest tubes, Plurex catheters, the ACGME sets minimum numbers that you need to achieve to be certified as competent in those procedures. And last but not the least, once you finish your fellowship, doesn't matter where you completed it from, everyone takes a single board certifying exam to be certified as a pulmonologist. We've already talked about the different career options that exist between academic versus private, clinician versus scientist versus educator. Another pro or lucrative aspect of doing pulmonary in the United States is the straight track to consultancy. As soon as you finish fellowship and become a pulmonologist, you are eligible to become a consultant, or as what we call an attending physician in the United States. Now, obviously, if you are in academic practice, you would have to still go through the hierarchy of assistant professor, associate professor, professor. But if you go into community practice, it's, such academic ranks don't exist, and you're a consultant, you're an attending physician. The United States healthcare scenario is very diverse. So you have people from different nationalities, ethnicities, race, background, and you get to work with them, learn from them, and train with them as well. Last but not the least, let us not pretend that economics doesn't matter. So the compensation for pulmonary critical care doctors is fairly good in the United States as well. Probably not as much as some of our other esteemed colleagues who deal with other thoracic organs, but I would still say that it's definitely around the median or slightly above it. So after listening to this talk, now you've decided you want to become a pulmonologist in the United States. You finished your medical training in India. What would be the path forward to make the transition? Well, the first step, you will need to get certified by the Education Commission for Foreign Medical Graduates, or ECFMG. For that, you will need to get your medical college diploma registered and acknowledged by the ECFMG. But after that, you take your medical licensing exam tests, the steps 1 and 2. Now, previously, they would have a clinical skills test as well, which was hands-on. You would have to travel to the United States to take it. Now they have terminated that. So these are all theoretical exams, which you can actually take sitting from India itself. Once you become ECFMG certified, now you apply for a residency through the electronic residency application system, or ERAS, to different programs. And from here onwards, the process is the same whether you're applying for residency or fellowship. Everything is through ERAS. So now you apply to different programs. They have downloaded your application. Some of the programs like you, so they've invited you for an interview. Since the pandemic, almost all interviews have exclusively become virtual over Zoom. So that has saved the applicants a lot of time and expense spent in traveling to different places to go physically interview. Once you've finished with your interview, now you make a rank list of your preferential order from your top choice to your subsequent choices. And so do the programs in terms of applicants. And now these lists are all fed into a computerized algorithm called the match. And through that, you are eventually assigned to a training program. You've listened to this talk, but you do not want to pursue a career in pulmonary medicine in the United States. There are still ways for you to engage with your pulmonary colleagues in North America. And the reason I use North America is because these organizations kind of cover both the United States and Canada as well. So the two main organizations that deal with pulmonary medicine in North America are the American Thoracic Society, which I feel is the larger, more international body. A lot of times they collaborate with the European Respiratory Society, ERS, as well. They do joint programs, they release joint statements and guidelines. Their annual international conference is typically in May, the month of May. And I feel it's a mix, it's an even mix between basic and translational science and clinical medicine. But the advantage is it is truly international. So there's a lot of international posters that are presented. There are international travel grants that are offered to attend the conference. They have different assemblies which give out international awards to pulmonologists and researchers from different countries outside North America as well. The other exciting thing that I like about ATS is their mentorship program, which you could apply for as a mentee, and you get assigned a more senior mentor who may be able to guide you in your career choices and path. The slightly smaller organization is, but by no means small, it's still pretty big, is the American College of Chest Physicians, or as we call it CHEST. This is a little more North America centric, and it's a heavily clinical organization. So they actually have question banks, they do board reviews, they do training courses throughout the year. And then they have their annual conference somewhere between October. This year it is in October, in 3 weeks or so. And the conference by itself is also a lot more clinical and educational. So there are a lot of interactive sessions, there are a lot of educational sessions, there's a lot more interaction between trainees and the faculty members. So look into these organizations. Even if you choose not to pursue a career in pulmonary medicine in the United States, you will still be able to engage with your North American colleagues through that. And with that, I will end my short presentation. This is my email. That's my Twitter handle. If you have any questions, thoughts, please let me know.
Anybody there? Live? He is present there? Okay, anyway, now he's gone. Dr. Parijat, are you there?
Yes, I'm here still, sir.
Okay, I am Dr. Ghoshal. Actually, you have shown the world of opportunity out there. Now it's for the juniors to seek options among them. Thank you. It was a very lucid and informative presentation.
Thank you. I appreciate the opportunity.
Thank you. Okay. So now, and actually it is being good. I see the crowd is getting thinner with every talk, but still Partha has done a good task actually, ensembling all the options there, and don't jump at a conclusion. You decide it in your own leisure time, which one will fit me most. Again, as I said, aptitude is not spontaneous. Aptitude develops on association. Is the presentation of Dr. Suman Das ready? Dr. Suman Das' presentation is ready, yes or no? Can we go to Suman Das right now? Okay, please, go on. Pardon? No, he's online, I think, Suman Das. So we'll wait for them? Okay, done. This is really a good opportunity. Actually, you are getting voices from all over the world. This is really good.
Sir, is this audible to you? You are not yet audible. Sir,
Okay. এবার শোনা যাচ্ছে?
yes, sir, you are completely audible, sir.
Okay.
You can go on with the session, sir.
Okay. I need to stay mute now if I'm on the session.
স্যার আপনি আনমিউট করে এবার বলতে পারেন স্যার, চেক করে নিচ্ছেন।
Okay. Is that all right?
Yes, sir, it's completely fine, sir.
Okay. Should I go ahead then?
Yes, sir, we can go forward with the session.
I'm going to close this one then. Okay. Hello. Hi, good
Sir, you are
afternoon.
audible, sir.
Okay, good afternoon. I'm Dr. Sumandas. I'm calling from Manchester in UK, and I'm a consultant respiratory physician in a hospital in the Greater Manchester known as Stepping Hill Hospital. My main work is in, well, I do everything on respiratory medicine, but I'm mostly on lung cancer. And I've been asked by Dr. Bhattacharya to talk about choosing a career abroad, in my case, in the UK. I'm not sure what kind of audience I have and who should I be directing to. So I'll keep it generic, more generic, but I will accept questions anywhere in between or in the end. Is that all right? So the UK training, both for undergraduates and postgraduate and specialty, is very similar to in India. Well, obviously has to be because it came from we had our medical education and the general education, everything we took it from the British. So but specialist training in the UK, there are multiple pathways to enter and progress in there, and that's what I'm going to focus on. And what I'm going to talk about is somebody who might be a generalist or have started their career in pulmonary medicine or pulmonology or respiratory medicine, whatever you want to call it. How can they enter to have a career in the UK, and how can they progress, and what do they expect here? So the physician training pathway, respiratory medicine is one of the group of specialties, which is called Group 1 specialties. And they all, the general trainees will have to go through this pathway where they do foundation training for 2 years after their medical graduation. So somebody who has done MBBS, they will be doing 2 years of foundation training where they go through both surgical and medical and other specialties, including general practice, psychiatry, and everything included. It is similar to house job or internship and house job in India. It's just been changed more recently, really, to be honest. About 10 years ago, it used to be called house job and all that. Then there is a selection process. Unlike in India, it's not exam based. It's more of what they have done and what they want to do. There are quite often some interviews, but it's quite informal type of thing. It's more of application, what you can put in the application. And then they enter into what is known as an internal medicine stage 1 training. These days they are called IMT trainees, internal medicine trainees. And that's for 3 years. I mean, you can do 2 years, but most of the people will do 3 years to be able to be selected for the next step, which is to the specialty. Now, somewhere while they're doing their IMT training, the initial training, it is very similar to doing MD in India. They are expected to get an MRCP degree by then. So 3 years is usually enough for that. And then they enter, they will have another selection process. Again, it's not exam based, it's more of competency and application based. They enter, they go into the specialty and internal training. Just a second, let me move this out of the way. Right. So once they get into specialty training, that is somewhere around 4 years. It's not very strict. Some people might take a bit longer, and quite often people are flexible trainees. They might like to have their family or something, and then they go into part-time and all that. That might take them much longer, but usually it's 4 years. So it's longer than in India in a way. Because in India, if you are doing a specialty training, it's usually not exceeding 3 years. And then you are eligible to get a specialist registration by the GMC, and then you can apply to be a consultant, which is similar to being a specialist. Now, I was talking about group 1 specialties. That includes acute internal medicine, cardiology, and it includes respiratory medicine, amongst others. Some specialists are not, some specialties are not included. Anyway, they are broad-based training, and the important thing to recognize here is that unlike in India, while we can do an MD in pulmonary medicine or MD in respiratory diseases and TB, here that specialty training is a continuous process, and that includes both internal medicine, that is general medicine, and the specialty. So somebody who is doing cardiology or respiratory or endocrinology will have to do their share of general medicine, both during training and being on call, and everything will include general medicine. Towards the end of the specialty training, they become more specialists, but usually they'll have to complete that. Now, coming to what we are interested in is where people can join in. Obviously, people can join in quite early, like if they have had their basic medical degree, that is MBBS, and then they have done their internship, they can join as a foundation year 2 trainee. So actually not they are here. So foundation year 2 training. So they can apply for the selection, and then if they're selected, they can join there. So it will be here. And that will mean that they have to go through the selection process to get into internal medicine. That mostly applies for people who are quite early stage in their career, like somebody who has done MBBS and has done their internship and want to join in. And if they're selected, then they can apply to the GMC for a GMC registration. And once they get a GMC registration, they can apply for their visa. Alternatively, people can apply to a junior clinical fellow post. Those people are usually who have done some respiratory medicine training or some other general, internal medicine training. And those, they can apply for a junior clinical fellow post, which is somewhere equivalent to IMT, slightly higher than foundation trainees, but depending on their competencies, they would be considered somewhere in between. The issue there is people can apply for those posts. They are not very frequent, and they are not formal training posts, so they are non-training posts. And possibly they will have to stay in that post as a junior clinical fellow for 1 or 2 years. And then if they complete, once they complete their foundation competencies, that is, they show that they're competent enough to qualify as a internal medicine, equivalent to a foundation 2 years training, they can apply for the selection and then try to get into the mainstream. By that time, they will be expected to do at least part of their MRCP before they will be selected, probably. Right. So the other group of people who might be interested in coming to the UK will be people who have got experience, who have probably done their postgraduate degree qualification in India. They might have been working somewhere as a consultant or a junior consultant, something like that. There is something called a Medical Training Initiative, MTI, which is sponsored by different organizations, and they accept trainee doctors from countries outside the Europe. I'm saying outside the Europe because European graduates can still apply through the mainstream. And they can either enter UK training at somewhere between junior clinical fellow and senior clinical fellow level. Senior clinical fellow level will be for somebody who with some experience and probably a postgraduate degree, or at least a couple of years of qualification in the specialty. And they can be offered a job for somewhere around 2 or 3 years, though most of the time the job is annually renewable. So it might say renewable at the end of the year following successful appraisal. So they have to show that they are doing well and progressing. And they will be expected that somewhere early in that post, they will be obtaining their postgraduate qualification. MRCP, by the way, is equivalent to a basic medical degree. It's not a specialty degree at all. Right. Depending on the post, they would still have supervision, training, career guidance, mentoring, and everything available, but it varies from trust to trust, hospital to hospital. Now, you might ask how to get through this. There are quite a few organizations who do these things, and you will see advertisements everywhere. For example, there is a association which runs the MED course. There are a few others like similar to that. They are all accredited by the Royal Colleges, and they have their own teaching program. And sometimes they lead to a degree, sometimes they don't lead to a degree, but they might be a good way to enter the system and then get through that. Right, an MTI course, as I said, once they're in the MTI scheme for 2 or 3 years, this is the site. You might like to copy it, or I'm happy for the organization, sorry, your yourselves to put my slides and send it to any of the people who are joining in. So you can click on that, and then this will talk about MTI thing, and then can tell you which are the accredited ones for the MTI scheme. So usually while they are in the MTI scheme, they will be doing a work somewhere between junior and senior clinical fellow. Towards the later part, they will be working as something like a registrar, like a MD, respiratory medicine type of, pulmonary medicine type of thing. Here we call it respiratory medicine, generally speaking. Don't call it pulmonology or pulmonary medicine. So they can enter postgraduate training, or they can apply for a specialist status through the CSER pathway. I'll come to the CSER pathway in a second. So CSER is Certificate of Eligibility for Specialist Registration. CSER is an alternative way to obtain specialist registration. Like my second slide, as I showed the flow chart, where I said how a regular trainee, like somebody who might have graduated here or might have graduated abroad, where they do their foundation year 1 and 2, then the internal medical training and then specialist training. And in the end, they get a specialist registration qualification, which means that they are registered like an MD or even a DM. But this is an alternative route to do that. So these are for people who have not done a GMC approved program, but they are able to demonstrate that their training, qualification, and experiences are equivalent to the requirement for the award of CCT. So what happens there is we need to get into the relevant postgraduate deanery, which is for respiratory medicine, will be the respiratory medicine postgraduate deanery, and they will have their own curriculum, and every trainee will be expected to do certain things and be competent in doing certain things at certain level. For example, somebody who has finished their training would be expected to be reasonably competent in bronchoscopy, reasonably competent to put a chest drain under ultrasound guidance. They should have thoracic ultrasound stage 1 trained. They would have seen so many patients. They would have general medical training, specialty training, and so many on calls and everything else. They would have been done their outpatient, inpatient, and everything. Now, the thing is that in this country, everything is evidence-based. Unless you can prove that you have done that, you haven't done it. So unless you can show that you have done, say, 200 bronchoscopies, or at least 100 unsupervised bronchoscopies. I can't remember the exact number now because it changes every year. It is not done. So problem about India is that quite often we don't have those evidence. Like we might not have a logbook, or even if there's a logbook, it's just a scribble, not clearly made. So that's the problem, that you have to be sure that you can provide those evidence that you have done enough of work equivalent to a postgraduate training here to be eligible for the specialist training registration. So there will be evidence of competencies, workplace-based assessment. That means day-to-day what you are doing, and then somebody needs to assess you and confirm that you have done that. CPD is continuing professional development. So you have to have been attending several lectures, both local and regional and national, or possibly international, presented there, doing some audit, research work. Now, research work is not so relevant in this country. People don't put so much importance in individual research. What they want you to do is that probably do some quality-based quality improvement project or audit, which is quite often local or sometimes national. Now, I have to say that despite all this, there are a lot of people who are competent NHS consultants. I've not gone through exactly this process, but quite similar. It's changed now. And if you go to this link, it will tell you the specialist application guideline. It will give you everything that you need to know, really. That's the end of my talk, and I'll go back to the main thing and ask if there is anything that they want to ask.
Hello.
Hi.
Dr. Sumandas, can you hear me?
I can hear you very well. Would you mind introducing yourself?
Okay, we are really thankful for what you said, because there are a lot of juniors here who are eager to know what are the procedures, and you have done it very lucid way, and it will save them a lot of effort so that they can try this route. And I understand that you are in Manchester now?
I'm in Manchester now.
Okay. And if you don't mind, can you have your email?
My email. I can
Yes,
give you
yes.
my email, but problem is that I cannot process anything. It has to go through a general route. I can only offer like general advice about in particular topics like getting visa or something, but everything is, has to be through the proper channel. So I can't really process anybody's or get somebody in there. If as long as that is understood, I'm happy to share my email.
Okay. So that is good enough. It is for just exchange, nothing to be extra. Everyone will try on his own. Thank you for having a very good talk.
Thank you. Anything else at all? Or should I come off?
No, thank you, sir. Thank you very much.
You.
For the rest of your life, and it's going to be something
just
which is
start about the
worthwhile
session.
after having done your PG. Good afternoon. I'm going to be talking on how we can motivate my young colleagues, how they can be motivated. First of all, I'd like to take this opportunity to congratulate all my young colleagues because you are now at a stage where you are moving in the career you have chosen. You are going to mold this for the rest of your life, and it's going to be something which is worthwhile after having done your PG. So what can I say really? I think the first important thing that I'd like to say in this era of investigative medicine is don't forget your clinical. I can give you a number of examples. The one is of a patient whom I saw many years ago, a CA breast patient who had surgery done, after which a PET scan was done. It showed multiple uptake in the left upper lobe, mediastinal lymph nodes, ileocecal junction, and this patient was told by the radiologist that she had only a few days to live. But the PET scan was not showing features which are classical site of metastasis of CA breast. And these were sites where you usually tend to see tuberculosis. So I told her, I don't think you have carcinoma, you have tuberculosis, start ATT. She did not agree with me. She went to Mumbai, met Dr. Wadia. A biopsy was done which showed granulomatous inflammation and she recovered. So clinical judgment in clinical sense is more important than by just reading the scan or the PET report. Similarly, you all know that all UIP pattern on CT scan is not IPA. If you see a UIP pattern in a young person, think of a CTD, and I can give you innumerable examples of antifibrotics being started and not making any improvement when this was a CTD related diagnosis. So these are important things that you need to keep in mind. Listen to and empathize with the patient. The other very, very important thing in this era of investigative medicine, we have forgot listening to our patients. And it's important for us to understand that if you listen to your patient, he is actually telling you the diagnosis. And this is another example of a girl I saw many years ago from Ajmer. She had episodic cough and shortness of breath in 2007, diagnosed with asthma and on treatment with inhaled corticosteroids and LABA combination. She has increased breathlessness over the past 1 month, which is not being controlled and was being referred for biologicals. She had bilateral polyphonic bronchi, there's a history of eosinophilia. As a matter of fact, her father said he had never seen her eosinophil count less than 10%. And she was seen in the OPD and advised as an add-on lung. The resident came to me for a second, and when I saw this young girl who was sitting quietly during the entire time the history was being presented, I asked her if she was all right and she had anything else to add. She looked at me and said that she had other problems which were always ignored. She had developed a maculopapular rash 3 years ago and was seen by a dermatologist. It was called a drug rash. She had weakness and decreased sensation over right foot, which was also thought to be due to the weakness of her being. This was her X-ray which she was carrying. EMG and nerve conduction showed sensorimotor neuropathy with bilateral median nerve, tibial and sural nerve involvement. Ejection fraction was only 42% with mitral regurgitation. This was the X-ray that we got done on that day. This patient had eosinophilic granulomatosis with polyangiitis. But if you look at the history, this was a classical history of EGPA. But no one had asked her the history and continued to treat her as asthma. So please listen to your patients. And are we really listening? To hear with thoughtful attention is what listening is all about. And there's a difference between hearing and listening. So I'm not saying hear your patients, listen to your patients. And I think that is active listening is important, and that is something that we need to look at when we look at our patients. Note all the cues. Sometimes patient tells you more by the expression rather than the history that the patient is giving, and respond to the feelings of the patient. So active listening is difficult work, and it requires not only listening but a lot of other activities. And this is a case of ILD, a patient on oxygen therapy. Again, by listening to these patients, you're able to understand the quality of life that they're. That also helps. So why are we not listening to our patient? And this is because we have had a paradigm shift in the practice of medicine. We have moved from clinical medicine where doctors spend a lot of time listening to the patient to investigative medicine where we spend more time looking at the reports and listening less to our patient. So I would really advise that if we go in for patient care, academic career, please do listen. And this is something that we need to do very, very sincerely. A lot of data suggests that this is not being done as sincerely as it should. And important to treat the patient and not the disease. Listen to the problems. Often we get focused on making a diagnosis and treating the diagnosis rather than treating the symptoms of the patient, and they get neglected. And that's why patients stop treatment because they feel that, okay, I have a diagnosis, but symptomatically I'm not improving. And that is another very, very important. Then empathize with the patients. I had a patient in PGI who had chronic empyema when I was a senior resident. And because I empathized with her, spent a lot of time with her, she still follows me. And I moved from PGI to Delhi, and it's been a long time, more than 30 years, but this patient still comes all the way for a regular follow-up. And I was just a senior resident at that point in time. I have patients from Kurukshetra who used to come from Kurukshetra to PGI. Many of them come and see me now in AIMS just because you are able to empathize with them and listen to them. So number of patients that I can give you who have been your followers because you have listened to them. So please listen to your patients. I have listened to my patients and learned a lot from them. So a good physician treats the disease. The great physician treats the patient with the disease. Remember that. That is very, very important. The other tricks is learn by teaching, and I would really say that teaching is something that is very, very important. Never consider it something that you cannot do. I would say even if you're in a non-teaching institute, catch hold of people and start teaching. It really increases your knowledge. The joy of discussion and understanding and interacting is something that you will really find very, very rewarding. Remember, every patient teaches you, and therefore don't be afraid to ask. That is also something that we need to keep in mind. it's very, very important that we ask our patients, talk to our patients, and that is something. Get involved in research. Many people say, why should I get involved in research? I am a clinician, took up medicine to see patients. Why should I do research? I am a surgeon, wanted to get my hands set for doing good surgery. Why should I do research? I am an interventionist. I want to do there and do a number of procedures. Why should I do research? I think it's very important to understand why research is important. And I did ask these very questions. These are two people. Can you name one person? He is a 22-year-old medical student and he isolated insulin with Sir Frederick Benting. This is Charles. And there are innumerable examples of medical students and residents who got involved in research and did path-breaking research, whether it be discovering islets of Langerhans or being involved in various other nerve transmission studies which were even done by students when they. So what is the role of research in today's medicine? Important to remember that half of what you learn in medical school is dead. The trouble is no one can tell you which half of it is right and which half of it is wrong. Much of what is wrong may change within 5 years of graduation and post-graduation. Medical research is advancing at a dizzy pace, and that is why it's important for us to get involved. Because the best way of learning about medical research is to dive right into it and perform medical research as young research. And it really helps in multiple ways. It helps to build up a spirit of inquiry, inculcate interest in taking up academic career. It helps to build an opportunity to attend meetings and conferences like this one. There are better career prospects, and it can also lead to meaningful science. So research actually and teaching all inculcate a spirit of inquiry. Every patient you see is a source of new information and new knowledge. He teaches you, we must learn to think, reason and analyze what we see and hear. This is also research. The process of exploring, evaluating and trying to find a solution to a medical problem can be very rewarding, and this is also research. So it improves critical thinking, it helps us to deep dive into the subject, and that is why research is very, very rewarding. I would say that if you are looking for an academic career, be involved in teaching, be involved in research, because this is something which is very, very exciting, thrilling, and once you are hooked, you are going to be hooked. There are a number of studies which have shown the value of medical student research. This is an old paper from Stanford which showed that everyone who's involved in research taught them to ask questions, review the literature critically, and analyze data. They said the experience motivated them to pursue further research, and 60% indicated they planned a full-time academic career, and 75% had at least one published manuscript, and 52% had presented. But what is important, and this is shown in this paper, that scholastic performance and research experience during medical school leads high attainment of faculty rank over 20 years in the future. So if you want to become a faculty, if you want to have a scholastic performance in the future, it's important that very early in your life you get involved both in teaching and in research. It's important that you look at research in a stepwise manner. Don't try and do things which are not possible, which disrupt your core curriculum, and has to be done with proper supervision. I think that is something that you must. So be a Sherlock Holmes. See, you see, but you do not observe. To a great mind, nothing is, and therefore, imagination is the highest form of research. Finally, I'd just like to say, be ethical. The practice should be ethical because that will also be something that will give you a lot of satisfaction.
Sir, it's completed, sir. No, sir, he is not. It was recorded. Okay, okay, okay.
Be ethical. the practice should be ethical because that will also be something that will give you a lot of satisfaction. Be ethical, the practice should be ethical because that will also be something that will give you a lot of satisfaction.
Good afternoon, dear friends. Over next 10 minutes, I shall be discussing and talking about opting in a subspecialty of pulmonary medicine, how to choose. First and foremost, we must look at it, how respiratory medicine has evolved over a time. Only then we shall be in a position to find out which subspecialty to be selected. Now, before 1970, if you see when you talk in terms of sanatorium, the evolution of the specialty is intimately related with tuberculosis. In fact, the history of TB is the history saga of the elevation of or evolution of modern medicine. Gradually, from the sanatorium, we progress to tubercular hospitals. Then the specialty become TB and chest diseases. Then they change the suffix and prefixes, and ultimately, in the first decade of the century, started calling as a respiratory medicine. But there have been multiple names which have been given to it as a thoracic medicine, pulmonary medicine, and obviously, as the things have evolved over the last 50 to 60 years, and particularly last 2 to 3 years because of COVID epidemic, we realized another importance of the specialty of acute respiratory failure and the people requiring multidisciplinary approach. Therefore, thus, a transatlantic divide can also be seen in it, where in USA, they were far more progressive and forward-looking, started calling it a pulmonary and critical care medicine, besides the specialty of a subspecialty of pulmonary medicine. Whereas in the British Isles, as in the Europe, respiratory medicine tends to be little dehyphenated from pulmonary medicine, but both are integrated part. And in Indian context, from the TB today, if we are talking about subspecialty, it means a significant evolution of specialty has taken place. But unfortunately, instead of subspecialty, it still continues to be a broad specialty. And the time has come where pulmonary medicine itself has to be considered a subspecialty of internal medicine rather than as a specialty. Only then the topic which we are discussing today is relevant. When you look at the spectrum of diseases which we see today, as I said, we started from tuberculosis, then we started looking at asthma. Initially, we thought that it's a pulmonary disease, but now we know the systemic manifestation. So organ crosstalk is important, and same is true for pneumonias and bronchiectasis, where we also see the suppurative lung disease in the lung, but at the same time, consequences could be multiple systems, including amyloid kidney. Then in late 80s, late 90s, people started talking medicine itself has to be considered a subspecialty of internal medicine
rather than as a specialty. Only then the topic which we are discussing today is relevant. The suppurative line reported from Canada. Tuberculosis, we thought that we will be able to win over it. Government of India has started very ambitious program, but we are still struggling. And now whole emphasis is to take care of preventive curative medicine treatment, as well as how to handle, how can we handle multi-drug resistant TB. Metabolic diseases are nothing else but a significant amount of it is related to breathing issues or multiple metabolic problems which happen with obstructive sleep apnea, which combines multiple subspecialties of internal medicine, be it cardiovascular, be it endocrine or metabolic, or be respiratory, especially with sleep disordered breathing. Now, the present day scenario with which in India we are practicing is that pulmonary medicine, we have different domains which are helping us in allowing the diagnostics, which could be radiology, pathology. We need sometimes surgical support from the thoracic surgeons, which are very limited in most of the institution. And critical care is a domain where people have been trying to elbow there, trying to squeeze into it with anesthesia and internal medicine, paramedics and physiotherapists, and ENT, especially when you're talking about allergy immunological disorders, as well as when we are talking in terms of sleep apnea syndrome. But particular interest, if you ask me, is a critical care. When we try to say it's a pulmonary medicine or internal medicine, primarily it's an internal medicine where we need to act as a subspecialty of a broad specialty. Obviously, these are the various degrees which are being given in our country, and the highest level is given DM degree. And what is interesting is that the qualifying exam is not only the NEET, but in the qualifying the broad specialty, unfortunately, again has been kept respiratory medicine, where it seems that our experts are not in tune with time. I'm sorry to say that, but it is the internal medicine subspecialty. Therefore, when we are going for the entrance examination, probably you can have a super specialty, subspecialty component as a pulmonary or a critical care combined together with a base specialty as internal medicine, because that is what will give you an insight into it. Organs don't work in isolation. I think that is important. And we need to be sure of it, that when we practice medicine today, tomorrow, or respiratory medicine tomorrow, we work at the baseline as a general physician, aware about most of the things, and then we come to the subspecialty and then subspecialty. So it should be a pyramid rather than we only focus simply on subspecialty, which is important. But having said so, it is important to realize it that subspecialty cannot be practiced in isolation. Now, what is desirable today is a multidisciplinary approach, where even if we practice subspecialty of a subspecialty of a pulmonary medicine, we should be able to integrate with our colleagues from other specialties, or even within pulmonology, expertise of a different individual should be taken advantage. For example, in my department, we are running a full-blown clinic of lung thoracic malignancies of the lung cancer. So all patients we are referring there so that an expertise is built up. We look up difficult airways, so we are referring all patients to difficult airways. Similarly, we are running DPLD and a post critical care clinics where we refer the cases so that expertise is there and students are they are posted the DM fellow across the board. Therefore, it is important that whatever subspecialties in the subspecialty we choose, we need to work in tandem and in close association in a collaborative way with our friends and colleagues. There has been a significant advances in diagnostic tools which have taken place, and that is what is telling us, and that is what is creating subspecialty. Like in cardiology, first we have subspecialty of cardiology. Later on today we talk in terms of thereabout in electrophysiology. There we talk in terms of cardiac diagnostics. There we talk in terms of cardiac failure, etc. So the multiple things have evolved, whereas the general at the bottom line, they all practice as cardiologists. And also this is coming up the era of precision medicine. So we need to develop treatment and therapeutics and diagnostics which pinpoint the diagnosis, and that is how a subspecialty and the patient management is evolving over a period of time. Now the subspecialties of pulmonary medicine, when you look at it, could be because of airways, where we have started with an asthma COPD, bronchiectasis. Today we are adding small airway disease. If I add to it, probably, though it is a systemic disease, maybe a cystic fibrosis. Allergy immunology, again, you will see an overlap with asthma is there, but this is a specialty in itself and is evolving over time. You have those breathing and sleep disorders. I've combined these together, though we are talking about sleep apnea. Primarily, you will see in hyperventilation also. You can have central sleep apneas, you can have peripheral, or you can have obstructive sleep disorders. Therefore, they work together, and obviously, the management to a very large extent depends upon it. Besides pharmacology dominantly as of today, again, it's a multidisciplinary approach, is a ventilatory, non-invasive ventilation, CPAP, what you call as a PAP therapy. Critical care medicine, I think all of you are aware about it. It has evolved, and obviously this is one subspecialty which tread the toes of large number of subspecialties of internal medicine. But nevertheless, it is important for us to understand that respiratory system plays a huge role, especially management of respiratory failure. But management of respiratory failure cannot be in alone without understanding the pathophysiology and disease processes in other part of other organ system. Diffuse parenchymal lung disease again is the one huge area which has evolved in our country. So people have been called, I've deliberately written pulmonology. Similarly, rheumatology, they write rheumatopulmonology. Therefore, it has a lot of overlap with subspecialty of rheumatology. Environmental and occupational disorders, all of us know about pneumoconiosis, silicosis is one of the prime example, asbestosis, it is there. And air pollution, I think we cannot put it under the carpet, and that is becoming a very big role. Therefore, I think some of us need to take up this particular subspecialty, which has a global health and public health implications. What I am seeing is a lot of youngsters are going towards interventional pulmonology. And one of the major reasons for DM in pulmonary critical care, or whether you have done an MD in respiratory medicine, people are looking forward to. Infections continues to play a major role. TB, though, has a very large extent gone to the public sector, but other multiple infections. Especially if you see, I've written pulmonary arterial hypertension, primary and secondary, if you can put it into that way. It still is in the domain of cardiologists, but this is one area where we need to work it up, and we work very closely with our colleagues from cardiology. Rehabilitation and palliative care is load is there. Oncology, so much of load is there. Similarly, post-COVID, we had succor to our patients. Thoracic oncology, the lung cancer, the pleural diseases, etc., has again gradually picking it up, but by and large has remained in the domain dominantly with the medical oncologist or people with the radiotherapy. But I think this is one area. And I've kept another specialty which is going to evolve, that is thoracic diagnostics. In thoracic diagnostics, you can have radiology, you can have a pathology, and you also, along with have an ultrasonography, which is going to act, or which is already acting like a virtual stethoscope, which all of our pulmonary physicians must be there. Therefore, the question is, you will say we know about it. The one which are actually in the board are commonly practiced today in Indian context. Sleep medicine, though, is evolving, but still more number of people have started taking up. But again, I am seeing not as much our pulmonologists are interested. Critical care medicine, if you want action, you enjoy it, that is one place which is there. But yes, I do agree that there is a far higher number of burnouts out there. Diffuse parenchymal lung disease, again, has been picked up, and both respiratory societies, ICSS, NCCP, and institutions have played central teaching training institutions like CAS, AIMS, or PJ have taken a huge role, or CMC Vallabh. Interventional pulmonology again has picked up, especially you see the youngsters over last particular point of time. One which I have forgotten to put it up is a lung transplantation. Now that lung transplantation has taken up and is gradually picking up, And that is an area which was not written here, which was not practiced in this country. And now we have got nearly 8 centers. In my own state, we have given approval to 1 center. And in coming years, you will see more and more people going for the lung transplant. So one of the important evolving specialty is in lung transplant, where you need a team between a physician and a surgeon. And the physician has to be a pulmonologist who is well trained in immune diagnostics, immune pathology, and is a competent intervention pulmonologist. Therefore, point I'm trying to make is, even if you choose a subspecialty, basic knowledge of pulmonary medicine is essential. And when we talk about pulmonary medicine, basic knowledge of internal medicine is essential to practice these conditions. In cases of asthma, now we are going through precision diagnostic. We're talking about molecular COPD, we have systemic effects. Therefore, though we may present or treat them in isolation, but you need an expertise. That's how we are now talking in terms of small airway diseases. So this is the critical care ICU. That's what we are practicing at Rohtak. And here you need to be trained. If you're not good in critical care, probably you're dealing with intervention pulmonology will also be faulty. Now, this is the non-invasive mask which we are using it up. It's a helmet in patients of acute lung injury, which took place in patients of COVID. E-electronic ICU, again, is a step. So the technology is picking up quickly. And interventional pulmonology, you're talking diagnostic, therapeutic, and research advances. Diagnosis, most important when we are looking at it, is EBUS, which everybody wants to do. But for God's sake, first learn basic bronchoscopy, basic procedure. Then you think in terms of going EBUS. That is important, and you know why you are doing so. What I have seen is that everywhere you want to do EBUS, no, that's not an answer. First, you understand basic bronchoscopy, get trained in the TBNAs, and then you go and gradually shape up to the EBUS, because it's not cost effective in all conditions, but it's an excellent tool when you are looking at mediastinal evolution. So managing technology requires a social conscience to judge what is only marginally beneficial and what is medically necessary. When I asked my residents, they were all studied IP in terms of therapeutic and putting stents and all. Suddenly they realized and they said, sir, with an experience and height set of 3 years, probably it is minimally effective. I'm not going away. Dominant role of IP today also continues to be diagnostic and therapeutics, especially foreign body, or if you are having resection of benign tumors. This is what we are doing, interventional pulmonology at Rohtak, and this is the interventional pulmonology. You have got a pleuroscopy, which have got a significant, playing a good role in diagnostics of undifferentiated pleural effusions, etc., and also pleurodiscs. Sleep medicine, again, is the one where you can choose it up. So you have a spectrum of diseases, understanding all organ crosstalks, I'm telling. And you need to know also burden of disease in the country, and you realize clean air is a problem. And in India Gate, you look before and after it, what is happening before Diwali, after Diwali. But that is the point I'm trying to make. When you're choosing a subspecialty, there's a wide gap in service. So general pulmonology is the primary need. And then when you are looking at it, there is also a wide gap in the society need requirement. So first and foremost, practice general pulmonology. Then depending upon your area of interest, A, and B, what you are interested in. Is it the action gives you a pump in adrenaline and you think that's your domain, go for IP. If you feel that seeing to it that the people go back to their health, and that challenge is how you can handle emergency medicine, go for critical care medicine. If you know technology is your domain, then probably you shall be looking at it. I will simply say that pulmonary sleep is one where we are seeing a lot of technology is coming into play. We can do it from a distance, or thoracic diagnostics also in terms of pulmonary function testing, etc., can help you practicing that. And if you feel you need to the top edge, probably you can do much better, like in end-stage lung diseases, which are there, which are coming up, then probably lung transplantation is there. In between, if your interest is in environmental disorder, it all depends on how you want, what are your problems. Therefore, what is very important, my dear friend, is understand the current and future need. Ask yourself what you want. You can shift. The good part of pulmonary medicine is you can shift as per your age, as per your interest, and you can change gears and can practice. Ask yourself what you want. Patient advocacy, right, and safety should remain a in your mind all the time, but you need to be ready for the technological advancement, move out of the shell and learn to collaborate whatever the subspecialty you practice. You need to open to people who share common interests and need to create training and education modules, the areas which you like, so that you can mentor more people to come and join. Thank you very much. And I will be more than happy to answer any of your questions. Thanks a lot.
So it was a recording?
Yes, it was.
I don't think Dhruv, are you, no, not
Ah,
like.
sir, good evening. Dr. Ghoshal, sir, good evening.
Anyway, so ultimately what Dhruv has said, summary is, all subspecialties are interrelated. So you cannot just focus on one without having a grasp of the other things. And he has also said it should be socially relevant, how much you are using and what you are using. So that was good. And now we move to Dr. Lakshmikant. Lakshmikant Baburao, please. We have two more, Krishnendu Mukherjee and Biswajit Shukul, that will be on the medical legal aspects.
Congratulate Dr. Parthasarathi for keeping such an interesting topic, and despite overshooting by more than 1 hour, still at least 6-7 people are still interested and sticking to the chairs. That is something which is very, very commendable about Dr. Parthasarathi Bhattacharya. So I'm going to keep it very, very short. I have been given some topics. I'm going to finish one in one slide. So online consultation. So is it feasible? Can it replace in-office consultation? How to utilize and do I do it? These are the 4 questions I would ask. The answers to this question are yes, it is feasible now. The COVID has taught us that online consultation is very much feasible. However, can it replace in-office consultation? Definitely not, especially if you go to the other side of the hall and ask them, can I do online consultation? Whatever you are teaching me today, can I do it all online? Definitely not. So it definitely cannot replace. How do we utilize it? This is small subset of patients where I think we can try and utilize it. However, you have to know your patients very well before you are actually resorting to it. Do I do it? I actually don't do it, even for follow-up patients. The reasons are different, but I don't sort of resort to it. Medical writing, again, this is one of the option. Is it really optional for us? I think no, it is must for everybody. We should try and write. All of us have enough material to be written about, and even if it won't change the practice immediately, that is what we try to expect when we write something, but at least it will be a hypothesis generating and will form a benchmark for others to come and do further research. So the only request in this area is try to contribute to society. Don't seek glamour in writing, medical writing. If you are looking for a glamour in medical writing, I think then you will not be satisfied at all. I have no experience at all whatsoever. So I'll possibly skip this, and in the interest of time, I would not invite anybody's opinion also. Telereporting, this is something which I had thought as a career when I was doing MBBS. I was a nocturnal animal or human being at that time. So all of my training years I have studied during night and I have slept during daytime. So I thought that is the best I can choose for the career. I can do tele-reporting for US people or UK people in the night, and I can just continue with that lifestyle. However, I did not like radiology much, and I went into medicine. So it is feasible and viable only in radiology at present is what I feel. To some extent feasible in sleep medicine and maybe in pulmonary function laboratory only if our colleagues acknowledge the deficiencies in knowledge gaps and if they refer you the right patients. If that is not going to happen, then this is not viable. One of my colleague has actually trained a technician from AIMS Bhopal who does this online reporting of sleep reports or polysomnography data. So that is something which can be done, but again, not for the prime time yet. Others, so I must congratulate the imagination of Dr. Parthasarathi Bhattacharya. If he cannot think of anything else to be put in that list, I don't think I can even think of. So I don't have anything much to add to whatever has been given to me. And with that, we come to the conclusion of my.
Okay, Lakshmikant, you have been very brief and very fruitful, I must say. Just one question. You really want to resort to medical writing for everybody. I agree with that. What is medical writing if it cannot get published?
No, I'm not saying don't publish it.
No, no.
Write and publish it. Yes.
It's difficult to get published, isn't
Yes.
it?
Yeah, definitely. So, in the interest of time, I did not go into details of that. Whether it gets accepted and gets published is different issue, but at least you should make an effort. So, see, for example, if I had to give an example, the most I have learned when I was doing my MD as well as DM, mainly MD in PGI, was when I was writing discharge summaries, when I was making presentations for the weekly presentations, and when I was writing death summaries for patients who were to be discussed in mortality meet. These are the three instances which have taught me more medicine than any of the clinical rounds in PGI has taught, because that is the time when you sort of go from the initial presentation to the end result, what has happened in one go. So that over 2 hours time you sort of review entire case history of the patients, and along with that, along the course, you review all the diagnoses, the diseases, the treatment of the diseases, how they are interlinked to each other, including diagnostics as well as treatment, and how they can have a lot of complications. So this is how. So if you start writing, even if it doesn't get published, still it will teach you a lot.
Okay, thank you. And also, actually, medical writing is a career now. At least we don't do it much, we clinicians, but few streams, particularly dentists, pharma people, and some pathology people are taking medical writing as their career option. They write for pharma companies, even they write for us. We make guidelines and we give them for medical writing. And they make it the whole thing and bring it to ultimate editing we do, but the basic writing is done by the career driven medical writing people. So it's quite achievable. Okay, now I don't know who is there, how to get Dr. Krishnendu Mukherjee and Biswajit Shukul in the fold. Will come here? You can go there. And what are the questions? তাহলে কি করবে আপনারা না কিন্তু কোয়েশ্চেন এখানে আসতে হবে না প্লিজ ডু
Basically, we are using the term medical legal.
আপনারা ভালো করবেন যদি দুটো চেয়ার দুদিকে নিয়ে নেন এখানে ওকে ইউ ডু
Basically, we are using the term medical legal. We are using the term medical legal issue. So, what is medical and what is medical legal? Because we are discussing about the medical legal aspect. The medical and medical legal is that suppose there is one injury. Doctor examined that injury and he suspects some foul play is there, either stab injury or gunshot injury. Then it is his duty to inform the police, because that injury needs investigation by a law enforcing agency. To fix up the legal responsibility, the case become medical legal. Medical থেকে medical legal হয়ে গেল। আমরা আজকে medical legal নিয়ে আলোচনা করব বলে এটা বললাম।
Yeah, I think we are short of time anyway, so let's get on with it. Now, I think this session has been planned in an interactive fashion. We already have been given some questions, and I think we can handle the questions alternatively. Right, so a patient has a cervical and mediastinal adenopathy. He was MT positive and cervical nodes were AFB positive on aspiration cytology. He was advised antituberculous drug. The patient lost to follow-up after 1 month. Till then, he was okay. After 1 year, a notice from the medical council with a complaint of negligence comes as the patient was later diagnosed with a lymphoma. What the doctor should do? Would you take it or would you want
As you wish, sir. As you wish.
Okay. Fair enough.
Okay. Okay. Now, patient is suffering from mediastinal cervical lymphadenopathy, and he was a Mantoux test positive. On the basis of cytology, ATD was given. The patient was, follow-up was only 1 month. The patient lost to follow-up after 1 month. Till he was okay. So in that cases, the follow-up is very important. Only 1 month follow-up is not sufficient enough. So doctor will examine him whether there is a improvement or not, size of the lymph node is decreasing or same thing. If necessary, some investigation will be given. So there is no follow-up. Certainly after 1 year, patient suffering from lymphoma. In our term, medical legal term, it is called as a novus actus interveniens, because he was suffering from tuberculosis and he was not follow-up. So in that cases, doctor is not negligent, because in the negligence cases, the ingredient of negligence is duty, dereliction, damage, death. So doctor is duty bound to treat the patient when he accepts the patient. If there is any deviation of duty, he will be dereliction of duty and he will be charged as a negligent act. And as a result of dereliction, there may be some damage of in death. So in that cases, follow-up was only for 1 month. And patient could not contact the doctor, So in that cases, doctor is not negligent.
Just as a clinician, I feel here the whole focus will be on that loss. If the patient is lost, I don't have any responsibility.
Exactly, exactly.
Sir,
The whole thing will be there on the loss.
Sir, again, we are very short of time, but we need to clarify a very fundamental principle here, and it is for those at least a few interested who are still, okay, yeah. You see, in India, as opposed to many other countries, there are no separate set of malpractice laws. So when we talk of these kind of complaints and litigations, we have to fall back on law of torts, law of evidence, law of contracts. And if there is anything in the NMC rules. What you're saying that everything rests on the follow-up, that the patient was lost to follow-up. A very smart lawyer for the complainant will put the blame on you, that you did not give me advice that I need to follow up. So the answer to these individual questions are very, very difficult to elaborate in these kind of sessions. What we need to know and what we need to understand from this, the take-home message for our regular practice is, you see, if you look at 100 litigations against doctors, you would find 80% of them, and we have studies on this, either emanate from the beginning, that is the consent, or the ending, that is the discharge summary or your advice. It's a very good practice to ensure that you follow an algorithm. In any kind of advice, do advise about diet and activity and about follow-up. And if you are not, if you do not want to, if you cannot specify, just write that follow-up as advised. But if the onus is of course on the patient to prove that you have not advised follow-up. But if you can produce a document, a copy of your prescription that I had advised follow-up as advised, then the case is automatically lost for the complainant.
That's what they say. I review after 4 weeks.
Exactly. That's the point. No, sir, not always. No. Very often we don't do it. Now, even if you think this patient does not need very close follow-up, at least make it a point to write review as advised or follow-up as advised.
Now, one thing is very important. Prescription to apni patient ke diye dichen. So that's why one very important thing is there, preservation of the record. So make a duplicate and preserve for at least 3 years. তাহলে প্রমাণ করবেন কি করে? হ্যাঁ, অবশ্যই।
Sir, this also should be clarified. As yet, it is not the case. The onus of producing the prescription is on the patient. But very soon, the onus will be on us. If you have gone through the draft regulations of the NMC, which will very soon be published in the Gazette, and once it gets published in the Gazette, it will become a law. The NMC has clarified that yes, you have to keep a copy, and they have made a target that by 5 years, all medical documentations will have to be digitized.
Sir, এটা 3 years ছিল, এখন 5 years হবে।
5 years করে
ড্রাফটে আছে।
Okay. Next, a patient was sick and poor. Yeah. Yeah, that's fine.
That is not his fault.
Since you have brought this up, this will be useful for answering many other questions. You see, as I said, there are no set of malpractice laws. So what is the basic concept of the Indian judiciary when dealing with medical malpractice? They employ what is called 2 tests. One is called the Bolam test, the other is called the Bolito test. Now in India, by Indian legal system, you have to prove that what you have done is at par with the ordinary skill of an ordinary similar other physician. The highest standard of skill is not required. So the court will only ask that was it justified medically to advise ATD only on the basis of M12 positive and AFB positive on aspiration cytology. If one expert or one set of experts says that yes, it is acceptable, even if another set of experts says that it is not acceptable, you still win the case. You win the Bolam test. The Bolito is a slightly different test, but the principle is that if one group of your peers say that what you have done is an accepted medical practice, then there is no negligence.
Sir, arekta test এসেছে Bolam, Bolito, Montgomery and modified Montgomery.
Yeah, we don't have the time. Okay, we move on. Yes. Yes.
Only empty positive could have been a greater thing. The form maybe later TB, but AD positive was there. Definitely.
টিউবারকুলোসিস স্যার, তবে স্যার একটা জিনিস আপনারা ভালো জানবেন, আমি ঠিক জানি না, ফিউ কেসেস বোধহয় টিউবারকুলোসিসের লিম্ফোমা থাকতেও পারে, মানে থাকে অনেক সময়। হ্যাঁ, এটা পরের ব্যাপার, এটি দিয়ে জাস্টিফাইড একদম স্যার।
Okay. A patient was sick and poor. The doctor prescribed anti-TB drug on basis of clinical and radiological suspicion. The patient improved. He was referred to RNTCP also, which is very important here. The patient improved but later developed diminished vision, probably from ethambutol toxicity. I think ethambutol is just a typo error. A big crowd came to the doctor seeking compensation. What to do? You want to answer it or do you want me to answer?
As you wish, sir.
Okay.
Please. Okay. Now, the patient was sick and poor. The doctor prescribed anti-TB on the basis of clinical and radiological suspicion. That is very important. The patient was improved and he was referred to RNTCP. So, doctor has referred the patient to RNTCP. Now, RNTCP, actually suspicion was there. They will do sputum and CVNAT test. And after that, they will diagnose. And whole control is on the basis of RNTCP. Because now RNTCP is dotted ব্যাপারটা থাকছে। তাহলে চলে গেল কিন্তু RNTCPর কাছে। ডাক্তার কিন্তু তাকে রেফার করে দিয়েছে। এবারে বলছি the patient was improved but later developed diminished vision probably from the ethambutol toxicity. এটা RNTCP থেকেই কিন্তু হচ্ছে। আইডিয়ালি আমরা জানি না RNTCP-তে কোনো আই স্পেশালিস্টকে সে কনসাল্ট করেছে কিনা বা তাকে বলা হয়েছিল কিনা যে ডিমিনিউশন অফ ভিশন যদি হয় তুমি রিপোর্ট করবে। এইগুলো তো আমরা এই জায়গাতে নেই। কিন্তু ডাক্তার রিলেশন যদি বলি তাহলে কিন্তু সে RNTCP-কে যখন রেফার করেছে তাহলে এই বিগ ক্রাউড কেম টু ডক্টর টেকিং কম্পেনসেশন। এখানে ডাক্তারের কোনো লাইবিলিটিস থাকছে না, ডাক্তার বোঝাবে ক্রাউডকে তার নিজস্ব স্কিল দিয়ে যে আমার কোনো দোষ নেই। স্যার
Here, very important to note, the person has not put a question that what would the court do. The question is what will you tell the crowd, or how will you handle the crowd? Now, if you had listened to the excellent presentation made by Dr. Khara, building up, that was just before Dr. Ghoshal's, he said something very important, that the aim is to be socially, move up as a social figure rather than as a good doctor. So the first thing to do is don't be hostile to that crowd, and don't be detached from the issue. That is not going to solve the problem. You should proactively say that he was my patient, therefore of course I would look after him, but first we need to see what is the cause of the diminished vision. You should proactively arrange for an ophthalmology consultation. You should proactively write a letter to the RNTCP and tell them that please go and talk to them and come back and report to me. Today, these are days of technology. And this is my humble request to every junior or middle grade trainee here. You see, one of the commonest recurring themes that we see in our medical legal cases and litigations is the doctor did not tell us, or there was no communication. Something that I follow very routinely. I'm far removed from your branch. I'm a surgeon. I use a lot of messages and emails. If I've diagnosed a complication in a patient and the patient's relatives are not there, I would send an email or a text message to them that please contact me, because in the unfortunate event of a litigation, emails, even WhatsApp messages and SMSs, these are admissible evidence in court. So nobody would be able to say that you have not communicated with the patient. So it's the same thing here. You have to create that bond with the. You don't try to be hostile to the crowd. Yeah, why should I compensate? It was not my fault. No, don't start with that. Start with the fact that this is very surprising and I'm very upset about it. But first, let us find out what has happened. This may not be due to a drug. So you proactively arrange an ophthalmology consultation. Proactively write to the RNTCP. Subsequently, when the crowd comes back, the crowd will start thinning out. And when the crowd thins out, then at one point of time you say that yes, if a compensation has to be paid, then it has to be decided by a proper body. I have not done anything wrong, so I will not pay any compensation. Okay.
Yes. So the immediate part is crowd management.
Yes.
Okay. And that the doctor has to be very good in patient communication, particularly crowd communication. That's a separate thing. Crowd is usually very hostile.
Yes.
Sometimes even they do not listen, they argue.
Yes.
That's a separate thing. But what I mean, at least to the juniors and online also, the year of the prescription is very important, because it depends on what guideline was at home.
Absolutely, sir.
Absolutely.
Absolutely.
So it is 1915. So what was the TB guideline at that present? Was it a notifiable disease? TB is a notifiable.
He has to prove that he treat the patient as per guideline.
So from 2001 to TB is a notifiable disease. So he has to refer it to. Now it is called ATP. Number two,
whether it was justified and it will be done on basis of clinical and
Yes, absolutely. Yes.
And refer the case
So
to RNTC.
that is what the court will do. If this case goes to the court or a consumer forum, they will ask a group of experts that was the doctor justified in starting ATD on basis of this?
Sir, two things is there. Exactly.
Yeah, in this case the onus is entirely
এখানে এটাই বলতে চাইছি যে
this case is onus is
actually
on that.
two part. One is যে ডাক্তার whether he is responsible or not. Another part is court. তাহলে কোর্টকে প্রমাণ করতে গেলে it is very important to show the documents. Yes, that is the very important. এবং documents is very important in that cases, either in the form of email or WhatsApp or paper, whatever it may be.
Okay, next question please. A private hospital reduces to the doctor's, well, a private hospital reduces the doctor's fees, stating inability of the patient reportedly without compromising anything on the hospital bill. How a doctor should act for similar non-payment? You want me to take it or? Okay, I'll take it. Okay. Okay. In practice, probably you wouldn't really do anything, you will gulp it down. But yes, if you want to do anything, you can. To some extent, it will depend on which state or which part of India you are in. Every state, because one part of health, hospital, dispensary, these belong to state list. As opposed to professions, the medical profession belongs to concurrent list in the Constitution of India. Health, the actual nitty-gritty of health belongs to state list. So every state has got a clinical establishment regulatory authority. In West Bengal, it is now a huge board creating right and left nuisance every day. Those who are residents of West Bengal, they know about it. Legally, the bottom line is who can actually approach the clinical establishment regulatory board? Anybody who is aggrieved by a clinical institution. So you can actually approach the clinical establishment regulatory board that I have been wronged. Two, the second alternative is you can sue the hospital. This is fraud. This is plain fraud, 420 IPC. So you can file a civil suit and then, fight it out in the court. Apart from that, there is nothing else you can do.
Another thing is that, sir has told, so it is nothing but the professional fee is the right of the doctor. He can claim. And last resort is he can leave the job. He can leave the job because two things, sir, whether he's a salaried person or consultant. Yes, yes.
He can go to the commission and he can sue.
He can sue the case in the civil court.
He can sue because on the basis of constitutional rights. Basis of constitutional rights, and this is fraud. Sir, I'll just go back to 2 lectures before our session. It was Professor Randeep Guleria who was talking about teaching, and in one of his slides, those of you who were here, he had mentioned what is the difference between a good doctor and a great doctor. A good doctor treats diseases and a great doctor treats the patient. Do you know what's the difference between a good lawyer and a great lawyer? A good lawyer knows the law. A great lawyer knows the judge. So if you sue the institution on this particular case, and if you can go to a great lawyer, this institution will be in very big trouble.
Yes.
Okay.
Because it is the right of the doctor.
Now, sir, a lawyer a bigger kichu nahi, it is good and great. Okay. Death certificate. Oh, sorry. Nowadays, after a litigation, everyone writes USG guided fluorocentesis. If someone does the procedure without USG, with all precautions, what all precautions will he take? Can this be done for a poor patient without USG guidance? Before USG, clinical test was enough with chest X-ray PA, and thousands of patients are successful fluorocentesis. That this is the question. There are some typographical errors. You want to take it or you want me to answer it?
Up.
Okay. So again, back to square one. The court is not interested. The court doesn't even know what fluorocentesis means. The consumer forum doesn't even know where the pleura exists. And very important, the court or the consumer forum, they are not interested to know whether the patient was rich or poor. The law is same for everyone. The only thing that they will be interested in is what would a reasonably similar or ordinary expert in that field say or do. That means by default it will go to the guidelines. If you can show that there are guidelines which suggest you can do a fluorosynthesis without ultrasound, particularly where you don't have it, where it is something urgent, it is life-saving, you are free, nothing will happen to you. But if the complainant can show a guideline, a compelling guideline, that an USG is essential for a fluorosynthesis, then you are in trouble. That's the fundamental bottom line. Now, here the question is, what all precautions would he take? The only precaution is not really a precaution, but a good medical practice. Be candid with the patient and the family. This equipment or this particular additional method is used nowadays. We don't have it. It not only it costs more money, but the thing is, this is something urgent. We have to do it right now. Thousands of cases were done before. If you can build that rapport up, and ideally if you can record it in your document, I don't think anything will happen if you do a fluorosynthesis without USG. Like for central lines. For central lines, internationally, it is still not a mandatory guideline to do the puncture under ultrasound guidance, except for dialysis catheters.
Dialysis. So one thing I am adding one thing that yes, family and the patient should be informed about this, and we will give one option also. If you want to do without USG, this is the problem. If they understand, then they will come. And before that, informed consent is very important in that cases, explaining everything. Yes, 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 yes.
In this particular case, the documentation means because it is an invasive procedure, it needs a consent. So that consent itself must document that we are doing it without USG guidance.
Without USG guidance, I have given that. Yes, yes. And these are the complications. Informed consent means that consent is nothing but the agreement or compliance, giving freely, voluntarily, without any fear or favor. So that is very important.
Yes.
Documentation is very important in that cases.
Either way, just adding one word that patient has been explained that this will not be done with USD guidance.
Yes.
Yes, that's enough.
Yes.
Since we are talking of consent, just a few additional seconds. The NMC has made two very important changes to the consent. Are you aware of it? The trainees here? If a patient is less than 18 years, then thus far, we always take signatures only from the guardians or the parents. As per the new rules, 8 years. Even if the patient is 8 years above, 8 to 18, you should get the signature of the guardian or the parent. You should also try and get a signature of the patient above 8 years.
NMC guidelines
okay. এটা মামলা হয়েছে কবে আলটিমেট বেরোবে বাট ইউ নিড টু নো
এখানে একটা ইম্পর্টেন্ট টপিক আছে
একটা সেকেন্ডটা আপনাদের ক্ষেত্রে স্যার অতটা অ্যাপ্লিকেবল না বাট আমাদের পক্ষে খুব ডিফিকাল্ট হয়ে গেছে ইন সার্জারি you have to specify the name of the surgeon. This is because there were a lot of complaints of ghost surgeries. Do you know what a ghost surgery is?
এটা স্যার সব জায়গায় এখন আসছে
So
আমাদের কাছে ওর নাম ফোন নাম্বার দিয়ে দিতে হচ্ছে
you have to mention specifically the name of the surgeon.
Sir, one thing আমি একটা জিনিস বলছি রিসেন্টলি মিনিস্ট্রি অফ হেলথ অ্যান্ড ফ্যামিলি ওয়েলফেয়ার গাইডলাইন যেটা বার করেছে আফটার দ্য অ্যামেন্ডমেন্ট অফ দ্য 2000 ক্রিমিনাল ল আন্ডার জাস্টিস ভার্মার ওপরে, সেখানে ভিকটিমটার বদলে সার্ভাইভার বলা হয়েছে সেক্সুয়াল অ্যাসাল্টের ক্ষেত্রে। সেখানে কিন্তু এজ অফ কনসেন্ট বলা হয়েছে 12। আমরা এখনো ধরে নিই, যদি আমরা পক্সো অ্যাক্ট ধরি, প্রিভেনশন অফ চিলড্রেন ফ্রম সেক্সুয়াল অ্যাসাল্ট, তাহলে সেখানে কিন্তু বলা আছে এ গার্ল ইজ সেড টু বি এ মাইনর ইফ সি ইজ বিলো 18 ইয়ার্স অফ এজ। সেক্ষেত্রে মাইনর যদি হয় 18 এর নিচে, লিগাল গার্জেনকে কনসেন্ট দিতে হয়। সুতরাং ওই ড্রাফটে 8 আছে না 12 আছে আমি ঠিক খেয়াল করতে
না,
পারছি না।
8, ওটা আমি 100% শিওর 8, because
ওটা বোধহয় অ্যামেন্ডমেন্ট হবে স্যার।
আচ্ছা, next we proceed. Death certificate. The patient was under treatment of a local doctor. Now she was attending now she was attending SS camp for 6 months until her death yesterday. The party is demanding death certificate from the local doctor. Should he give it? Very contentious issue. I think you should also comment. I would also comment. But না, আমরা এক্সপার্ট নই স্যার, যাই হোক।
Now she was attending SSK for 6 months. So I have not seen her for 6 months. SSK will say, if you have party is demanding receipt from local doctor, I'm not bound to give it in my own.
এটা হচ্ছে নর্মালি। এবারে আপনাকে যদি আমি জিজ্ঞেস করি স্যার, যে পেশেন্টটাকে কি আমি বলেছিলাম যে 6 মান্থস যখন পিজিতে যাচ্ছে রেফার করেছিল, কাগজপত্রগুলো আমার সাথে মিট করবে, দেখাবে? যদি সে জেনে থাকে, সাপোজ ইফ দ্য পেশেন্ট অ্যাটেন্ডিং এসএসকেএম and also inform the doctor regular basis, what will happen?
Okay, so I think we should know what the law is, all right? Now, many doctors have an understanding that to be able to issue a death certificate, you must have seen the patient within the last 72 hours, or at least in the last 24 hours in the case of hospitalized patients. Now, please be clarified about this. This is not the law. This was a judgment on a particular case where a homeopath had administered a death certificate. In India, Ayush doctors can write death certificates as per the law, so homeopaths can also write death certificates. So what is the law? Now, this particular act, Registration of Birth and Death Act 1969, enumerates this in good details. A physician, a medical practitioner, a registered medical practitioner can issue a death certificate in what is called a Form 4x4A if either of two criteria: has seen the patient in the last illness which has led to the death, or is fully aware about the patient's clinical conditions which has led to the death, which are not exactly synonymous. You have not seen the patient in the last 6 months, you do not know what was the cause of death, but you may be aware, depending on what was your rapport with the patient or the patient's family. There is no such thing called the time limit. You are absolutely fine to give a death certificate. Fundamentally, it is your judgment whether it is safe to do so.
Yes. সেই জন্য স্যার আপনাকে বললাম, পেশেন্ট যদি র্যাপোর্ট রাখে।
হ্যাঁ,
আমি এরকম ভীষণ গরিব মানুষ, ডেথ সার্টিফিকেট দেওয়ার ডাটা পাবো, আমি অপারেশন করে আমি ডেথ সার্টিফিকেট লিখছি, আমি খালি অ্যাসিওর হলাম যে কোনো ফাউল প্লে নেই।
আপনি যদি শিওর থাকেন,
ফাউল প্লে কি করে অ্যাসিওর হলেন স্যার? যে
জানি আমি ওই লোকটাকে চিনি বা খুব অসুস্থ ছিল, পিজিতে দেখাচ্ছিল, মারা গেছে আমি কালকে রাত্রে, এবার আমি না কিছু করার নেই, যা করি আমি, আচ্ছা ঠিক আছে, কেউ নেই তোমার, আচ্ছা তোমার ডেথ সার্টিফিকেট।
So you are a registered medical practitioner, so first criteria met. Did you see the patient in the last illness? Time tana, you haven't seen. But criteria number 3, were you aware of the patient or the patient's illness? You are, so you are fine to give the death certificate.
ওখানে দুটো জিনিস স্যার উচ্চারণ করলেন, একটা বললেন ফর্ম 4 আর 4A,
হ্যাঁ,
এটাকে অ্যাকর্ডিং টু বার্থ অ্যান্ড ডেথ রেজিস্ট্রেশন অ্যাক্ট 1969 সেটাকে অ্যামেন্ড করে নতুন কিছু অ্যামেন্ডমেন্ট এসছে, এটাকে বলা হয় এমসিসিডি, অর্থাৎ মেডিকেল সার্টিফিকেশন অফ কজ অফ ডেথ। এখন যে হাসপাতালে যে ডেথ সার্টিফিকেটগুলো ন্যাচারাল ডিজিজে দেওয়া হয় তাতে 3টে পার্ট আছে। ফার্স্ট কলমে এতে ইমিডিয়েট কজ, অ্যান্টিসিডেন্ট কজ, আন্ডারলাইন কজ। সুতরাং 4টা হচ্ছে ইনস্টিটিউশনাল, অর্থাৎ গভর্নমেন্ট হসপিটালে যদি থাকে, আর 4 এটা হচ্ছে নন ইনস্টিটিউশনাল। আর বাদবাকিগুলো স্যার তো বলি।
If you have any doubts, because the patient was going to a government hospital for the last 6 months, the head of the institution can issue death certificate, put a form number 4. So if you have any doubt, you should request them that no, I cannot issue death certificate, go back to SSK. In case you ever issue a death certificate under duress, you can issue it. Please walk into the next, within the next 24 hours, walk into the nearest police station
and inform.
And inform. Achha, a young guy who's a government employee is not your patient at all, though his father is. The guy went to a pleasure trip and after returning he's requesting for a sick certificate. How will the doctor deal with the situation? Answer is capital N, capital O.
একদম একটাই অ্যান্সার,
Don't give.
ছেলেকে লোকটা মার্ডার করে এসছে, এবার এসে ওর কাছে বলেছে আমাকে সিক্স সার্টিফিকেট দিন, ডাক্তার সিক্স সার্টিফিকেট দিয়ে দিয়েছি। সিক্স সার্টিফিকেট দেওয়ার পর জানতে পেরেছে যে ওর ছেলেকেই মার্ডার করেছে, ওর পুরো গল্প আছে। সো দ্য অ্যান্সার ইজ বিগ নো।
স্যার বিগ নো বলে দিয়েছে, একদম। সেটা তো আলাদা।
সে আবার পার্টি করে কিনা লোকজন দেখে আনবে কিনা সেগুলো তো অন্য ব্যাপার।
হ্যাঁ, বাট এটা দেওয়া সম্ভব না। The best way of dealing with it, even if they call a crowd, is to try and explain to them যে দেখুন এটা আপনিও বিপদে পড়বেন, আমিও বিপদে পড়বো।
মানে সোজা কথা স্যার, প্রথম কথা হচ্ছে এই ডেথ সার্টিফিকেটের ব্যাপারটা এত ডাইসি, বাড়ির আত্মীয় যদি একটা যদি কমপ্লেন করে দেয় তখন তো ডক্টর উইল বি ইন প্রবলেম। আমাদের কাছে অনেক কেস এসছে, হাফ বার্ন করে চলে এসছে, ন্যাচারাল ডিজিজ বলে মাটির নিচে পুঁতে দিয়েছে, এক্সহুমেশন হয়েছে, এসছে, ইট ইজ এ কেস অফ মার্ডার। সুতরাং বিফোর ইস্যুইং ডেথ সার্টিফিকেট, যেটা বললেন স্যার, ইফ ইউ আর শিওর রিগার্ডিং কজ অফ ডেথ, ইফ ইউ আর শিওর অ্যাবাউট, অথবা পেশেন্টের সম্বন্ধে জানেন তাহলেই দেবেন, তা না
করেনি।
ওটাও জাস্টিফাইড, ওটার কোনো ল নেই, কিন্তু
ওটা স্যার
জাজমেন্টের প্রেসিডেন্স আছে।
ওটা স্যার 4 ঘন্টা বলা হয়, কিন্তু একটা কনসেপ্ট এসছিল 1995 একটা রেকমেন্ডেশন আছে, সেই রেকমেন্ডেশনটা এখনো ইমপ্লিমেন্ট হয়নি। সেটা হচ্ছে যে ব্রেন ডেথ কেস যদি হয় ডিক্লেয়ার করে দেয়, তো তখন একটা প্রপোজাল ছিল যে 1 ঘন্টার ভেতর দেওয়া যায় কিনা, কিন্তু সেটা প্রপোজাল হিসেবে ছিল, মানে অর্ডার হয়নি। এখন 4 ঘন্টা আপনাকে ওয়েট করেই দিতে হবে।
এই 4 ঘন্টার কোনো মানে
কনভেনশন
পাবলিশ, মানে গ্যাজেট পাবলিশ কোনো ল নেই, কিন্তু দি অ্যাবসেন্স অফ অ্যান এক্সিস্টিং ল, a judgment of an apex court has the same force of a law.
আরেকটা স্যার, আরেকটা কারণ ক্লিনিক্যালি সাসপেন্ডেড অ্যানিমেশন।
এক্স্যাক্টলি, ওই সাসপেন্ডেড অ্যানিমেশন আমাদেরই ওয়েস্ট বেঙ্গলের প্রফেসর জেবি মুখার্জির একটা ডিপোজিশন ছিল সুপ্রিম কোর্টে, তার বেসিসেই 4 ঘন্টাটা এসছে।
আরেকটা হচ্ছে রাইগার মোটিস ডেভেলপ করে যায়, একটা বডিতে রাইগার মোটিস ডেভেলপ করলে তখন তার বেঁচে নেই।
Question we can conclude after that.
কোনটা? কোথার ক্ষেত্রে? নো নো নো, ওই তো আমি আগেই বললাম। নো নো নো, ইয়েস।
It can be.
It can be.
But legally, you are protected that you have given a gift, because to the best of my knowledge and in good faith. The question is, if you are not a registered medical practitioner, If you have not seen the patient in the last
So you are not
or
bound
if
to
you do
issue.
not know about the patient, তাহলে you will be indicated.
এবং সেক্ষেত্রে 1 মাসের ক্ষেত্রে নতুন একটা নিয়ম আছে, যদিও বিদেশে নিয়মটা পাল্টেছে। আমরা বলা হয় লাস্ট 14 ডেজ যদি দেখে থাকি, আর একটা নতুন এসছে লাস্ট 7 ডেজ, সেটা এখনো এতে আছে বিদেশে।
There was one more question which is not showing here. After a day-long hectic chamber, you are sleeping with, and a nearby patient with shortness of breath has arrived your home for consultation. How to tackle the situation? Okay, again, and a nearby patient with.
আচ্ছা, এখানে দুটো প্রশ্ন আছে স্যার, বলবো? শর্টনেস অফ ব্রেথ মানে কতটা? যদি এমার্জেন্সি হয়, ইফ ইট ইজ এ কেস অফ এমার্জেন্সি, ইউ আর বাউন্ড টু এক্সামিন দ্য পেশেন্ট। এবং আমি বলছি স্যার, বলছি আপনাকে, বলা আছে, অন্তত আমাদের যতটা নলেজ আছে আমরা জানি, যদি আপনি রাস্তা দিয়ে, যদি আপনি কোনো ডাক্তার হন, আপনার রাইট টু চুজ এ পেশেন্ট আছে, অধিকার আছে, কিন্তু এক্সেপ্ট ইন কেস অফ এমার্জেন্সি অ্যান্ড রোড ট্রাফিক অ্যাক্সিডেন্ট, এই দুটো ক্ষেত্রে বলা আছে। সেই জন্যই বললাম কথাটা। সে থাকতে পারে, আমি টেক্সট বুকের কথা বললাম।
I'm telling you what is the law of the land. If you are not working, you are not bound to attend to a patient.
এটা আমার একটু দ্বিমত আছে, এটা আমার দ্বিমত আছে।
Is there a law that you have to attend to this patient? No. I tell you what. I tell you what. Even when about 7-8 years ago, if you ever went to buy a rail ticket, there was a separate tick box you tick if you are a medical practitioner. Why? Because in a long distance train, if there is anybody who suddenly falls ill, you know, the guard of the TT, they have the liaison, they would know which doctors will be traveling in the train. Indian Railways is a pretty movie. If you are traveling on a train, say for a holiday or going for a conference, you are not bound to attend to a patient. Even if you are told but yes, now when the question of morality or ethics comes, of course you go.
না বললে বিপদ আছে, আমি ফ্লাইট একবার করে তারপর যার হয়েছিল তার তো কিছু হলো না, সে বাড়ি চলে গেল, সবাই বাড়ি চলে।
না স্যার, এই জায়গাটাতে একটু মানে, হ্যাঁ, না লিগাল প্রোটেকশন কি? আপনি তো বড় বড় ওষুধ তো দিচ্ছেন না, আপনারই পেশেন্ট আপনাকে কমপ্লেন করছে, সে আসতে পারছে না, হোয়াট টেলিফোন ডাইরেকশন ইজ দেওয়া উচিত না। হ্যাঁ, বারণ করা আছে, কিন্তু যেহেতু আপনার রেকর্ড আছে আর আপনি সিম্পল ছোটোর ওষুধের উপরে যদি দেন, সেটা আপনি অন গুড ফেথ দিতেই পারেন, কিন্তু ওই যে টেলিফোনের ডাইরেকশনটা কিন্তু আজকাল বলে উচিত নয় দেওয়া।
আমরা কি করবো শর্টনেস অফ ব্রেথে? এমআই ছেলে হলে বড় একটা 80 মিলিগ্রাম স্ট্যাটিক নম্বর
না, দুটো বলা আছে, একটা বলা আছে যে in case of emergency, একটা right হবে doctor to choose the patient, তার আছে। আবার পেশেন্টেরও রাইট আছে to choose a doctor, except in case of mass disaster, road traffic accident এবং emergency। আপনি তাকে দেখে অ্যাডভাইস করে রেফার করেন না, কিন্তু আপনাকে দেখতে হবে। আমি আমার দেখা যাচ্ছে ভুল হতে পারে, আমি মিস করতে পারি, কিন্তু আপনাকে অ্যাটেক করতে হবে। এইটা যে আপনি এইটা যেটা বলছেন, এটা ইন্টারপ্রিটেশন নয় স্যার। জানি না স্যার, আমি এটা লিগালি বাউন্ড না। আমি আগে পাঠিয়ে দিচ্ছি, আমার কাছে একজন করে না, নট বাউন্ড টু স্টপ স্যার। আমাদের তো লিগাল বই থাকে না, আমাদের যে টেক্সটবুক আছে অন্তত আমরা বলতে পারি সেইটাই ঠিক আছে। না পার্টিকুলারলি এটা কি লেখা আছে স্যার? এই কথাটা লেখা আছে। হ্যাঁ, বাট সেটা কোথায়? when you are at work, you cannot when you are at work. No sir, আজকে আপনি বাড়ি ফিরছেন গাড়িতে, বাইপাসে একটা অ্যাক্সিডেন্ট হয়েছে। This is all the symptom only. What is it? Trial of the nothing to do. না না, আপনি কি বলছেন? This is very unpredictable. At work, what I'm trying to say is that morality and law because two are depends on what is written in the bond. Mortgage data coming closely data recently study putting over the bodies. Our colleague, very brilliant and a big name in Canada. Our fellow brilliant has completed every graduation from CMC fellow and into the bond. He has got into DM. He has said in writing to CMC fellow the dean that I will do this bond, but after completing the DM. Into okay, transfer certificate we care. I complete the bond, but let me do the DM first.